Very good welcome to you. We are about to start our portfolio committee meeting. And this meeting is specifically called because we are continuing with our public hearings on the NHI bill. Before we proceed, can I just hear from our committee secretary, Ms. Majalamba, who are all in attendance, from the members of parliament, and also if we have any apologies.
Good morning and thank you, Chair. Present is Dr. Jacobs, Mr. Munyai, Mr. Sokacha, Dr. Harvard, Ms. Wilson, Ms. Ishmael, Ms. Chirwa. I've received apologies from Dr. Tembe Kwayo, Mamu Hlengwa, Mr. Van Staden, and Ms. Sugers. Thank you, Chair.
Thank you very much. I also want to bring to the attention of the members this morning that this is live on Parliament TV, YouTube, Twitter, Facebook. It will also be published on IONO. And I am requesting all members and also our guests to please switch on their cameras when they speak, so that we can make certain that whoever is watching this program will be able to identify the people who are behind the voices. So we are about to start, and I just need to remind the members and all of those who have logged into this meeting that this meeting is a virtual meeting of the committee of the Portfolio Committee on Health. I would like to remind you also that this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute the microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons on the bar at the bottom of their screens, which has an option that allows a member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjections. I see a request from Honorable Munyai that our guest should rename, is saying, can our guest fully rename their computers or phone with full surname? So whoever that is applicable to, would you please do that so that we are also aware of who has logged onto our committee meeting. So honorable members, this is our second meeting for the year and we welcome Mediclinic. I see the CEO of Mediclinic is present, Put Pretorius. You're very welcome with your entire team and we look forward to hearing from you whatever your presentation would be to us this morning. I would want to then just welcome Mediclinic Southern Africa. I see they are named and go straight over to you, Mr. Pretorius, for you to do your presentation and to introduce your team. Thank you very much.
Good morning once again, Honourable Chairperson, and good morning also to all the honourable members of the Portfolio Committee. Honourable Chair, before I introduce our panel, I would like to use the opportunity to sincerely thank you for inviting us to participate in these deliberations today. We feel very privileged to be part of this NHI process, and it's our clear intention to make a positive and constructive contribution today. My name is Kurt Pretorius, and I'm the CEO of Midi Southern Africa, and I'm joined today by Advocate Carisha Pillay, who's a senior counsel in the Cape Bar. We also have present today in our team Advocate Michelle Norton, senior counsel in the Cape Bar as well. And then the fourth member of our team is Rowley Buys. Rowley worked for Midi Southern Africa for more than 20 years. He was our Chief Strategy Officer when he retired. He is still currently working as a healthcare consultant. He's a specialist in health policy. Rowley has been involved in the NHI process for many years, and he was a member of the Ministerial Advisory Committee who developed the initial green and white papers for NHI. Honourable Chair, I also want to point out that we provided a slide presentation to facilitate our presentation today, and we also provided the honourable members with notes that accompany our slide presentation. The notes are exactly the same as what we have on the slide presentation, although it is in a Word format, and on some of the points we elaborate slightly on the notes, but the notes and the slides should be read together. Before we start with the presentation, I also want to discuss the approach that we are going to follow. Obviously, Honourable Chair, you and the honourable members have been dealing with so many written submissions and so many public presentations during the last couple of months that we decided to follow a very focused approach and a slightly different approach to make sure that we assist the committee as best as possible. So we will look at the current NHI bill through a constitutional lens. We all understand the process, and we know that the policy debates have already been concluded, and we all had the opportunity to comment on the green papers and the white papers, and we are into the parliamentary process now. And for the Health Portfolio Committee, it's extremely important to be able to finalize the NHI bill. And our approach today is to support this committee in its final deliberations to finalize the NHI bill. We will focus on the most critical aspects of our submission. We also use the opportunity to provide a full written submission when we had that opportunity earlier on. Obviously, we can't deal with everything comprehensively today. And then, very important, Honourable Chair, I want to make it very clear that Midi Southern Africa supports universal health coverage, and the private sector, unfortunately, is often labelled as against NHI or against universal health coverage. I want to state unequivocally that we support universal health coverage, and we support the purpose of the Act as set out in Section 2. Having said that, we have some key concerns about the current bill, not about the policy, but the current bill. But we think it will be possible to correct those issues that are of concern, and we will discuss it with you today. So in terms of our agenda, we'll start with an executive summary, then an introduction to Mediclinic, then Mediclinic's position on universal health coverage. We will then delve into some of the detail around the concerns with the bill. We will end with a summary of the key concerns and proposals to address the concerns, whereafter we will close with some concluding remarks. So I'm going to move on to the executive summary then. This slide actually captures our full presentation and will make it easy for members to understand our position and our concerns. Firstly, there are some very important proposals contained in the bill that we think are very innovative, and we are fully supportive of these proposals. Firstly, there's the strategic purchasing concept. Secondly, there's a purchaser-provider split like we already have in the private sector in South Africa, which is very encouraging. And we also support the primary healthcare centered package, especially during the initial phase. We have three main constitutional concerns that we would like to discuss. Firstly, we think there could be a breach of the right of access to healthcare services. Secondly, there is a lack of reasonable certainty on the nature and scope of the NHI scheme as contained in the draft bill. Thirdly, non-compliance with the standards governing public procurement is a further concern to us. We think there are key threats to access. Firstly, inadequate resources for effective implementation. As we all know, a big challenge in South Africa at the moment. Secondly, we are concerned about the role and viability of private sector hospital providers. And thirdly, we have a concern around the possible erosion of medical scheme cover due to the limited role of medical schemes. We are confident that these concerns and shortcomings can be addressed very successfully, and we propose a number of measures to address these concerns. Firstly, we believe that we should set measurable milestones to stagger implementation based on benefit costing, financial and human resource estimates and availability of these resources. Secondly, expand the role of the private hospital sector. We want to be part of the solution and part of the national healthcare system in South Africa to provide services to the people of South Africa. We think the limitations on medical scheme cover should be removed. Amend relevant sections to ensure reasonable certainty for users, providers, and medical schemes. A key concern is the current level of uncertainty. Establish a fair and transparent methodology for reviewing the scope of services covered by the NHI scheme. Provide for a fair, equitable, transparent, competitive, and cost-effective procurement model, which is a very important component of the proposed model, and then establish an independent body to determine appropriate reimbursement models and scientifically calculated tariffs. On the next slide, we will move to the introduction to Mediclinic. Very briefly, Mediclinic International. Mediclinic Southern Africa is the South African and Namibian division of Mediclinic International, a diversified international private healthcare services group. You can see we've got operations in South Africa, Namibia, in the Middle East, in Dubai and Abu Dhabi, also in Switzerland, and we have a minority stake in the Spire Group in the United Kingdom, which also has a national health system. We are focused on providing specialist-oriented, multidisciplinary services across the continuum of care. We are not only into hospital care, but also other components of the continuum of care. We have experience in operating within a range of healthcare systems with varying economic and regulatory dynamics. Our purpose, our core purpose, the reason for our being, the reason why our staff get out of bed every day is to enhance the quality of life. Very important to us. And then our vision is to be the partner of choice that people trust for all their healthcare needs. Just a snapshot of our Southern Africa operational overview. We have 50 acute hospitals, 13 day clinics, 5 subacute hospitals, and 2 mental health facilities. We have more than 8,600 beds, more than 300 theaters. We are supported by more than 2,800 independent admitting doctors, and we employ 15,000 permanent employees. And at the bottom, you can see some of the brands that are part of our continuum of care service offering. The next slide covers Mediclinic's position on universal health coverage. I already touched on this during my opening comments, but just to reiterate, Honorable Chair and members of the Health Portfolio Committee, universal access to quality health care for all South Africans is an imperative to which Mediclinic is fully committed. I want to repeat, to which Mediclinic is fully committed. There is no single way. According to the World Health Organization, all countries must make choices and trade-offs, and we want to be part of developing the final NHI model for South Africa. How universal health coverage is achieved should be informed by the South African context, and the NHI bill already lays down some of the essential components of universal health coverage. I already highlighted the importance of strategic purchasing principles, also the importance of a purchaser-provider split, and then very important, a primary healthcare center package, which is absolutely important in the South African context. We also think it's very important to elaborate on some of the lessons we learned during the COVID-19 pandemic. We can apply some of these principles when we jointly tackle the big challenge of providing access to quality healthcare to the people of South Africa. During the COVID pandemic, this pandemic enabled various public and private sector stakeholders across various industries to collaborate. The private hospital sector participated in all the Business for South Africa work streams together with other players in the private hospital industry. Public and private sectors engaged in developing agreements around processes and fees for the admission of public sector COVID-19 patients at private facilities. And if we can do it during a pandemic, we can also do it during normal circumstances. Collaboration in the rollout of COVID-19 vaccinations created opportunities for public sector users to receive vaccinations at private sector sites, and the opposite happened as well. Many private patients who have medical scheme insurance use the opportunity to get excellent service from public sector vaccination sites. We would therefore welcome further engagement with public sector stakeholders to develop the components of a sustainable healthcare system that will be required under NHI. Honorable Chairperson, Advocate Carisha Pillay will now address some of the concerns that we have with the current version of the NHI bill.
Thank you, Kurt. Good morning, Chairperson. Good morning, honourable members of this committee. If I could perhaps start with the constitutional standards which this bill is subjected to. And what we intend doing in the remainder of our presentation is to identify and set out aspects of the bill which we believe bear on its constitutionality. As a point of departure, this committee must be satisfied that the bill can achieve its objectives in a manner which complies with the Constitution. The risk is, if it does not, then any legislation that may be ultimately adopted or specific provisions in that legislation may well be set aside by the Constitutional Court. And in our view, the bill potentially gives rise to three main grounds on which it may infringe the Constitution. The first of these is that it may breach the constitutional right of access to healthcare services. That's the underpinnings informing this bill, as we see from the preamble of the bill. Secondly, it's that the bill does not indicate with reasonable certainty what the nature and the scope of the NHI scheme will be. And the third is that the provisions for the NHI to procure healthcare services do not comply with the procurement standards as set out in section 217 of the Constitution. If I can then move to the first of our grounds of concern, and that, Chairperson, honourable members, concerns access to healthcare services. Section 27 of the Constitution protects everyone's right to have access to healthcare services. Now, this right imposes two levels of obligations on the part of the state. The first is a positive obligation to protect and progressively realize this right within the state's available resources. And the second is a negative obligation not to take steps which are retrogressive. And if the bill cannot achieve its objectives, the state would ultimately be failing in its positive obligations. So too, if the bill results in reduced access to healthcare services, the state would be failing in its negative obligation. The NHI White Paper has already acknowledged that the NHI is a substantial policy shift that will necessitate massive reorganization of the current healthcare system. And so, the risks posed by such a far-reaching upheaval are enormous. Chairperson, honourable members, against that background, I will now hand over to Michelle Norton, who will deal with the threats to access to healthcare services.
Good morning, Chair and honourable members. In this slide, we've identified three key threats to access to healthcare services. The first is that there are inadequate resources for the effective implementation of the NHI scheme. The second is that the bill offers virtually no role to private sector hospital providers. And the third is that the bill erodes existing medical scheme cover. In the next slide, the first threat we deal with is the threat of inadequate resources for effective implementation. There are legitimate concerns, Chair, regarding the availability of the financial and human resources which are required to implement the NHI scheme effectively. We know that South Africa's healthcare system is currently faced with a range of challenges and constraints. We have a weak economic outlook, high levels of poverty and unemployment, and a narrow tax base underpinning the multiple social spending requirements. In 2017, the Davis Tax Committee report observed that the proposed NHI in its current format is unlikely to be sustainable unless there is sustained economic growth. And as we sit here today, we know that that has not happened. We have a critical shortage of human resources for health and a complex underlying disease burden in South Africa. South Africa's doctor to population and nurse to population ratios are low compared to peer countries. specialist to population ratios are currently 10% of the average calculated by the Organization for Economic and Cooperation and Development, the OECD. And extreme deficits exist in the projected number of specialists by 2040 when we account for the disease burden in South Africa. We have an overburdened public health system, which was found by the Health Market Inquiry not to provide a reasonable alternative to the services of private providers. And so here we come to a pivotal issue in our submissions, which is that if the existing healthcare delivery system, which comprises public and private providers, is uprooted, and the NHI scheme envisaged in the bill cannot be effectively implemented, everyone's right of access to healthcare services would be threatened. The next slide, we deal with the second threat, which is to the role and viability of private sector hospital providers. The private sector currently plays a significant role in the provisioning and financing of healthcare services. And here too, Chair, the HMI, the Health Market Inquiry, recognized that private providers are important agents in the delivery of healthcare. Private hospitals provide facilities, currently approximately more than 530 private facilities with over 40,000 licensed beds. And 30% of the total hospital beds in the country are in private facilities. Private hospitals play a significant role in training nurses. More than 50% of the output from nurse training programs in the country is from private institutions, and between 4,300 and 4,500 nursing students were enrolled in training programs offered by private hospital groups during 2014 and 2015. The private hospital sector also makes a significant contribution to the South African economy generally. In 2016-2017, which is the last period for which an analysis is available, private hospitals contributed over 55 billion rand to the national economy. That's 1.3% of GDP, supported over 248,000 jobs, 1.57% of national employment, and contributed over 16 billion rand in tax, 1.5% of total tax revenues. In slide 17, we note that key components of the bill threaten the viability and the role of the private hospital sector. Firstly, the contracting and reimbursement frameworks in the bill do not accommodate private hospital participation. The referral networks and the service delivery models, which are set out in the bill, don't take account of the role and the structure of private providers. For example, Chair and honorable members, you'll see in the language which is used to describe healthcare provision in the bill that it reflects the current classification of the public healthcare provision: central, tertiary, regional, specialized distinctions. And this classification gives rise to two main problems. First, a limitation on the procurement of services from private hospitals and other providers that don't fit into this classification. And second, this classification provides for insufficient flexibility to accommodate new service delivery models in the future. The next point we make is that the criteria for provider accreditation don't take account of the structural features of private healthcare provision. For example, the ethical rules that apply to private providers in relation to the sharing of fees, their business models, and subcontracting. The bill also provides no reasonable certainty that private providers will be reimbursed at a commercially viable level. And here we're saying that we must be certain, and it's not clear from the bill, that prices will exceed the provider's total cost of delivering the service, and therefore support sustainability of providers. Prices also must bring about parity between the public and private providers. And here we point out that there are very significant input costs differences between public and private providers, including private providers being subject to taxation, different costs of capital, costs of labor, and the public financial mechanisms which are available to the public sector and not to the private sector. The second point we make is that the exemption of the NHI fund from the provisions of the Competition Act exposes providers to risks that the fund, as the very powerful single purchaser of healthcare services in South Africa, will be in a position to cause harm to competition and to erode private sector resources by, for example, using its dominant purchasing power to force prices for healthcare services below the competitive level. And we know that once you force prices below the competitive level, you will then have sacrifices in terms of quality of services, choice of services, and in terms of innovation, which is a key element in the provision of healthcare services. The fund, as a dominant purchaser, may also conclude exclusive dealing arrangements with particular providers and thus threaten the existence of other providers in the market who would be protected by the provisions of the Competition Act. And finally, the bill limits medical cover to complementary cover. If that term is narrowly defined, it will limit private hospitals to providing services only to those who can afford to pay out of pocket, a very small minority of the population. The third threat that we've identified is the erosion of medical scheme cover. Approximately 9 million South Africans currently belong to medical schemes, and the cover obviously is concentrated in the economically active segments of the population. And those who are currently insured enjoy a guaranteed cover for prescribed minimum benefits, a very important innovation in medical scheme cover. And so they enjoy access to treatment for over 270 medical conditions and at least 25 chronic conditions like diabetes and asthma. Section 8.2 of the bill allows for medical scheme cover where there is divergence from the prescribed referral pathway or the formulary described in the bill. Sections 6.0 and 33 of the bill, however, limit the role of medical schemes to complementary cover only. And what this means, what this very important term means, is not clear from the bill. The uncertainty that results, we say, is illustrated with reference to the table we've given you in slide 19, where we've identified 3 categories of services under the bill. Under category A, we have 2 subcategories. In subcategory A1, we have covered, we've called these services covered paid services. These are services which in principle are covered by the NHI fund and in fact are paid for in a particular case. Category A2 is covered unpaid services. This would be services which are in principle covered by the fund but not paid for in a particular case because, for example, the user did not follow the correct referral pathway. And third, category B is precluded services, services which are in principle not covered by the NHI fund. Now, what we put to you today, what we submit today is that if complementary cover means that schemes can provide cover only for precluded services, category B, leaving out covered unpaid services, the bill will clearly be retrogressive in terms of access to healthcare. And in slide 20, we take you through an example of how that might come about. We ask you to consider a patient with chronic renal failure who's currently receiving life-sustaining hemodialysis treatment covered by a medical scheme. If the NHI is implemented, let us assume that in principle it would cover this treatment, but it's an expensive treatment and the NHI fund may not be able to provide cover to all patients who need it. Patient A won't be able to obtain medical scheme cover due to the restrictions on medical schemes, and won't be able to, and may not be able to access hemodialysis due to rationing. So patient A finds himself on a long waiting list, denied access to life-saving treatment. We pointed you to a couple of important court decisions illustrating the kind of challenge that this might give rise to. In the South African case, Law Society of South Africa against the Minister of Transport, the court found that there will be an infringement of the rights of paraplegic road accident victims to healthcare if the payment for treatment only covers treatment in the public sector, but the required specialized care is only available in the private sector. And in the landmark Canadian case of Chauli versus Attorney General, the Canadian Supreme Court found that a prohibition which was introduced, which prohibited private health insurance, the purchase of private health insurance, breached citizens' rights to life and to security, where the public health system was not able to provide them with adequate health care within a reasonable time. And importantly, we say the majority in that court pointed out that the state had effectively limited access to private health care to all but the very rich who could afford access to private health care without the need for insurance. So we ask you to consider that case law in looking at what the effects of this bill might be in respect of access to healthcare. In slide 21, we look outside South Africa for guidance. We note that in almost all countries, pursuing universal health coverage make use of hybrid financing models. Those models have varying degrees of duplication between public and private insurance coverage. They facilitate explicit income cost subsidies and introduce a degree of competition to the system, and that no low or middle income country has successfully implemented a single payer system that provides comprehensive coverage for the whole population, free at the point of care. The prohibition or the material limitation of the role of private health insurance is not required to achieve universal health coverage. And there is very limited evidence that such a model is effective in controlling healthcare expenditure and ensuring coverage. On the next slide, we look at more specific examples in respect of hybrid financing. We see that in upper middle income countries such as Russia, China, Romania, Bulgaria, and Malaysia, they allow a combination of supplementary private insurance, that is duplicative private insurance, and complementary private insurance. And almost every country in Europe allows for supplementary private insurance coverage, which may be sold in combination with some form of complementary cover. And then we have different financing models in countries such as France, Thailand, and Chile, where there are distinct pools catering for specific population groups and showing efficiency in responding to local population needs. As examples of single payer systems, we have Canada, and we note that Canada's total healthcare expenditure increased from 8.7% to 10.5% of GDP between 2000 and 2015. And most importantly, 15% of that spend was paid out of pocket. And Chair, honourable members, you've heard from other presentations that the most regressive finance model is one that increases out-of-pocket spend, because that means individual South Africans having to draw on their own resources to obtain medical care. And then in the countries like Brazil and Ghana, the high out-of-pocket spend, and we have the percentages there, 27% and 38% respectively. They both initially embarked on a single payer model, and this was the result, raising questions about how progressive this model is in terms of financing and financial protection. In slide 23, we highlight some of the measures which are required to address these concerns. We submit that the bill should provide for staggered implementation based on benefit costing, estimates of financial and human resources, and with measurable milestones having to be reached before key aspects of the NHI scheme are implemented. We suggest the removal of the limitations on medical scheme cover to ensure a comprehensive and sustainable role for private providers in the NHI scheme. We ask that you make provision for the sustainable existence of medical schemes and private providers, which in turn will allow for cross-subsidization of lower costs to the private sector. We ask that you optimize the capacity of the medical schemes environment to cover as many members of the population as possible, and building on very successful innovations like prescribed minimum benefits, including low cost benefit option frameworks to provide insurance for lower income households, reviewing and improving prescribed minimum benefits, and introducing a risk equalization mechanism which incentivizes schemes to compete on value to members rather than on attracting younger and healthier members. Thank you, Chair. Carisha Pillay will now deal with the remaining constitutional concerns.
Thank you. So now that we've looked, or Michelle's gone through the respects in which the bill impedes the right of access to healthcare services, the second constitutional ground is the principle that legislation must provide reasonable certainty. And we submit that the bill fails to provide reasonable certainty in a number of key respects, and its failure to do so renders it vulnerable to a constitutional attack in these respects. And so the first is that there's no reasonable certainty on the nature and the scope of healthcare services that will generally be available under the NHI scheme. And the corollary to that is that there's no certainty on the nature and the scope of healthcare services that will be available outside of the NHI scheme. Equally so, honourable members, there's uncertainty as to how registered users of the NHI scheme may access healthcare services within or outside of the NHI scheme. So too, there's uncertainty on the nature and the scope of the role of private healthcare providers in the NHI scheme and what the permissible scope of medical scheme cover is. These are substantial uncertainties in respect of the legislation, and bearing that in mind as against the constitutional principles, we've proposed certain measures in order to remedy those. And in the next slide, we identify what those measures are. As a departure point, we say that the bill should provide a fair and transparent methodology for reviewing the scope of services covered under the NHI scheme. And this would include a non-exhaustive list, but at the very minimum, it would include a transparent process of determining the benefit package, taking into account core principles of access, quality, and affordability. It would also entail the representation of all healthcare provider groups on the Benefits Advisory Committee, and it would include a review of treatment guidelines by an independent committee of academic and private sector specialists. Chairperson, if I could then move on to the third constitutional challenge that in our view the bill presents, and that relates to the issue of procurement standards.
Just quickly, Ms. Pillay.
Section 217 of the Constitution requires that when an organ of state contracts for goods or services, it must do so in accordance with a system which is fair, equitable, transparent, competitive, and cost-effective. Now, that is a peremptory constitutional threshold against which all legislation must comply. The bill, however, in our opinion, does not comply with the prescripts of Section 217 of the Constitution. And it doesn't because the scheme that it sets up is for the fund to determine the payment rates annually, and then for the Healthcare Benefits Pricing Committee to recommend the prices of healthcare service benefits to the fund, and then for the fund, in consultation with the minister, to determine the nature of the procurement payment mechanisms.
Sorry, Ms. Pillay.
I'm sorry, I'm told that the chairperson would like to make a comment. Perhaps I'll just pause for a moment.
Yes, I'm just hoping to ask you to maybe go a little bit faster because I'm considering our time, but I also realize that what you're talking about here, you need to emphasize in the way that you're doing. So I realize you still have 8 more slides or 6 more slides to go. Yeah, so just a little bit of faster talking and then we can get there. Thank you. I will allow you another 5 or 10 minutes, but because I can see you're going to require
Thank you, Chairperson. I'll be brief in what remains. And so in addition, we say that the bill gives the Minister of Health authority over both the NHI fund and the provider services in the public sector, which undermines the purchaser-provider split, and it creates a conflict of interest. Chairperson, just in closing in my section, the next question that we've interrogated is how can those shortcomings be remediated? And we say in the first instance, what's required is a review of the existing legislation which governs how organs of state contract for goods and services to ensure that the bill provides a lawful procurement framework. And in doing so, there really are 3 core submissions that we make. The first is that the model should provide for decision-making by a neutral, independent body. The second is that reimbursement of public and private providers in accordance with the different actual average input costs of public and private providers, respectively. And the third is that any tariff evaluation to be conducted in accordance with the appropriate coding, comprehensive costing data, and annual inflation. Chairperson, I'll now hand over to Kurt Pretorius, who will make some concluding comments and summarize where we are on it. Thank you.
Thank you, Karisha. Thank you, Chairperson, for your patience. I'll conclude with 2 more slides. On slide 29, Honourable Chair, we summarize all our key concerns and proposals, which makes it a lot easier to interpret. Firstly, the first concern is the breach of the right of access to healthcare services, and we have 3 important points: inadequate resources for effective implementation of the scheme, a limited role for private sector providers, and the possible erosion of medical scheme cover. Proposals to address stagger implementation based on costing and human and financial resource estimates with measurable milestones. Secondly, ensure a comprehensive and sustainable role for private hospital providers in the NHI environment. And then thirdly, remove the limitations on medical scheme cover to address those possible concerns. The second one to highlight is the lack of reasonable certainty on the nature and scope of the NHI scheme, we propose to amend the relevant sections of the bill to provide clarity on the following issues. Firstly, the nature and scope of services available under and outside of the NHI. Secondly, how users access services under and outside of the NHI. And thirdly, the role of private providers and medical schemes. We also suggest that provision should be made for a fair and transparent methodology for reviewing the scope of the services offered by the NHI scheme, including a transparent process of determining the benefit package. Secondly, representation of all healthcare provider groups, and then an independent review of treatment guidelines. Our third key concern, non-compliance with the standards governing public procurement. We suggest that the NHI bill should provide for a fair, equitable, transparent, competitive, and cost-effective procurement model, and to establish an independent body to determine appropriate reimbursement models and scientifically calculated tariffs. In conclusion, Honorable Chair and Honorable Members, we would like to once again express our full support. As I've mentioned, universal access to quality healthcare for all South Africans is an imperative which Mediclinic fully supports. In its current form, however, the bill is subject to the risk of not meeting its objectives. The future of healthcare for this country and all who live in it will be determined by this bill. It is of fundamental importance to the future of all our people. It is a golden opportunity to harness the resources of all role players in all healthcare sectors and to provide clarity and certainty to all. And lastly, but not least, Mediclinic remains fully committed to being party to the development and delivery of South Africa's future universal health coverage dispensation. Chairperson, we understand that this is not the end of the process. There will be many more public presentations, and there will be a process that the honorable members of the committee will follow to finalize the bill, and we are willing and able to support and participate wherever we can make a contribution. Honorable Chair, thank you very much for listening to us.
Thank you very much, CEO of Mediclinic Southern Africa, to you and your team, and for the presentation that you had done. We have a number of members who want to raise questions with you, and we're hoping that you'll be able to answer all of those questions. Just to remind the members that for today, we have cut the time from 45 minutes to 30 minutes for discussions, raising of questions, and also for responses. So we need to be mindful of that. And then also where I had left out on welcoming anyone else, which I think I had not done because I said welcome to everybody who had joined this platform. But I think in particular, I should also welcome the MEC of Health of the Western Cape and the staff of the Department of Health who are part of our program today, and all other members of media, etc. Honorable members, I have a number of names of those who want to raise questions today.
Chair, I raised my hand before, please.
Thank you very much. Is that something you want to raise or a question, Honorable Munyai?
It's not a question. I want to raise it before. Honorable Chair, in a highly contested bill such as the NHI, I think we need to be consistent with time. Otherwise, in final analysis, we may be taken to court for inconsistency. I want us to continue with a similar time that has been provided for others, and continue to do as, because there's also an option if members, they will not want to answer some certain question, to really send some written reply. I'm just appealing that we should not change the time allocated for other previous organization and a future organization. I'm trying to persuade you, Honorable Chair.
Thank you, Honorable Munyai. Let me explain why we had done that, because we were planning on having 6 to 7 presentations per day in order for us to finalize our work. It had been coming on for a long time. I hear and note what you are saying, Honorable Munyai. I must say also that we have had one withdrawal for today, which might allow us some more time, and it's with that in mind that I did mention to the presenters from Medical in Southern Africa that I would allow them another 5 or 10 minutes. I see the committee secretary is writing to me that we have not changed the time. So let me then make a ruling today. We will stay with our 45 minutes. Let us not take more time with this. It is now 12:21. 45 minutes from now would give us 39 to 10 minutes. Let's say 10 minutes to 1 o'clock. We should be completed. So let us then continue. I do not know who the Zanella iPhone is. We do not take any questions raised by anybody apart from members of parliament. So you may please lower your hand. Thank you very much. We will now continue. Honorable members, I have the following names. Honorables Gela, Ismail, Clark, Harvard, Chirwa, Sukacha. Anyone else?
Honorable Munyai.
Munyai. So I'm going to repeat in this order. Honorables Gela, Ismail, Clark, Harvard, Chirwa, Sukacha, Munyai. Can you please raise your questions, and we'll see how quickly we get done with it. Thank you very much. Be also mindful that we have a number of presentations today. Will be followed by the Hospital Association of South Africa after this one. We'll have a bit of a longer break because of the withdrawal. Then we'll have the Western Cape government at 15:45, SAUDA at 17:45, and Life Healthcare at 18:15. So we are going to finish quite late today. Honorable members, please prepare yourselves for anywhere between 19:30 and 19:45. Thank you very much. Please, you can start raising your questions.
Thank you very much, Chairperson.
Honorable Gela.
Yes, Chairperson, thank you very much. Chairperson, I've got 2 questions that I want to ask to the presenters from Med Clinic. We appreciate your input into this process, and I heard that you also support the NHI. Your concern about microeconomic factors is noted. What is your view about the expected efficiency benefits of monopsony, purchasing power and economies of scale of the NHI? From your experience in your industry, do schemes or administrators with economies of scales have efficiency benefits? You are worried about the uncertainties with regard to the healthcare services funded by the NHI fund. You are worried that the Benefits Advisory Committee won't be able to determine the services. Are you aware of Section 15.3b of the bill in line with Section 25 and Section 57 5C? Those are my two questions, Chair, to the presenters. Thank you.
Good morning, everyone, and thank you very much for your detailed and thorough presentation. I just have three questions. My first question, Mediclinic warns that the NHI fund is strongly influenced by the judgment of the minister and increases the risk of governance failures. Now, what recommendations can you provide with regards to management of the fund in order to ensure that there are effective mechanisms in place to prevent corruption and mismanagement of the fund? When I'm asking this question, I'm referring to specifics specified in the bill, so that the issue of corruption or future corruption can be managed or controlled. My second question, in which way would you like the private sector to be included in the bill to ensure efficient provision of healthcare services? In your presentation, you've discussed a lot. I'm actually asking the question as to what specifics would you want included in the bill to ensure that your concerns raised are actually provided in the bill for efficient healthcare services that will be including the private sector. And my last question, listening to your presentation, would you say that you agree or support the NHI in its present form? Thank you, Chair.
Honourable Clark.
Thank you very much, Chairperson, and thank you very much for the detailed presentation. Very interesting issues raised in that presentation that we need to really take on board. Just the following questions I'd like to ask. In slide 9, you mentioned that the UHC should be informed by the South African context. Can you elaborate on this point? What implications does the current economic climate have on the adequate implementation on the NHI? What do you foresee being the implications of the NHI on health access? Should there be critical shortages in financial and human resources? Do you foresee a drop in access to essential services? What do you feel are the reasons that the NHI does not seek to include a hybrid financing model? Based on your concerns regarding the negative effects the bill could have on access to healthcare services, in what way do you foresee it resulting in an increase in the inadequate part of healthcare access rather than improving equal access as it intends? Now, I'd also like to know, would you say that an independent ombudsman would play a key role within the outcomes of the NHI in terms of transparency and accountability? Quality of health, how would you implement the wellness aspect in line with the NH bill to achieve this important indicator? What is your view in terms of a parallel health system rather to a blended approach? And, we had Discovery during a presentation yesterday, and they made some really key points around that matter. You spoke about quality healthcare. Do you think in the current status quo, in terms of the state of state hospitals and the environment they function, would the NHI bill be successful and would it achieve its outcomes? I thank you. Thank you, Chair.
Thank you, Chair, and also thank you for all the presenters. I have two questions. First one, you have mentioned several constitutional challenges, including reimbursement mechanism for providers. Are you aware of Section 26 of the bill, which discusses the establishment of a healthcare benefits pricing committee? Are you also aware of Section 10E and the Section 25(5)? Have you read the white paper, which also outlined different reimbursement mechanisms by level of care? Second question, your submission raises concern that Constitution places a negative obligation not to take retrogressive steps on access to health care. Which is your basis for this concern? Can you provide clarity of when certain rights may be limited? Thank you.
Thank you very much, Chairperson. Sorry about that. Firstly, thank you to Midi Clinic for their presentation. I think one of the important things that I noted that I would like to speak on, because we've been raising consistently, is the issue of access, and them speaking about how it is a concern in their presentation. Their recommendation in really checking if the NHI is a valid model for the issue of access. I mean, we've said this because we are saying that it does not resolve the issue of access in rural and township areas, as there aren't any private facilities in those areas. So the persons living in rural and informal settlements and in townships will still be subjected to the public healthcare in its current state and its current form. And there isn't a clear plan on the issue of infrastructure and broadening the issue of access in rural areas, especially in the Eastern Cape, where we've seen even with the COVID plannings that there was an issue of people getting access to healthcare. And the issue of the NHI does not particularly address this in those areas. So now with wanting the investigation to go or to happen in relation to checking if it is indeed the valid model for checking the issue of access, what do they recommend should comprise of the team or the stakeholders that will carry through this investigation? Because I personally, on my side, I'd like to take this up on a serious level. Thank you very much, Chairperson.
Thank you very much, Chairperson. Let me greet all my colleagues, and let me also welcome the presentation. Just two questions, Chair, from my side. You are anxious about the potential conflict between the Benefits Advisory Committee and the Minister in the determination of healthcare services. Can you please clarify your concern? Also drawing from the experience in your industry, specifically on the review of the PMBs. Let me have my specs on. I can't see now what I've written here. The PMBs, noting the existing challenges with the PMBs. By this, I mean the short payments by schemes and limited funding for primary healthcare. My second question, Honorable Chairperson, is also you have observed contradictions between Section 33 and 60 of the bill. Section 60 states that the user can purchase healthcare services that are not covered by the fund through a complementary voluntary medical insurance scheme or any other private healthcare insurance scheme or out-of-pocket payment. And Section 33 states that once the national health insurance has been fully implemented as determined by the ministers through regulations in the Gazette, medical schemes may only offer complementary cover to services not reimbursable by the fund. Please, can you clarify this contradiction for me? Thank you very much, Honorable Chairperson.
Is it me, Chair?
It's you, Honorable Munier.
Thank you very much. Sorry, I have the challenges with my cameras, so forgive me if I can't have my pictures for the sake of the media and all guests. We noted the presentation by Midi Clinic, Southern Africa. Your presentation raises concern about the role and viability of the private sector, private hospital sector. I note that in your presentation, you have not provided the whole picture of challenges in the private sector. My question, therefore, to you is, under which regulatory dispensation do private sector hospitals currently fall under? And what is your view of implementation of regulatory process for your business? What are your concerns on the findings of the health market inquiries with reported market concentration, vulnerability to collusion with formal and informal cartels, benefiting from excessive utilizations, lack of scrutiny of quality of services, difficulty of new entrants into your space? This, according to Health Market Inquiry recommendation, has contributed to the high cost of private healthcare. You have raised concern about the limited role of the private sector providers and the use of the public sector classifications. Can you enlighten this committee of the existing private sector provider classification that you would like to be considered? Honorable Chair, the presenter raised the issue of the collaboration during COVID-19. It's precisely because private sector and public sector have hospital system has been overwhelmed. As a result, collaboration was unavoidable, including moving patients from the private sector to public hospital. So some of the areas of those were some of the areas of collaboration. I want to ask, do you have a fear for a democratic process for legislative reform by Parliament to address the current skewed racial current two-tier systems? With private medical scheme receiving 8% to GDP, accounting over 400 billion rands, how can it be, Honorable Chair, unconstitutional for everyone to have access to healthcare services? Because the state, as per Section 27 of the Constitution, must take reasonable legislative and other measures within its available resource to achieve progressive realization of these rights. When Parliament made budget, they don't have all the money in their pocket. For instance, they'll go source money. Some of the recently sourced money has been coming from the IMF and the World Bank, 11 billion. Not only to pay the debts, but to intervene in the interest of the public. How can it be unconstitutional or breach of the Constitution in terms of Section 27(2) for the Constitution to state that there must be reasonable legislative measures? How can it be breach of the Constitution to have rights of equality and human dignity as enshrined in Section 9 of the Constitution and 10 respectively? How can it be constitutional to have right to life as enshrined in the Constitution? I think, in my view, maybe the presenter must really take us whether their presentation and the contestation of the Constitution is based on greed, not access for collective interests of our people. It's purely, in my view, protection of the big business and monopoly in this regard. My last question, because you caution up on the on the time. I want to say, Honorable Chairperson, with all due respect, that the fact that you know, we had COVID-19 and bad infrastructure in public, and also problems in the private sector as per health market inquiry. It is precisely the reason, don't they think it's precisely the reason we need to have NHI? Lastly, Honorable Chair, I want to give example here, Honorable Chair, with due respect, that procurement of vaccine, is a better model when it was done by the state for every citizen. Some quarters tried to contest that view, and they were defeated in the court of law. And I'm saying, putting of resource, Honorable Chair, to address the health needs for all South Africans, it's a better issue to do. I don't want to waste your time. My last example, we were involved in a car accident with my brother. I was less injured. My brother was terribly injured. But the ambulance, ER24, which is part of their company, refused to pick him. They wanted to pick me because of medical aid. Those are the issues, amongst others, Honorable Chair. We believe, and I think also they believe, NHI seeks to address. Thank you.
Thank you, honorable members. Are there any other members whom I have missed who would want to raise any points with the presenters? If not, I only have 2 points I want to raise with you. The one is with regards to your operations in the UK and your participation in the NHS. With noting, of course, that the NHS is predominantly publicly funded or financed through the Spire Healthcare Group. Would you be able to tell us more, or can you please tell us more about your operations in the UK and what your view would be on the ability to function there versus what we are talking about in South Africa in terms of the NHI. And then you have questioned the intention to massively reorganize the current healthcare system, noting that you said that it will create enormous upheavals. The question is that you should please maybe elaborate on those anticipated upheavals, and would you prefer that the current status quo should remain in South Africa? Thank you very much. I think those are all of the questions from the honorable members. You're very welcome to reply to these questions. Thank you.
Thank you, Honorable Chairperson. With your permission, I will start with the last questions first. As far as the UK is concerned, you are quite correct. They have a publicly funded national health system. The difference between how the system works in the UK and what is currently proposed in our draft NHI bill is that patients, after contributing to the NHS fund, are still allowed to take out private medical scheme cover, and the cover is not limited to complementary cover only. So it's a hybrid financing model, and patients have freedom of choice. The important principle which we also support is that people cannot opt out of contributing towards the National Health Fund. And the same principle, we believe, should apply in our envisaged NHI as well. In terms of the quite radical overhaul of our healthcare system, we are in principle not against that. We only used the opportunity today to point out that it is a radical overhaul to move from our current budget system to a system where funds will be pooled and taxpayers will contribute to that pool, and that there will be a split in the purchaser and provider function and the governance that will be required to support such a system. I see Rowley also wants to contribute.
Yes, Mr. Chairman, thank you very much to the honourable members. Maybe I respond first of all in terms of the HMI report, which was briefly mentioned. There are some statements made around the excessive utilisation, the quality, and so on. And so let me deal with that. The HMI report found no cartels and no collusion in actual fact. And in terms of the HMI report for the hospital groupings, found that there was also no excessive profits. That clearly indicates that the difference between our input costs and our prices that we charge are quite reasonable and in line with normal business operations. In respect of the quality thing, we inform and we are governed by the provinces who do inspections. We're also governed by the Office of Healthcare Standards and Compliance. And consequently, there is an oversight in terms of quality. What the HMI recognized was that there wasn't a quality organization that was publishing quality data for the general public to look at. Mediclinic on its own is already doing that, and you can look at that kind of data on our website. However, it is true that there is nothing for the industry. What is important to say in this regard is that it behoves the Minister of Health to publish the data that it wishes to collect, to find an organization that collects that data on a regular basis, and then goes through a process of evaluating that data and publishing it so we can actually have a benchmark for all of the providers, that both doctors and hospitals, to be benchmarked against. That is something which is outstanding, but it really requires some form of legislation or regulation by the Minister of Health and the Department of Health to in fact enable that. I also want to talk to the context of the interaction between the doctors and the hospitals for utilization. And while they identified a few disciplines where there was some form of utilization increase which could not be explained, the important differential here is that private hospitals in no way contributed to that. That is purely a arrangement between the doctors and the patients concerned, and we would assume that the patients had a considered decision in deciding whether they needed an operation or not. So all in all, the HMI report did not find any significant negative concerns with regard to the hospital industry, and in general, we would accept and work with any proposals in that regard, which would make a change. I can go through one or two of them just to highlight that for you, and that is let me just get my page. To give you an indication, you spoke to the market size. I just want to record that the market also struggled to get a complete data set together to find out exactly what the size of the market is. And in some of the presentations that you will see still coming to you, that the hospital market is significantly different from what was initially accepted by the HMI. In fact, today we find that 34% of the market is in fact owned by independent or small operators, and that the rest of the industry, which is Netcare, Life, and Mediclinic, are in fact only the balance. And so there is in fact a significant degree of competition in our market, which has come in the last 4 or 5 years. So all in all, we think that the HMI report has not pointed significant fingers at the hospital industry, and we truly believe that we could go with all of the recommendations that they in fact make.
Thank you, Rowley. Chairperson, I would like to add, in response to the concerns raised by Honourable Munya, that we are not being defensive or protective about our industry. We are concerned about the delivery of healthcare to all the people of South Africa. What we are arguing is that we have very good resources available in the private sector, and we want to be part of the future national health dispensation in our country. We want to be part of the solution. Maybe two additional points to point out. There were no negative findings regarding the levels of profitability in our hospital sector in South Africa, and there were no negative findings about tariffs in our private hospital sector. So we are saying we should work together and leverage the strengths in the public sector and the private sector to find future solutions for our country. I'm going to go back to the first question raised by the Honorable Gela about the economic context and whether we see efficiency benefits for the bigger schemes. The short answer to that is yes, we definitely see that the bigger schemes achieve economies of scales and that they are more efficient, and this will be one of the benefits for the NHI fund. On your second question regarding the benefits advisory committee and the different sections that you referred to, I'm going to ask Michelle to respond to that specific question to provide more context.
Thank you, Kurt. I think the main point that we make there is that there's currently no certainty. It's not evident from the bill itself what the scope of benefits is. And there is this contradiction between whether it may be determined by the minister or by the Benefits Advisory Committee. And so the point which we reiterate is that these are not things that can be left until later. The legislation must provide reasonable certainty to all concerned, everybody who's going to use the NHI service and all those who wish to provide services in terms of it must be able to regulate their activities on the basis of some certainty.
Thanks, Michelle. While you have the microphone, I think it's very important that we respond to the question raised by Honorable Sukacha regarding Section 33 and Section 6.0. Maybe it's appropriate just to give the full perspective on those very important sections in the bill.
Thank you. Yes, I'd like to respond to that because that really is the nub of that table that we put before you, where we said there are three kinds of services. They're the covered paid services, the covered unpaid services, and the precluded services. Now, if you read Section 33, it says that medical schemes will be restricted to providing cover for services which are not reimbursable. Section 6.0 says the medical schemes will be able to provide cover for services which are not covered by the fund. Now, what's crucial is the meaning of those two terms, why the same term hasn't been used in both. So at the end of the day, it's very important whether the services which cannot be covered by medical schemes are what we've called the covered unpaid services. In other words, you or I, as users of the fund, need to have a hip replacement. I'm probably giving away my age with that example. But we follow the, we go into we seek that service from the fund, and it's available, it's covered by the fund in theory and principle, but at some point we're told that you haven't followed the correct referral pathway or it's not medically indicated at this stage. And so you reach that point where the fund is not going to provide that service to you free. Can I then can I rely on medical cover for what is then a covered unpaid service? Or am I high and dry? And in order to know that, I need to know that at the outset because I need to know what kind of cover I can take out just to cover myself for that eventuality. If that not reimbursable and not covered is simply what we've described as the precluded services, let's say cosmetic surgery, That's precluded by the fund. You have to get it else. We have to get it privately or with medical cover, or pay for it out of your own pocket. Then we're clear that that's all that medical schemes are able to cover. But the point we make is that if that's the case, then you and I, in the scenario that I have sketched, will be high and dry when we reach a point in the NHI pathway where we're told that we're not covered, that the service won't be paid for.
Thank you, Michelle. Honourable Chair, I'm in your hands as far as time is concerned, but if we are allowed to continue, I want to respond to the question raised by Honourable Clark.
I would give you 5 more minutes. Thank you very much.
Thank you, Chair. Honourable Clark referred to slide 9 and developing a solution for national health within the SA context. And mention was made of the discovery proposal for a hybrid financing model and what our views are on that specific issue. We are fully supportive of a hybrid financing model. When I referenced the UK earlier with their national health system and the system of private medical insurance, there's excellent cooperation as well between the public and private sectors. And the NHS often outsources services to the private hospital industry. The reality is, in South Africa, we cannot afford to implement any national health insurance system that will not fully utilize all the resources in the public and in the private sector. Any system that will do harm to either the public sector or the private sector will not achieve the objectives of NHI. So most of the proposals, Honourable Clark, that you mentioned about an independent ombudsman, independent measurement of quality, etc., we support all those proposals. Many of those recommendations were also made in the Health Market Inquiry report. I'm not sure whether my colleagues were able to fully understand the questions raised by Honourable Harvard. It sounded as if she referenced many sections in the bill, 2610C and 25.5. I'm not sure, Carisha or Michelle, whether you are in a position to respond.
I think we thought that was one that we might ask leave to respond to in writing so that we can look more closely at that those sections first.
Thank you, Michelle.
But I do think Carisha is willing to address some of the other constitutional questions.
Please go ahead, Carisha.
Thank you very much, Kurt. I thought a common thread that ran through many of the questions dealt with the alleged unconstitutionality of the bill. And they came up in different forms, but I think at the rub of it, the question was, if you have a bill that seeks to give equitable access to healthcare services, is that not directly in accordance with the imperatives of Section 27.2? And to that we say, of course, the purpose of the bill, the objectives of the bill, are unlikely to ever be found unconstitutional by a court. But the question rather is directed at the mechanisms underpinning the bill in order to meet that objective. And the mechanisms underpinning the bill, we know that the Constitutional Court has told us they have to be rational, they have to be capable of meeting the ultimate objective on it. They have to provide sufficient certainty and detail so that people may arrange their affairs in accordance with it. And where our difficulty lies is primarily that the question of sufficient certainty is missing from the bill. And absent sufficient certainty, people have no clarity as to what falls within the NHI, what falls outside of it, and how can they regulate their own affairs in order to ensure that they can access healthcare services as provided for in Section 27. And the difficulty in getting there is the various hurdles that the bill places. So of course it tells us you need to be eligible, you then need to register. But once you register, you get services which are within available and appropriate resources. You get services which cannot be unreasonably withheld. You get services within a reasonable period of time and so provided it falls within the formulary. But there's no certainty on any of those questions as to what the end result is and what's the appropriate criteria to meet those benchmarks. So in summary, on the question of unconstitutionality, the point we make is perhaps a slightly more nuanced one, and that is that government's not going to be taken to court because of the objectives of the bill, which purport to give equal access to healthcare services. If there is a challenge, the challenge will lie in the mechanisms developed in the bill and whether those mechanisms meet with the constitutional imperatives. Thank you. So in light of our time constraints, I'll stop talking now.
Are you done, CEO?
Thank you, Honourable Chair. I think we have run out of time and we've made notes of all the questions. We will definitely respond in full to all the questions. If I may, in closing, Honourable Chair, just once again reiterate that we support universal access to health coverage. We support the objectives of the NHI. We are concerned about certain detail in the current draft bill, but we think it can be solved and we are willing and able to participate. And once again, thank you for accommodating us and thank you for your guidance and your patience. And good luck with the big task that you and your team are busy with.
Thank you very much. We appreciate you coming to do this presentation. Of course, as I always say, we also learn from these presentations, and I'm certain you also learn from the questions which are raised. And yes, we will be looking forward to your written replies to any questions which were left out. Thank you very much once again for coming. Honourable members, let me also welcome Dr. Lomo, Sikomiseni Lomo, our Deputy Minister, whom I see has also joined our platform, while we are then going to say goodbye to the representatives from Mediclinic Southern Africa. You're welcome to stay on should you wish to do that. You're also welcome to leave. Thank you very much. I'm going to welcome the representatives from Hospital Association of South Africa, Dr. Bomela. I think is the, yes, Dr. Dumisani Bomela is the leader of the team, will be presenting on behalf of HASA. Let me just call you HASA. A very warm welcome to you and your team. Thank you very much for coming this morning. We will go straight into your presentation. Thank you.
Thank you very much, Honorable Chair. Is my picture showing? Can you see my picture? I just want to be sure.
Yes, I can see you well and I can hear you well. Thank you very much. You may continue.
Thank you so much, Chair. I am Dumisani Bomela, as the Chair has said. I'm the CEO of the Hospital Association of South Africa. The presentation will be made by myself and Melanie Da Costa, who chairs HASA's Research and Health Policy Subcommittee, which is one of HASA's board subcommittees. Melanie is also a past chair of the HASA board. To complete our team, there are 3 other board members, Neil Ne, who also happens to be the CEO of NHN, the Association for Independent Hospitals. There's also Dr. Ncaban Zwaiba and another board member, Ms. Clara Finlay, who is the chairperson of HASA's legal subcommittee, which is another board subcommittee. In the next 45 minutes, Chair, we hope to make a thoughtful contribution to shaping the National Health Insurance Bureau. And in doing so, we wish to cover the following ground. We will provide a very brief overview of HASA membership and their footprint. We will turn to what we believe from a policy perspective is necessary to fulfill fundamental founding principles of the National Health Insurance Fund. And then we will share our proposed recommendations on the bill. Please allow us, Chair, to start this discussion by acknowledging and thanking our many colleagues on the front line of the fight against COVID-19 for their massive sacrifice. We are reminded that we are still in the midst of that pandemic. If we can move slides and move one further slide. One slide back. So, Chair, thank you. So, Chair, through this presentation, our aim is to assist in crafting a bill that enables a successfully implemented national health policy, the National Health Insurance Bill in this instance. But before we do that, we will briefly share who HASA is and what HASA's stance is towards the National Health Insurance Fund and this bill. HASA is an industry association for private hospitals in South Africa. The information on this slide reflects the entire private sector with the total footprint of private health establishments. HASA members comprise approximately 80% of the acute beds. On this slide, acute beds are the big number at the top of the table. Our members include Life Healthcare, Midi Clinic, Southern Africa, Netcare Limited, Pty Limited, and the National Hospital Network, which is a collective of independent hospital operators, also referred to with the acronym NHN. The NHN has the largest number of facilities in the market. As of 2016, 67% of all private hospital facilities were owned by the independent operators, many of whom have their origins in the marginalized communities, which is where they operate even now. It is noteworthy that Life, Mediclinic, Netcare have extensive experience operating in other territories where universal healthcare systems are in place. We move on one more slide to the next one. If I may summarize the slide on HASA's position on some of the key issues, Chair. HASA and its members agree with several key aspects, such as the bill's objective of universal health coverage, the endeavor of improving equity and access to quality healthcare, as well as addressing the healthcare system's performance. We also agree with an iterative approach in ushering in the NHI and in its expansion, which means learning and adjusting as we pursue various milestones. The social solidarity and equity principles are something we support strongly, meaning all must participate in a common risk pool and contribute according to their means. We'd like to point out that in our view, instead of expanding on numerous bottlenecks that impede access, the SAIS fails to fully articulate the problem statement with a consequential narrow definition of the financing system structure as the main obstacle to the achievement or attainment of universal health coverage. As a result of this concern, our presentation will highlight various underlying issues in the system to address lack of equity and access, which cannot be addressed just by changing the funding structure. In this regard, in this presentation, we advocate for the following. We will advocate for the following: clearly defined, transparent, measurable milestones rather than dates to advance the NHI reforms. Avoiding unintended consequences of implementing a schedule of amendments to other acts upfront rather than through a phased approach. Mitigating against the inherent concentration of operational risk that comes with a single NHI fund. And also mitigating against the systemic and financial risk that is inherent in a single fund. Our intention in this presentation is the shaping and the implementation of an NHI that meets the spirit of improved access, as well as sustainable delivery of, sustainable delivery objectives. At this point, Chair, I would like to hand over to my colleague, Melanie Da Costa, to carry on with this presentation. Thank you. Up to you, Melanie.
Thank you, Dr. Bomela. And good morning, Honourable Chair, Honourable members of this esteemed committee, Honourable Deputy Minister of Health and representatives from the Department of Health and colleagues. So we truly appreciate this opportunity to engage with this esteemed committee on this critical topic. As healthcare providers, we assure you that we are fully aligned on the obligation to ensure that all South Africans get the access that they need when they need it. We recognize that the South African healthcare system is highly fragmented. We further acknowledge the unequal distribution of resources and the impediments on affordability given the employment realities in South Africa. And as private hospitals, we assure you of our full commitment to building towards a just society. So if the system that we build for future generations is human-centric and sustainable in the longer term, I'm sure that you will agree that we've succeeded in what we are deliberating today. So HASA unequivocally supports addressing inequality in health access. All literature points to the fact that prepayments is an important stimulus in improving access to healthcare. The reason for that is primarily because it opens up the ability to purchase healthcare services from private providers as well as public providers. Now, at the heart of a human-centric healthcare system are two fundamental principles. The first I've already alluded to, and that is that everyone gets the care that they need when they need that. But the second one is also critically important, and that is with respect to our healthcare workers. We know that in South Africa, we have a very small pool of healthcare workers. We also know that healthcare workers have experienced incredible emotional and mental stress and physical stress responding to 4 COVID waves. And studies have shown high levels of burnout. It is absolutely critical that we retain our healthcare professionals, but even more so that we speak about how we structurally increase the healthcare workforce in South Africa. So with respect to the implementation of reforms, we note the WHO's guidance that the bench strength of a health system can affect both the speed and the quality of the implementation of reforms. Now, despite COVID-19's many devastating impacts, it has presented the healthcare sector with a very powerful opportunity to innovate. We've seen much innovation in the digital and health tech space, such that we're seeing increased access remotely and even monitoring of patients remotely. We've seen significant increase in analytical capabilities and even artificial intelligence. And this can go to many purposes, including managing disease progression. The reason why I raise this with you is one of the big impediments to healthcare access has been the one-on-one relationship between a patient and a healthcare worker. We feel that we could be at a cusp of a healthcare revolution where we could be seeing efficiencies in future that we haven't seen over the last few decades. So now, as we turn to the problem statement, I just want to apologize that there are some contextual slides from a policy perspective, but this is important because it does inform some of the legislative recommendations that we'll be proposing. So as Dr. Bomela noted, the SAIS is pretty limited in its focus. It's got a very narrow focus on the key problem facing universal healthcare, being the financing system structure. Now, we totally agree that funding and the financing system structure is important. We note that the Medical Scheme Act of 98, together with amendments introduced in 2000, actually introduced principles of social solidarity, but in effect, it was half pregnant. We implemented the risk elements, but we did not counterbalance that with the elements that would have distributed risk better. So we introduced prescribed minimum benefits and community rating, as well as dispensations on early joiner penalties or waiting times. What we failed to proceed on was the counterbalancing reforms of mandatory cover and risk equalization. 15 years on, we've seen the impact of that in terms of the adverse risk on medical schemes, given the decisions that younger and healthier people have made in terms of purchasing healthcare cover versus the decisions made by the older and sicker population. So we are aware of the funding constraints. South Africa's per capita expenditure on healthcare is but a quarter of that in the OECD. But what we want to stress is that in terms of healthcare professionals, this is an even dire reality. So hence, the problem statement that we're dealing with is both physical access as well as funding. So the Development Bank of South Africa in 2008 created an in-depth study on the health problems in South Africa. And they were pretty clear in recording their concerns with respect to the capacity of the South African system to deal with the demands. Now, we note that in the memorandum of the objects of the NHI bill, it does cover more detailed system strengthening, but this needs to be more explicit, and we think that this goes to the milestones in section 57. So it's critical that, as we think of how we deal with these various challenges, that we also manage the risk of the significant transformation. As you well know, the NHI is pretty substantial in its impact. So we need to ensure that as some elements of NHI go live, be they benefits or be it other legislative amendments, that these steps enhance access to care. Now, this concern is primarily with some of the benefits that might be purchased initially just from the public system rather than primary healthcare and emergency services. And I will elaborate on this, as I did notice in yesterday's session, there was some confusion on this topic. So we also need to be quite pragmatic and wise about concentrating funder risk. And by funder risk, we are referring to some of the operational items, as well as the funding envelope and the burden that that might place on the state. So we note in addition that the delivery burden might very unintentionally transfer to the state if the removal of some of the medical scheme tax credits isn't aligned to the phasing in of benefits and how they are purchased from some providers, but potentially not from other providers. So quickly turning to the mainstay of the health system. So this table basically shows you the realities we face and stark realities with respect to nursing resources and doctor resources. So the sustainability of the delivery of healthcare services is very much dependent on these two elements. And arguably, the shortage of healthcare resources is the single biggest impediment to healthcare services in this country, even as we stand today. So the graph lays context to the nursing challenges. We just want to stress that there was certain closure of nursing colleges in the 1990s, and in the decade following that, the public sector was able to really step up in terms of nursing output to the extent that it was the larger contributor to nursing output. More recently, there have been changes to the curriculum and very significant constraints in the forms of quotas that have been placed on nursing, on private nursing institutions. And we feel that that is highly problematic. So HASA recently collaborated on a study with the Department of Health and with an external consulting company to confirm if there's a shortage of nurses in the country or not, and to what extent there's a shortage. The reason for this is obviously there are parties that believe that there are enough nurses in the country. In short, at a minimum, South Africa is in need of 20,000 nurses with immediate effect. But among our panel is Dr. Neba Nzwaiba, who participated and oversaw this research from HASA's perspective, and he can certainly field any questions you might have. Now let's focus on the doctors. Firstly, to acknowledge there is a grave shortage of doctors in the public sector. We're not taking away from that. In certain specialities, it is in fact unconscionable. The point we want to note is that there's a lot of debate on the distribution, better distribution of doctor resources, without an acknowledgement that we have an absolute shortage of doctors in the country. And the debate we need to be having is how we structurally increase the number of doctors in our country. Now, a significant explanation for the shortage of doctors relates to the output of medical schools. So what we have on this graph is the active medical schools in South Africa versus other countries and the population it serves. Now, not taking away from the extra capacity added over the last while to the various medical schools, but also the opening of a new medical school, and certainly not taking away from the Nelson Mandela Castro training program, we do note that other markets do embrace private medical schools. Now, I always reference the fact that, do you know that Harvard is private? Do you know that Yale is private? Developing markets also embrace private medical training. Just looking at India and Brazil alone, in terms of either medical schools or output, they contribute about half. I know that this panel is often reflected on Cuba, and if you were to add Cuba to this table, it would sit above Libya in terms of the active medical schools per million population. So let's just turn to the shortage of beds. And I think that this is an important slide, as a lot of people feel that actually there are enough beds in the country. When I reflect on this slide, we're at about 2.3 beds per 1,000 population. Just out of interest and context, Cuba would be sitting at 5.3. So even though some people argue we have enough beds, we would argue that at ground level there is a dire shortage. And you just have to reflect on a couple of specialities such as maternity services, the waiting lists on a whole lot of surgical lines which can run into multiples of years, and oncology services, to note that there certainly is a shortage of resources that we need to honestly reflect on as we strengthen the system. This slide for me is a great slide of contextualizing the supply side of healthcare. You know, in effect, it tracks the number of beds in South Africa over more than 4 decades. The overall population, as you know, has increased from about 25 million people in the 1970s to closer to 60.7 million today. The burden of disease, as was discussed yesterday, has increased exponentially, and add to that urbanization, and you find that facilities in major metro areas are really congested. So it's notable that public sector beds started contracting from the early 1980s, but it remains the bedrock of the health system at about 70% of beds in the country. The fact that the number of doctors, nurses, as well as hospital bed numbers have not kept pace with the population growth, it does mean that in order to increase each of these categories, we do need significant investment in healthcare. So the challenge we face is to build a health system that can deliver the reforms at the speed and the quality, but also such that the future generation requires. So a clear understanding of the interdependent, multifaceted nature of healthcare is required. And we do understand there are a lot of resource challenges, and it doesn't bear repeating, but just to the extent that there are a lot of steps ahead of us. So if you don't mind, let's turn to the funding system, the purchasing and the funding system. The first thing I would love to note is just the fact that HASA supports the purchasing of services from the private sector as a means to improve access to healthcare. We believe that there's actually nothing stopping this happening today. The purchasing of hospital services by public systems is commonplace in many countries around the world, if not all. The impediment is not so much the financing system structure per se, but funding, and that we appreciate. What we do note in the bill is that, and I do apologize, but I am having problems changing the slides. What we do note in the bill is that the bill is explicit in purchasing primary healthcare services and emergency services from the private sector and the public sector. And what's documented here is extract straight from the bill. But with respect to hospital services, it's more explicit about purchasing services from the public sector. So as you can see, the fund must transfer funds directly to accredited public hospitals. So the question is, what is the contracting body for the private sector? So much can be read into this, including a very pragmatic view that, you know, this will come at a later stage of NHI for good reasons, so that the NHI is not overcommitting upfront, and I think that that is understandable. However, what is important is we do need to understand how the bill caters for NHI benefits that may be phased in, but only purchased from certain providers and not other providers. So on this score, we note Section 55 gives the minister the powers to establish relationships with public and private health establishments, and also the power with respect to optional contracting in of private healthcare service providers. Section 7(4)(g) of the bill is explicit that in phase 1, the purchasing of hospital services will be from the public sector. And all of this is okay and understandable. Section 33 basically says that medical schemes would be able to continue cover of private hospital services if this was the case. I guess the issue we just want to understand here is, what does it mean until, when the fund is fully implemented? Because Section 33 says medical schemes can offer duplicative cover in effect until the NHI is fully implemented. The question we have, however, is how does this play out with the schedule of amendments in the bill, specifically with reference to the Medical Scheme Act? And the second question to this is, how do we consider the phasing in of the reduction of medical scheme tax credits, or the withdrawal, to the fact that we could have benefits that have now been listed, but not purchased from private hospitals up front, but rather just from public hospitals? So let's touch on these tax credits. As you're well aware, the white paper as well as the bill does speak to the reallocation of medical scheme tax credits. And this also makes full sense once the NHI is fully implemented. The question is rather just to acknowledge that the primary purpose for a tax credit is to reimburse a taxpayer that is actually not using the public system. So we acknowledge that you have paid your taxes. We acknowledge that you are not using the public system, so we can focus that resource on the most vulnerable, and therefore here is a tax credit to encourage you to purchase private health insurance or private medical scheme cover, as it's termed in South Africa. Now, this is pretty common the world over. Australia is actually very progressive in its tax credits based on age. The younger you are when you purchase private, the higher the tax credit that you'll be given. The issue is just that the removal of these medical scheme tax credits will obviously have an effect on some of the medical scheme population, and unfortunately the poorer, at a time perhaps where the NHI is not purchasing the services from the private sector. And I guess all we are highlighting to you, and I do apologize, I am struggling with this with the system. So all we're highlighting to you is that if the removal of the tax credits results in a structural reduction in medical scheme members, at a time where some of the hospital-centric or sometimes known as catastrophic cover is implemented, if it's not purchased from the private sector, it could mean that there's a shift of population into the public sector. And I guess a case in point here might be oncology services. So if oncology services are introduced but only purchased in the public sector, then and we know the problems with oncology services to date in terms of the demand versus supply constraints, and this is something that we just need to reflect on. Just to highlight more specifically the impact of these tax credits. Dumi, I am wondering if Laura needs to present because I am struggling with this with the system. Do you think, sorry, Chair, if you don't mind, will I be able to log out and log back in again?
You could do that if it's going to be speedy. Thank you.
Let's just try this. Apologies for this, honourable members. So this graph over here basically shows you medical scheme contribution per beneficiary per month, and it's broken down into income groups. On the right-hand side of the axis, you see the proportion of household income. So focusing on income group 1, what this is indicating in this study by Economics in 2017 is that the poorest 20% of medical scheme population would have paid 820 Rand contribution before the tax credit. That would have been 35% of household income. After taking into account the tax credit, however, the proportion of household income would have fallen by 60%, from 35 down to 22. And similarly, for income group number 2, it falls by 30%. So using an affordability threshold of 12.8%, Economics was able to deduce how many medical scheme members might be vulnerable in this phasing in of NHI, and they estimated that there would be approximately 22% of medical scheme beneficiaries. I acknowledge that the discovery number presented yesterday was lower, and we think that that might go to the affordability thresholds and people's perception on that. So let's just turn to the purchaser-provider split. So SA Public Hospitals, obviously, the bill does reflect the fact that we need to go to a purchaser-provider split, which we support. It's commonplace in all health systems that purchase services from all providers in the market. The reform, however, is complex, and the implementation shouldn't be underestimated. So we haven't seen a detailed paper on the proposed reforms. So this too will need to be piloted and will need to be iterated on. The risk is simply that public hospitals will now need to balance the money coming in every month to the money going out to service the population needs. Management and administrative reality is very different under a purchaser-provider split, and this too would need to be incorporated into the various milestones. So yesterday we had some discussion on strategic purchasing, and We refer here now to monopsony buyer, and there have been a lot of questions from this esteemed panel on the benefits of a monopsony buyer. And we just want to acknowledge that the blunt force of a monopsony buyer is not necessarily strategic. There is much global precedent on monopsony purchasers setting prices too low. Even though that might be attractive in the shorter term, in the longer term, it erodes the supply chain, either of services or of quality services. So in a purchaser-provider split, it is absolutely critical that healthcare services are priced in a scientific fashion that is transparent, and it is also an efficient payment system. And it's the efficient payment system that has been the undoing, for example, of COID and RAF, where healthcare providers could be sitting waiting for many months for payments. And at such time that the NHI is ready to purchase from private providers, it is very important to understand the structural differences. And most of these structural differences are as a function of regulation. At such time, either these need to be dealt with individually, or we need to create an equal playing field. The first, we note that doctors are employed in the public sector, and by law, they're not employed in private hospitals. The second is that private sector actually attracts VAT. You might not be aware of this. The world over, it's quite unusual to have a VAT on healthcare services, but private healthcare in South Africa attracts VAT, and there's also corporate tax. The third element relates to the purchasing of drugs and surgicals. Now, drugs and surgicals is about a third of the spend on hospitalization. As has been presented to this esteemed panel, the bill does speak to regulating the discrepancies between the prices in public and private sector. As you know, the single exit price locks in the prices for the private sector, but it is at a higher level than that of the public system. And obviously, these are items that need to be carefully considered as you equal that playing field, or you level the playing field. The other issue that needs to be noted is Capex. So in the public sector, it's possible that there's a different department, the Department of Public Works, that funds infrastructure. In the private sector, the profits are basically of the business need to be reinvested to the extent that we can sustain infrastructure, failing which there needs to be an injection of capital. So by and large, we find that about 50 to 70% of the profits of a hospital is reinvested in sustaining it, in sustaining the portfolio. The balance is paid out to shareholders as a dividend. So this goes to the return on investment. So as you know, we are not funded by taxes, but our investors tend to be pension funds or unit trusts. And in this particular situation, the PIC is a significant investor in the South African market. And as you would appreciate, they manage government employees' pension funds, and in effect, they need to return the money to the pensioners, having ensured that they have been able to keep up with the cost of inflation. So there is a requirement on a return on investment. I think it might also be of value to share with you that we are fully affair with not-for-profit hospital groups around the world. In fact, we've competed with some of them in other countries, and there are two fundamental differences. The first goes to the employment of all healthcare workers, and the second is they tend to get tax credits. So by definition, most places don't have a VAT on private healthcare services, but corporate taxes, they would get an exemption on that. But at the end of the day, whatever the profit is, you would find a similar situation. 50 to 70% gets reinvested in the business, and the balance is paid in dividends to the charity or to the church that funds that hospital so that it can continue its work. So just turning to the conclusion on the funding system, as mentioned earlier, international literature is very clear that mandatory prepayment is a key ingredient to achieving universal healthcare cover. So as private hospitals might be phased in at a later time, we do recommend that you consider the impact of amendments on the Medical Scheme Act up front, and also how it is that tax credits and the removal thereof is considered dependent on the ability to purchase from both private and public sector. We do also beg the question as to whether there has been sufficient consideration for the concentration of risk and the unintended consequences. Now, this is with reference to the operational risk as well as funding. So we believe that purchasing services from both the private and the public system goes a long way to closing the equity gap. And I think that it goes a long way to discussing how we address the two-tier system. With respect to the funding structure, we feel that the operational risk is significant. Yesterday, we had a presentation by several medical schemes, and the processing and administrative capacity on a daily basis was eye-watering. The RAF and COID once again has shone light on some of these complexities over time. The other risk relates to funding, and I think what was presented yesterday is the reference to over 200 billion that is brought in by private medical schemes, on the assumption that comprehensive benefits are introduced as referenced in the bill. Once the bill is fully implemented, it would mean that the private sector would play a significantly smaller role. And the question is, how do we replace that funding envelope? Because that funding envelope is imperative to the sustainability of all healthcare providers. And I think that there is a question mark on that. We do note that in terms of the risk itself, from an operational perspective, that the NHI fund could either be national or it could be provincially located, certainly with a single risk pool and risk equalization. Similarly, private administrators could also be considered. We note that there are alternative NHI approaches, and we don't believe that these have been sufficiently ventilated or engaged with. And we heard Discovery Health yesterday present a blended model, and this blended model required mandatory NHI taxes up front and a basic NHI package offered by either government funds or by private funds. And we think that there are some other, and we support that in general, we just want to admit that, but over and above that, there are alternative NHI approaches. One of them was constructed by Insight Actuaries for Business Unity South Africa. And Chair, we would think it would be helpful for Insight to actually share that level of detail with this committee. But in short, we're recommending a more inclusive approach to achieving universal healthcare that has a greater participation, not just of private healthcare providers, but also of administrators too. So just
Mr.
looking...
Forster,
yes, sir.
I can just remind you, you're about 2/3 through your slides. So I am a bit concerned at the pace that you're going and you have used.
Certainly.
Yeah, so yes, please see what you can do about that.
Perfect, I'll give you my assurances. So just in terms of specific amendments on the bill, because the bill is intended to create new statutory rights, and it also changes, restricts, or abolishes other existing rights, it is essential that the message is framed in a very clear manner and that there's limited uncertainty. And we want to indicate to you that we have found that uncertainty, even for us, where we might be a little bit more au fait with this. So as you know, Section 6 establishes user rights. Section 7, basically guides to the pathway one must follow before you can access NHI benefits. And if you haven't complied with that, Section 8 certainly covers for it. Section 8 says that if you haven't complied or if you don't get covered, you can certainly pay for voluntary medical insurance. We do note with Section 8 that there is a bit of uncertainty because people might get to that point in their healthcare journey and find they don't have cover, do not have medical aid. And we note that Section 8 does not allow, appears to not allow, for out-of-pocket cover. And even though that might be considered regressive, it is hard to imagine, and I don't think there is an example in the world of no out-of-pocket payments. In terms of the role of medical schemes, I think we have covered that it is, with respect to full implementation, that there is some confusion, And also, obviously, we note that the bill seeks to rule out any additional purchasing of additional insurance once the NHI is fully implemented, but for complementary cover. I think that the issue of timeframes has been well ventilated, Chair, and I think that we can move to these recommendations. So it's recommended that Section 8 should consider out-of-pocket payment. We believe that Section 33 needs to really define what fully implemented might mean. Consideration needs to be given to an integrated multi-funder NHI and removing the restrictions on additional funding after contributing to the NHI. That goes just to move some of that, the concentration of risk in the single fund and on government too. So Section 57 goes to some of the milestones, and we have heard you pose the question as to what these milestones might be. And it does go to the expansion of these priority services as we progress towards comprehensive healthcare, but also population coverage. But Chair, in the interest of time, a full set of milestones was issued to the to NEDLAC from Business Unity South Africa, and we could certainly share that with you. Then just turning to the sustainability of providers. So we note Section 35 speaks to the fact that the fund must actively and strategically purchase healthcare services. We have a recommendation here, and the recommendation is that there is an amendment in the word just to include with reference to quality and sustainability. On Section 11.2, this goes to the monopsony power. The bill is explicit in negotiating the lowest possible price. Taking guidance from international markets, our recommendation is that we include the most efficient price, considering quality once again. In terms of timely payment, even though the bill in Section 10E references timely payment, it is recommended that it is more explicit. And we notice the Medical Scheme Act in terms of Section 59 of the Medical Scheme Act actually guides to 30 days. In terms of the Healthcare Pricing Committee, and I do apologize, it keeps doing this, we note the experience of those listed to be included in the Pricing Committee, and we've got 3 recommendations. The first is that we believe the Healthcare Pricing Committee should be independent. The second is that there are certain expertise that have been omitted. The first is that of coding. In terms of coding, there might be 1,000 procedure codes, 10,000 disease codes. Definitely need an expert in coding. We need an expert in medical on the cost of medical infrastructure and the regulations thereof. That's R158 and 187. And certainly much experience in terms of new healthcare technologies. We further recommend that the committee chair reflects the very highly technical and varied range of expertise on the committee. Just the last element, Chair, is the omnibus approach to legislation. So as we all know, Section 58 speaks to the transition, and not just the Section 57 transitional arrangements, but all the laws relating to it. And the words explicitly in the bill is that the schedule is hereby repealed or amended. And we haven't been able to clarify the timeline on this, but our recommendation is as follows. We believe it is premature to contemplate all of the amendments that will take effect during or on full implementation of the bill. We suggest that legislative reform should only be considered when it is necessary, once the NHI has been fully established, and that these legislative amendments are necessary to future the fund's objectives. We further recommend that all proposed regulations should be subject to public participation. We want to give you one example on this. And the example, and it could be just a misinterpretation, and we're happy to engage the panel on this, but it's with respect to the Medical Scheme Act. So Section 58 says we repeal and amend the Medical Scheme Act such that the definition of a medical scheme is the collection of a premium for the disbursement of healthcare services that is not provided by the provisions of the NHI. So, some people might argue that the provisions of the NHI are clear in Section 8 and Section 33, but already we see there is an element of contradiction between Section 8 and Section 33. Furthermore, The changes to the definition of the business of a medical scheme, according to our interpretation of the stated intention of the bill, is that it creates an outright exclusivity in respect to the fund's benefits. We also note that there are worrying carve-out with respect to maternity services in particular. So on that score, our recommendation is that we remove the schedule or make it a draft schedule referencing it to section 57, and there will be an opportunity to have public participation when the time is necessary. Thank you, Dr. Bomela, back to you.
Thank you so much, Melanie. And now, Chair, as we come to the close, we would like to highlight the importance of building trust and confidence in the institutions, along with our very best efforts to build equity, to improve quality care, and generally to address the challenges we face in meeting our healthcare challenges. The NHI is an institution that is being proposed for generations to come. We are, in effect, discussing the single most important inheritance we can give to our children. We cannot afford to fail. And if we just move over to the next slide. These are the last few slides we've got now. And building the required trust and confidence in an institution begins with a strong governance approach. We agree with the concerns already raised by several stakeholders on the governance issues. We have quoted the Dalla Oma Institute on this slide, and we've listed several concerns relating to governance, such as the separation of responsibilities, concentration of powers, especially to the Minister of Health, independence and transparency. This is to procure now credibility and legitimacy with the general population. You need that independence and transparency, as well as performance and sanctions for board members to ensure proper stewardship. On to the next slide, please. In addition to the governance provisions, there are several other aspects to the bill that we raise for the attention of the committee. Without going into detail on any of them, we have listed some on the slides, which I will go through very, very quickly. Section 3(5), we urge that the Competition Act is not excluded from the NHI design. Section 13(5), parliamentary sign-off after consulting with the Minister of Health for board appointment is our recommendation. Section 16, conflict of interest provisions should include direct and indirect conflicts. Section 27, stakeholder advisory committee should include business representatives as one of the main players in society. Section 39, time periods for accreditation of service providers should be specified. Section 49 should provide for a transparent and incremental program for reallocation of medical tax credits. It's a point that has been well made by my colleague Melanie. And then lastly on section 52, again, we're raising the concern about the ministerial power. Our last slide for the day, Honorable Chair and honorable members, as we go to conclude our presentation, we believe that the NHI bill forms a credible basis and an important step towards universal health coverage. But the exclusion of other forms of funding and the limitation of rights to access outside of the NHI once fully implemented, is a concern as it detracts from the principle of long-term, sustainably built universal healthcare system that leaves no one behind. The envisaged restrictions on private cover in the NHI bill are unprecedented and do not exist even in the other countries with a single payer system, except perhaps you might argue for Cuba. In this presentation, we've tried to deal with the health system strengthening and governance, which are not sufficiently addressed in the bill. We've also pointed out ways to avoid negative impacts on hospital sustainability in their ongoing ability to provide quality care to patients under the purchaser-provider split. This is a reference to both public and private hospitals. We feel that their sustainability would be threatened if these are not addressed. We've also pointed out some likely unintended consequences, pointing out why and how these could be mitigated. We have specifically highlighted the following: the merits of a single versus multiple fines, the principle of measurable milestones that are required to progress the NHI objectives, the critical requirement to define fully implemented, which is not done in the bill, the need to time the various legislative reforms as per their absolute necessity in a process that is also underpinned by public participation all the way. And our last slide, Chair, we set out in the beginning of this presentation to provide our recommendations to strengthen the bill in order for us as a country to collaborate towards the provision of universal access to quality health care. Accordingly, we close on a positive note by reaffirming our commitment to working hand in hand with the state to build the very best version of the NHI for this country. And we thank you, Chair. We will be ready, our team will be ready to take the questions and clarifications from the committee members. We hand back over to you, and thank you so much.
Thank you very much, Dr. Bumela, and I'm not sure if it's Ms. or Dr. Da Costa, but we appreciate you coming to do this presentation to us. We have a number of honorable members who want to raise some points with you, and I'm going to mention them in order. And honorable members, if I had left anyone out, you're welcome to shout on this platform. It would be Honorable Gela, Honorable Siwela, Honorable Sukacha, Honorable Howard, Honorable Munyai. Any other members who want to raise questions, please shout on the platform now. If not, can we start in that order? Thank you very much.
Chair, can you add me, please? I did put it on the group.
Thank you, Honorable Clark.
Thank you so much.
You will be after Honorable Munyai.
Thank you very much, Chairperson. Can I proceed?
Yes, Honorable Gela.
Thank you, Chair. Firstly, let me welcome the presentation from HASA. I've got questions that I want to ask from their presentation. My first question, Chair, to the presenter. Your presentations proposes amendments under Clause 55 appear to insist on defining the South African health system in terms of the segregations we currently have in the public and private sector. Can HASA indicate what is missing in the context of this particular clause of the bill, which addresses health establishments such as hospitals without associating them with either the public or private sector? Can HASA propose how, as accredited and contracted healthcare service providers, they should be defined and worded? My second question, Chairperson, that will be only question, Chairperson, for now. Thank you very much.
Honorable Siwela. Honorable Siwela, you are next. We will move to Honorable Sukacha. Catch up with Honorable Siwela later.
Can you hear me, Chair?
I can hear you now, Honorable Siwela. Please continue.
Oh, okay. Thank you, Chairperson, for the opportunity. And I have one question to ask the presenters. Now, can the presenter, to the presenter of HASA, can you please share with the committee your views about the MHI recommendation on the certificate of need? I am asking this question because that is one of the things that need to be addressed in the private hospital market. The concentration of private facilities within metropolitan areas, which does not always follow the healthcare need, particularly from the rural provinces. And secondly, with reference to your concluding remarks, is HASA aware of the Presidential Health Compact and what it says with regard to health system strengthening as enabler of NHI? Thank you, Chair.
Thank you very much, Chairperson. Welcome the Chairperson. Just one question. You have raised an objection to the single fund model by indicating that it will have a negative impact on the health sector and its sustainability. We have also recommended the maintenance of the existing multiple payer system. My question is, why should the committee consider retaining the status quo when it continues to fall short in providing optimal and equitable healthcare to all South African citizens? Thank you very much, Chair.
Thank you very much, Chair and Presenter. I just have one question. What is HASA's definition of an iterative approach and a milestone approach? What are the measurable milestones that HASA has identified? How such can be included in the bill? And where in the bill can such be included in an iterative way as you suggest? I thank you.
Is it me, Chair?
Yes, it's you, Honorable Moniai.
Oh, thank you very much for the opportunity. My first question is as follows. In slide 20 of HASA presentation, you highlighted the need to consider the unintended consequences associated with the funding, which is proposed in the NHI bill. Can HASA perhaps please provide the committee with specifics around what HASA considers to be the unintended consequences of the funding of the healthcare of the proposed NHI bill? My other question, Honorable Chair, is as follows. I must say, I scribbled in various papers here, so just forgive me. This question that I want to ask, Honorable Chair, in the previous presentation by Midi Clinic, I asked this question and it could not be answered. They could not answer it. I want to repeat and plead, repeat the question. This time I'm pleading with HASA to answer the question in the same industry. What is it that, why is it that their ambulances continue to discriminate on the basis of an accident victim's pocket? As in the example I gave about me and my brother involved in an accident. They attended to me because I had medical aid. They didn't assist my brother who was terribly injured. Section 27 of the Constitution, subsection 3 says, I quote, open quote, no one may be refused emergency medical treatment, close quote. But the ambulances that came to our scene did this and violated this Constitution. And we know of many similar complaints. Can HASA as the association in these industries please answer this question and advise what must be done? The NHI will not do this discrimination. I want also to go forward. It seems HASA want to achieve a universal health coverage without the national health insurance. Without the national health insurance. I'm hearing this persistence, Honorable Chair, persistent questions about the resources. This is not the first bill that the Parliament is dealing with. Why money should be the preconditions when we're paying taxes to government? Equally, NHI can be funded from the general taxation. Why they believe that we're not going to fund money? Because including in Parliament, when the Minister of Finance tabled the budget, he doesn't have all the money. To some degree, he will find the money to implement the policy position or the act of Parliament. Why they think that should be the preconditions. Lastly, I want to ask HASA, or are they singing for the benefit of their association, of their members? I don't want to say lunch because they're well paid, I guess. But I'm saying, do they want really, and I think Honorable Sokacha tried to deal with these issues, do they want this country to continue with the racial skewed two-tier system in these countries, where the medical aid or medical scheme, private medical schemes, right? For instance, can I please be protected? Get 88% to GDP, equitable or accounting for more than 400 billion rand.
Point of order, Chair.
Can I please be protected? I'm making my own input.
There is a point of order, Honorable Chilbetsi Munyai. What is your point of order, Honorable Wilson?
Thank you, Chair. That is the second time today that the Honourable Munyai has accused medical aid societies of being racist and acting on racial grounds only. I think that is unfounded, and it was proved yesterday in a presentation, and I think we need to stop that line of questioning and those kind of implications to the people concerned. I find it very unhealthy in this environment. Thank you.
Honourable Chair.
Point of order, Chairperson.
Can we just go slow now? Honorable Munyai, we've just had a point of order raised. Now you wanted to answer, and then I have another point of order.
I want to clarify, yes. I want to clarify. I misunderstood. The person that raised point of order misunderstood me. I'm saying the current status quo, Honorable Chair, is racial, based on the old system, racial, two-tier systems that does not address equality in this country.
Sorry, Chair.
I didn't say the people.
I think this is wrong.
Please, I didn't say the organization that present here, they are racial. No, I speak about the policy, which is racial. That's why we're reforming it. When it is a two-tier system, which is not equal, what is it?
All right, so now, honorable members, I will go to the other point of order. Thank you very much for your clarity, Honorable Munyai.
Thank you very much. Thank you very much, Chairperson. I think I even raised this like last year in one of our NHI hearings as well, that I think we are going over and above in what we are supposed to do essentially as a committee during these hearings, which is to listen to the submissions and consider them as a portfolio committee. Now, on the thing of the racism and systemic oppression, we all know that that's the current situation and status quo in the country. But what I want to warn against is the apparent intimidation against people that are presenting to this committee. Right now, it's not our place to speak or to debate or to analyze, but to hear what the submissions are as a portfolio committee, because now we are listening to the people. We're taking parliament to the people to hear what they have to say and then consider all of that. If there's a clarity-seeking question, then we raise those as a portfolio committee. But otherwise, this period is to hear what the submissions are as a portfolio committee, not to contribute, not to debate, not to analyze. And if there is something that we need clarity on, then we seek and pose questions in that manner, not for any other points. Thank you, Chairperson.
Can I clarify myself, Honorable Chair, through your permission?
Honorable Munyai, can I be in charge of this meeting, please? I'll give you an opportunity.
Okay, I'm not challenging your authority, Chair.
I'll give you an opportunity now, if you would just let me complete my sentences. We've had points of order raised against what members had thought you had said. Firstly, that would be Honorable Wilson. And then secondly, what Honorable Chirwa said she had raised before. And then you had responded to Honorable Wilson and she had accepted your explanation. So I would give you an opportunity now to respond to what Honorable Chirwa had raised, and then we would have to move on with this matter after I would have then made a ruling. Thank you very much. Honorable Munyai.
Sorry, Chair, I don't accept his explanation. I am listening to what he's saying. I have my own views on that. I don't think it's acceptable, but we will discuss this in the correct manner going forward. Thank you.
Thank you very much for your understanding, Honorable Wilson. Honorable Munyai, on your response to what Honorable Chirwa had raised now.
Okay, let me address these issues quickly, Chair. Just hold on. Honorable Chair, I'm saying maybe I'll be listening properly now. I'm going to address this issue. Chairperson, the current status quo does not allow every South African to have the right of access of healthcare. I'm going to ask the question because you must indicate the issue and ask the question so that you are well understood by the presenter. And I'm saying again, this is within Section 27 of the Constitution. The state must take reasonable legislative measures to address the status quo, unequal status quo, two-tier system. And I gave example of this inequality, Honorable Chair, so that the presenter must understand when they respond to my question. For instance, number one, the private medical aid schemes, they are receiving 8% to GDP is a fact, and which is equitable to over 400 billion. Yet, and this cover only 26% of the population. Yet, some overawed 8%, 76% is not really receiving care. Are they comfortable with this skewed, unequal status quo to persist in the country? Lastly, the issue of intergovernmental relation. Do they want it to be the precondition? Because Honorable Chair, intergovernmental relation will be there post the act and before the act. As I said, it's not the fact. Do they want this to be the preconditions for NHI to be and multi-sector before to be implemented? Honorable Chair, my other question, I must say, Honorable Chair, and maybe if...
I'm really giving you the last question. I still need to make a ruling.
Now you can make a ruling. I'm giving it. I repeat the question that was misunderstood. Honorable Chair, in the previous presentation by Midi, I asked the question and they did not answer it. I want to repeat the question. And this time, Honorable Chair, I plead that HASA answer the question as they are in the same industry. Why is that their ambulances discriminate on the basis of an accident, a victim's pocket? As in the example I gave of me and my brother who were involved in accident. I was less injured. My brother was terribly injured. They attended to me.
We've had this question.
The medical aid, and they left. My brother didn't have medical aid. That effect is discrimination. Do they want to continue that status quo? Thank you.
Thank you very much. Honorable members, please behave yourselves. You would see that I am in charge of my meeting, that I allow the opportunities, and that I said that I would make a ruling after Honorable Munyai had concluded.
Chairperson,
I will give you an opportunity now, Honorable Sukacha. I see your hand is raised on the platform.
Yes,
Let me complete what I am trying to say. So I am saying that those members who shout from the side, including yourself now, Honorable Sukacha, but I would assume you were not aware that I had seen your hand raised on the platform. Let us refrain from doing these things, please. We should also be mindful that this is a live broadcast. We should be an example to the people of South Africa and all of the viewers and all of the people, especially in our roles as members of parliament. So just before I do that ruling, make that ruling, Honorable Sukacha, can you please raise your point that you want to?
No, I'm very sorry, Chair. I thought you are going to make the concluding remarks, and I was just careful before you make them. I want also just to make a point. Chair, I was just to caution members, in fact, Honorable Shirwa, I must just be very careful for grandstanding. I don't remember her making this point that she said she made. I still remember the committee, we as the committee called a meeting and we outline how our questioning and our way of asking questions to the presenters and so on. I think it's a committee decision. It's not her point that she has made. She should not come here and be grandstanding. It's a committee decision. I still remember we had our own meeting as a committee, and we cautioned each other to say that the way of questioning, we must just be careful when we question and interact with the presenters and the inputs that they are making. I just want to correct that one, not for grandstanding. Thank you very much, Chair.
Thank you very much, Honorable Sukacha. Honorable members, let me start with the one word that Honorable Sukacha used, the word interacting. Let us be mindful of our roles and our responsibilities. And if we're not certain, let us go and read up what are mentioned within the rule book. And then secondly, on decisions we had taken prior to this meeting. Let us also be mindful of what we say to members who come or people who come to present to us, so that we do not offend people or offend one another, but that in the context of that decision that was taken, as rightfully mentioned by Honorable Sukacha, we said that we will work with all people who come to present to us in a respectable manner. Thereby, I'm not saying that any member was now being disrespectful, but let us please be careful about the processes which we have to perform, the work we need to do, so that we do not find ourselves in a difficulty because we had not done our work correctly. So I would just like to caution us and leave it at that decision. Thank you very much. Honorable Clerk, please continue.
Honorable Chair, what was the ruling? On the
Honorable Munyai, the ruling is that we refer to the meeting where we had decided to be gentle and proper in our engagements with all the people who come to present, and that I said that does not necessarily mean that I am saying anybody has been improper or has not been kind to our presenters. But we take note of what has been raised also by Honorables Wilson and Chirwa, and especially Honorable Wilson, who then guided us by saying that she's hoping to have another discussion on what she raised at a portfolio committee meeting where we would be able to discuss that matter and not on this platform as we are now gathered here today. So my ruling is there will be another meeting to discuss these points which were raised in light of the previous meeting where we had discussed the engagements which we were going to have post that meeting. Honorable Clerk, can you please continue?
Thank you, Chairperson. In clause 11.1, it provides for the fund to investigate complaints against itself. What are your thoughts on this clause? What impact could it have on fueling the risk of corruption within the fund? And then what are your predictions on the vacancy rates at private and public hospitals once the bill is implemented? Thank you.
Thank you very much, honorable members, for all those questions which were raised. We note that we are taking a few minutes of the response time of the presenters of HASA. I note the hand of Honorable Munyai. Honorable Munyai, is that a legacy hand?
No, it's not a legacy hand. I wanted to make a follow-up, if you permit.
You're welcome. A follow-up question, Honorable Munyai?
Yeah, Honorable Chair, I want to ask a very simple question to the organization. They were indicating that they were challenging the role of the minister in their presentation. Do they think we need to change the constitution in order to change the role of the minister? Because there's no other way to change it willy-nilly through an HI bill. Thank you.
Thank you very much. So Honorable members, I would assume there is no other member who would want to raise any questions. Let me ask the presenters a couple of questions. And the one has to do with the limited fiscal space concern and the macroeconomic challenges faced by South Africa. I would want to ask them a couple of questions related to what they had raised. And the one is on the view. What is the view on the current cost escalation in the private sector, specifically in the industry? And would they consider these costs in the context of the GDP expenditure on private sector for 16% of the population versus the GDP expenditure in the private sector, in the public sector? And does an equitable healthcare system not offer better access to services to people from different socio-economic backgrounds? You have also recommended an additional role of voluntary private funding as opposed to funding for complementary services. What is your opinion on duplicative cover and meaning the funding from the NHI Fund for Comprehensive Health Care Services, including medical schemes funding for the same services? And would that not perpetuate the current inequities, thereby threaten the achievement of universal health coverage, which you say you support? And just to remind you that human resources for health in South Africa is also biased towards the private sector. And this is annually demonstrated through publication of density ratios by catchment population. Then also to ask you about your awareness of the Presidential Health Compact in terms of its recommendations, and on matters related to conflict of interest, direct or indirect, as proposed in your presentation. How does HASA intend to manage the possibility of conflict of interest with its members in the Stakeholder Advisory Committee? Those are all the questions which I wanted to raise. I'm just trying to, give me a moment. And then you raised 11 pieces, you mentioned 11 pieces of legislation, where I think you were saying that those sections were, or those 11 pieces of legislation were not considered when the objectives of the NHI bill were considered. And here I am referring to your slide 33, if you could maybe espouse on that. Thank you very much. You're very welcome to respond to all these questions. Honorable members, we are now running a bit late, and we will have to carry on until we have received these responses, and we will have a break after that until we then meet with the Western Cape government. Thank you.
Thank you very much, Honorable Chair, for handing back over to us to respond to the questions that have been asked by the honorable members. The members have raised a number of questions, and we will try to answer as many of them as possible. So the whole team will handle different parts of the array of questions that have been raised. From the start, Chair, I will take a few of those questions and then let the team to handle the rest of the questions. I would like to start with a very sensitive matter that was raised, sensitive and personal matter that was raised by Honorable Munyai. Just to say that no one wants to experience what he said he raised with his brother. And it is a matter that really requires a very proper interaction between him and his brother and his family, together with the, with the service providers involved. And in that respect, Chair, I would suggest that I undertake to facilitate that interaction to provide the Munyai family with the respect they deserve, and without being presumptuous, because there will be other factors that come into the whole issue that we will not be aware of in terms of the interaction at that moment on that day. And we would like him to get to the bottom of this. If it happens that at some level, there would, and I'm not saying that it does, there would be a requirement for an apology. That's what he deserved if he was wronged. So I just wanted to deal with that first. And then I want to just deal with a few questions that Mr. Honorable Munyai has also asked. In terms of the issues which I would put together under the envelope of the status quo, and whether we would like to perpetuate the status quo, I think we would like to state categorically that in all that is wrong with the status quo, from the funding side, we believe that the main cancer is the absence of risk pools. So we think the problem is that whatever solution comes, which is pragmatic, has to be underlined by a proper sharing of risk pool, the widest possible sharing of risk pool, which we have argued can be achieved through other mechanisms. And those mechanisms we have argued for, we feel they actually address the risks, because with any policy reform such as the NHI, there will be risks and benefits. And we can see the potential benefits of the model as it is proposed. But we worry about the many what-ifs that lie ahead of us. And we see the risks that go with those. And hence, our proposal is that we need to move away from this status quo, but it is important that we define what it is that is wrong with the status quo. Is that there is no sharing of risk. It's too fragmented. We are anti-fragmentation. We are pro-risk pool sharing. On the provider side, as again, we were at pains to explain in our presentation, we would like the public and private facilities to be treated equally. And we would like them to provide a similar quality of a set of services to both the public and private patients. Sorry, let me correct that. A similar type of service to all patients that come through their door, without discriminating about their status in society. And we would like them to be accessible to people from all walks of life. That's what we are advocating for. So we categorically would like to state that we do not want the perpetuation of status quo. We think it is not right, as I have explained. And then the issue about okay, I was just going through my notes. I hope one of my colleagues got the point about the intergovernmental relations. You made a statement, but I didn't quite get the question. And I think a lot of the questions that have been asked do seem to be cross-cutting between the honorable members as they had asked them. At this point, I would like to hand over to my colleague, Melanie Da Costa, who will later hand back to me on some of the questions that she hasn't covered. She will cover most of the questions, and she will hand back to me the ones that she will not have covered, or to the other members of the team. Thank you.
Thank you, and thank you so much all members of the committee for your questions. I think it's important perhaps just to start with some of the overarching topics. And Honourable Sokacha, you asked about us recommending the retention of the status quo, and that is the furthest thing from what we're saying. We're saying that we fundamentally agree with the introduction of a fund that, and I think we stressed it 2 or 3 times in the presentation, we have found by the introduction of a universal healthcare fund, it does allow for the purchasing of services from private providers as well as public, and we think that that goes a long way to closing the gap. In terms of medical schemes, we're actually highlighting that, exactly as Dr. Bomela has mentioned, that the social solidarity principles are absolutely important. Including them in the broader framework is the recommendation we're making. So just to be clear, we are recommending the purchasing of services to the extent that the fund is able to from public providers as well as private providers. We are recommending that for primary healthcare, emergency services, as well as hospitals. For hospitals, we're acknowledging the pragmatic view that this might come later on with respect to private hospitals. And then with respect to medical schemes, we are specifically saying we think they have a role to play in order to ensure that there isn't a concentration of risk. Remember, we don't know for certain. Either way, we don't know. But it's how would you structure a system that it is sustainable? And given the lessons that we have banked with COID, with RAF, and other institutions in South Africa, we think that that uncertainty is a fair statement. We don't think it is an unwarranted statement. In terms of certain other questions, on the Presidential Health Compact, yes, Chair, an honourable, I think another honourable member asked the question. We participated very thoroughly in it. There were reams and reams and reams of recommendations. The one thing that we have learned in strategy is if you could summarize it in 5 to 10 points, it's much better than hundreds of points. But yes, we are aware of it, and there are just a lot of pieces of work. So we appreciate the time that this might take, but more importantly, we're at the table, and in any way in which we can learn or provide assistance, we will do so. Honourable Geller, you asked about Section 55. I think the reason why we flagged Section 55 was actually just acknowledging that perhaps private purchasing from private hospitals would come later. I think it's explicit. So I think we're acknowledging that. And then reference to that, Honourable Chair, you asked us about the Omnibus approach, and I think you concluded that we felt it hadn't been considered. I think what we're saying is it should be reconsidered, acknowledging this phase-in approach. I think that is all that we're saying. I think we're acknowledging that there could be some unintended elements that when the NHI was being envisaged, perhaps it overreached, thinking that it would be a shorter time frame to get to all of the catastrophic type cover being purchased from public and private providers. We think it needs to be reviewed just to take the phasing into account. Honourable Harvard, you mentioned the iterative approach, and Chair, if I may, and as mentioned in the presentation, it's a very comprehensive piece of work that BUSA did on this, and BUSA obviously is a collaboration across all the healthcare providers. This was put to NEDLAC, but we think it would be better if we send you a documented version of that, if you're comfortable with that. I think that that Dr. Bomela has covered some of the questions, Honourable Munyai, and I just want to reiterate, certainly our experience that what your experience in that event, I would argue is unusual, and I know it's hard to take my word for it. I work for Netcare, And we have seen tens of thousands, and we have it very well documented that, we have, it's very unusual, your experience, and I think we just acknowledge that would have been a terrible experience to be had and support the recommendation of getting those details and following up on that. Let me just see if I've covered all the other questions. Honourable Clerk, I think there's a question with respect to complaints and the fund itself reviewing these complaints. It's not an area of my particular expertise, but my learnings have been the segregation on governance is absolutely critical for any organisation. So I think segregation in terms of governance is important. In terms of the vacancy rates, I am going to ask my colleague Neben Zwaiba to weigh in on this. And I just want to note one additional question with respect to the impact of certificate of need, and we'll hand over to Clara Finley. Thank you.
Thank you very much, Mel. Honourable Clerk, with regards to your question around the prediction of vacancy rate across the system, I'll refer to the study that we as HASA conducted last year in collaboration with the National Department of Health. The study actually predicts that the gap will widen to about 178,000 nursing professionals, more specifically, by 2030, if we do not ramp up the production of pipeline. Currently, we produce about 3,000 qualified nurses per annum. In order for us to catch up and make sure that we do not find ourselves in that predicament by 2030, we would need to increase that substantially to about 20,000 per annum. Thank you, Mel.
Honourable Chair and committee members, let me pick up on the certificate of need question that Melanie referred to. I think just to set the context of that, draft regulations in terms of the National Health Act on certificate of need were published during the course of last year. And those draft regulations impact a myriad of healthcare institutions. It covers health agencies and it covers health facilities, which is every single kind of possible facility in both the public and the private sector where healthcare is rendered. So it is everything from a very small primary healthcare rural clinic, a general practitioner hospital, right up to maybe a multidisciplinary private hospital or a teaching hospital in the public sector. So it is a huge number of facilities that are affected by the draft regulations. HASA submitted comprehensive comments, as did many of the HASA members, to the National Department of Health. I am not aware of any further developments after that. We have requested to engage with the National Department of Health on the point, but it certainly is an aspect that needs to be debated and considered very carefully, considering the number of role players covering both the public and the private sector, to ensure that whatever the end result thereof might be, that it will be effective and useful.
Thanks, Clara. Chair, I just acknowledge that I did miss potentially two of your questions, and I might need a repeat on your last one. The one you did ask was about the escalation in private costs, and so basically the spend on private versus public. So on that one, we acknowledge that there is this variance. We further acknowledge, as stated in the presentation, that our absolute spend is low versus the outcomes we'd like to get, relative to the OECD. Even the private sector costs per capita benchmark well or below, comparator countries offshore. And I think that was well documented in the Discovery presentation yesterday. But notwithstanding, we think the introduction of a social solidarity platform with a common risk pool, basic NHI benefits will go a very long way. I also want to state that from a provider perspective, a hospital provider perspective, we feel that if there's an equal playing field with public hospitals, that we actually can compete well. I think we spoke to the structural higher costs, be it due to tax in itself, which was 43%, due to SEP, etc. I think if that wasn't in play, that we would compete well. You might not be aware, but it's important to stress that some of the low-cost medical schemes actually have rates that approximate that of government's UPFS. So I think the devil is in the detail, and if you wish to get more information on that, we can certainly share. Chair, I think you had another question, and I think I might have missed it. If you wouldn't mind repeating if we've left anything out. Thank you.
Thank you very much. The other question was with regard to the voluntary practice funding as opposed to funding for complementary services. And I wanted to know what your opinion was on duplicative cover. And then secondly, whether that would not perpetuate the current inequities, thereby threatening this achievement of universal health coverage, which you say you subscribe to, and that the biasness of human resources for health towards the private sector, and what your view would be on that. That was the question. Thank you.
Thank you so much. Thanks, Honourable Chair. So I can understand the fear up front. I think we must just acknowledge that just opening up the purchasing of services between public and private, even in the United Kingdom through the NHS, took great strides in incorporating the provider base in the private sector into the system, and acknowledging all the capacity constraints. We think that that will go a long way in terms of closing the gap. We acknowledge that in an ideal world, you would go with a single fund that is fully funded, and that we can raise the taxes that replace what the private medical schemes have raised. We think that practically we've got to deal with the reality that we might just not be able to do that. And as the NHI strengthens, at least you have the certainty of cover. But what we have found, even in the UK, when we saw the financial crisis of 2008 into 2010, we actually saw quite a massive fall in private medical insurance, because by that stage they had several years of the NHS purchasing from private, and because of affordability constraints, no rational person will go and purchase if they are comfortable with the service that they are getting for free. So we think that a strong NHI will naturally crowd out private medical insurers without it needing to be outlawed. In terms of just the shortage of skills, that is something that we do acknowledge. We think that opening up the purchasing for private GPs and private specialists will obviously go a very long way, and our focus really needs to be how we get private medical schools into play. And and we're not saying that it's private hospitals that would be running this, but it could be Harvard, it could be some of the Indian universities, but certainly accrediting private hospitals to continue in that journey together with public academic institutions, we see as 100% foreseeable and doable. Thank you, Chair.
Thank you very much, Dr. Bomela. Are you done with all of your responses?
Yes, we are, Chair.
Thank you very much. I was busy typing a little chat to you, and I asked you whether I should address you as Dr. or Miss Melanie da Costa. One of the members, Miss Asina Ismail, who has lost a connection, would like to have your contact details. So I was busy typing it, but I might as well mention it now, so I'd not be able to complete that task.
Can you facilitate that through the committee
secretary? Yes, thank you very much. We appreciate you coming to do the presentation today. As I said earlier, we also learn, and I'm hoping you also learn from us, but we will take the processes forward as the Portfolio Committee on Health. And yes, maybe if you want to say a few last words, Dr. Bomela, before we will then close for lunch.
Thank you, Chair, Honorable Chair, and thank you to the honorable members as well. And again, may I observe that the Hospital Association of South Africa has been deeply engaged in the national health insurance throughout its evolution, Chair. And we have contributed research to the white paper and the green paper and the policy documents that have come out. And we have hosted Ministers Motsoaledi and Mkhize in our conferences in that ongoing quest to engage and get to learn more what can be done, what needs to be done, how can we contribute. And most importantly, to support the reforms that are taking place to increase equity and access and equity in healthcare. And we have hosted government departments, and it's an ongoing task, interactions that we have. And therefore, we are thankful for this opportunity once again to share our thoughts and ideas, and generally to make the contribution to ensuring that every citizen in our country is able to access the care that they seek. Thank you so much, Honorable Chair and Honorable members of the Portfolio Committee.
You're very welcome. Honorable members, we are going to take a break. Fortunately, we had one of the groups who had to present to us not being able to make it and asking for a postponement. We will be back at 15:45, 3:45 on the platform. I would advise you not to log out if possible, but to make certain that we at least log in at least 5 minutes before the time. If you do log out, maybe even 10 minutes. And again, Dr. Bomela, you and your team, you're welcome to stay on, or you're also very welcome to leave the platform. Thank you, honorable members. Enjoy your lunch.
Recording stopped.
We are hoping to have fruitful engagements and representations from those who will be coming to present to us for the afternoon. You are all very welcome. Any new people who have joined our platform and our meeting, you're very welcome to our meeting. And we will now continue. I have seen the MEC of Health of the Western Cape on the platform. I am not certain who is leading this delegation for the Western Cape government, who will do a presentation on the NHI bill to the Portfolio Committee on Health. And we'd like to start immediately, honorable members and those who are to present. So honorable, who will be leading yourselves?
Afternoon, Chair. Good afternoon, honorable members. Thank you for having this opportunity. My name is Noma French Mbombo, Dr. Mbombo, MEC for Health in the Western Cape. With me, the HOD is on leave. With me is Dr. Krish Valabji, who's the Chief Director for Strategy and Support. And I'm sure there might be others who might have joined from the department. He's the one who's going to lead the PowerPoint presentation, but I will start with just a preamble and then we'll take it after the presentation. Noting, Chair, that our presentation is very short because we already submitted our input, I think, 2019. So what we have done is to summarize so that we allow the members to engage, because this is an opportunity we wouldn't want to miss in regard to having this conversation. Thank you, Chair.
Thank you very much, MEC. You're very welcome, and your team. We can go right on. You can start your presentation.
Okay. Thank you, Chair. Whilst Dr. Valabji is preparing the presentation, just a preamble. In South Africa, we need to acknowledge the fact that our health system in South Africa is quite fragmented with the issues of the access to the quality services. We find that it all depends mostly on who has got, who can be able to afford. Therefore, the issue of health as a human right and a social investment, it means that it just becomes a dream in some instances, because it has been now turned into a commodity. So therefore, the universal health coverage is a must for the South African community. What does it mean? It means that access to the quality services from the preventive, promotive, rehabilitative, palliative, subacute, and every aspect that is crucial. So it's long overdue. For some of us who have been in health quite longer, those who are health professionals, it becomes exciting that at least we do some light in regard to the health reforms. So therefore, South Africa does need a health reform quite urgently before the systems collapse. With the NHI, for Chair, just in case probably some members might not be from the health space, don't know that this has been actually a history that has been there. The first phase of the NHI, it was 2012 to 2017, and there was an evaluation of the report in 2019. For that period, it was specifically to test the health system and using about 10 areas related to the primary health care.
Sorry, MEC, I just want to, because your people will then struggle, I just want to say to our committee secretary, there's a request for screen sharing. So I'm sorry about that, but that's in order to save time. You can continue, MEC.
Thank you, Chair. I think Dr. Sadiq Karim was the one who was asking for the sharing. Is a DDG, is also Chief of Operations, who's acting HOD. Thank you for that. So I was saying, Chair, that the history of the NHI, it doesn't start now with the legislation. It starts way back with the phase one, HNHI phase one, 2012 to 2017. That was focusing on strengthening the health system, focusing on 10 areas or 10 streams. Among the streams, if I could just list quickly, It was about a ward-based primary healthcare outreach teams. It was about the school health program. It was about GP contracting. It was about the ideal clinic realization and the maintenance model, the district clinic specialist team, which is I was one that I was focusing on at the time that I was advising the Ministry of Health before I became a politician. Centralized chronic medicines dispensing and the distribution, the health patient registration, which is the health records, the 8th one, stock visibility system, the 9th one, infrastructure projects, and then the 10th one is about human resource for health. And from the evaluation that happened there, it was about that when now the country starts the phase 2, because at the time, the decision was about 3 phases to start the phase 2. Lessons learned from the phase 1, it was about for successful implementation of the NHI, there should be clarity of the vision, and we should be able to set appropriate priorities, and also it's crucial that there is an element of accountability. And also for the NH2, which is where we are now, supposed to have started 2019, 2022, which is now the NHI, which is the bill. It also speaks about to ensure that we protect the public sector, especially in regard to their resources, and also about the implementation. So now in the NHI2, which is about the bill, what you are coming with the Western Cape is about there's no way, there's no person in South Africa, specifically within the health system, who could be against the health reforms in South Africa. Because at the end, as a public, we absorb quite a lot of the social ills, but as yet, in terms of the budgeting, it's skewed. As I think some of the members did indicate, the issue related to the GDP that is being allocated, but noting that some of the problems that have been, because I've been here since the presentation by the private, is because of we have never had the regulation that could be able to regulate and how the private should be able to work on. And with the National Even Health Act, when it was started, it wasn't repealed because the province can still use the 1977 National Health Act. So going forward, Chair, the One Health system with a multiple entries in order to be able to look in terms of the needs and also the choices is just one way that the South Africa could be able to assort these fragmentations. And also the issue of the NHI in regard to ensuring that we leave no one behind. The triple HU, which is the accessibility, availability, affordability, and the quality of care. These are very crucial. And also that notion, Chair, that talks about the affordability, because sometimes you find people where they say that because I've got, I can afford, therefore I could be able to drive a jet and all of those. But one needs to understand that the poorest, which are the ones that are actually most absorbed by the public, they also do contribute tax-wise. I'm mentioning this, Chair, because NHI 3 is about the taxation, which is going to come after probably 2024, 2025, if we're talking about the whole of this issue. So going forward, as the Western Cape, we do approve and also condone and also accept the universal health coverage. However, the NHI, we don't see it as the way it's seen, as much as that the principles have been indicated there. Because the issue of the balancing, the funding, because it's just like insurance, it's insurance. Insurance, you can buy a beautiful insurance, but what are the guarantees in terms of getting what you want? Because you don't want to be standing aside the road where the car cannot be fixed because of the ABCD of the insurance. So what we believe in this format, it will have a huge dire negative impact on the provinces as a whole, not only that in terms of the purchasing, but also in terms of the whole issue of the stewardship. What we believe is about gone are the days that now we have to create binaries and coming with these narratives that polarize, talking about the public versus the private, or the national versus the province, because at the end, we are the one health system. About 24, 26 countries have implemented the UHC. Before we had COVID, actually, some of us with a trip that was arranged by the National, we went to Thailand, which is similar in every respect with South Africa, and there's yet the amount they pay per capita in regard to health is quite more or less the same, but the returns on investment is quite large. We are grappling with the issue of the quadruple burden of disease, and as yet we find that many people are outside the health system. Lastly, Chair, personal level, the social determinants of health that are not being mentioned in the NHI bill. It's quite a discomfort, because at the end, we cannot only focus on the service deliveries in terms of subacute, when the social determinants, which actually what is being absorbed by the health, I'm talking about the issue of the poverty, the issue of the unemployment, equity, but specifically in regards to the environmental aspect, which is the access to water, access to sanitation, that is being absorbed by health. So with that, Chair, the team will present. It's going to be a short presentation, but they're focusing on the policy imperatives related to the procurement and also and other parts of it in terms of the strategic purchasing. And then we come up with a proposal, and then I'll take it from there. Thank you, Chair. I will switch off my camera.
Thank you very much, MSC. I don't see your presentation yet. And Dr. Karim, you are welcome to continue.
Chair, I think Ms. Isaac is starting the screen share. But just from my side, it's myself and Dr. Viability. Apologies from Dr. Kluti, who's on a well-deserved break as you on. You just put my video on at least. I think that would be proper decorum. Dr. Kluti, who's on a well-deserved break. Dr. Viability is going to do the presentation on our behalf, but we've obviously had lots of discussion in the department, and as Minister said, she's very well versed with all the issues. So over to Dr. Viability, Chair, with your permission. Thank you.
Thanks very much, Dr. Karim. Good afternoon, Chair and honorable members and colleagues. Just I'm Krish Viability. I'm the Chief Director for Strategy from the Department of Health. We want to approach this in a very succinct way because we've submitted very detailed comments previously. So this is a high-level summary. Next slide. So we would just pass some introductory remarks. Then we want to focus on the policy concerns regarding the bill, and then our proposed approach to UHC and the NHI, and then end with some concluding remarks. Next slide. So South Africa as a country and the Western Cape as a province have both strongly endorsed the UN approach and the global movement towards UHC. UHC is an approach to advance health equity by removing the barriers to access, quality of care, and removing financial hardship. And those are the principles that we firmly endorse. The strategic intent of the bill to achieve these principles of UHC is completely supported. However, there are specific concerns on the architecture, the distribution of roles and responsibilities, financial flows that need to be addressed. The comments that follow are intended to be constructive, to strengthen the bill, and really to promote a collaborative effort between government, national government, provinces, civil society to achieve the goals of UHC. So like I said, the province has submitted very detailed general and specific comments on the bill, and this presentation covers only a subset of very high-level comments owing to time constraints. Next slide. So as we know, in terms of a problem statement, in the private sector, the access and unsustainable cost escalations are underpinned by severe market concentration and fee-for-service incentives. And these are often perverse incentives for over-servicing, etc. And that's the nub of the challenge in the private sector. In the public sector, the access and quality challenges are underpinned by funding shortfalls, lack of good leadership and management, and governance systems in the main. And those are the kind of twin challenges of the public and private sector. What does the bill intend doing? So the bill establishes the NHI fund and its governance structures. It outlines the committees through which the NHI fund will carry out its functions. And it also provides an overview of the management officers, including the procurement of health services. It partially refers to the role of provinces and the National Department of Health, and I'll speak more to that later. Next slide. So what are the policy concerns regarding the NHI bill? And like I said, 83 pages of very detailed comments have been submitted. So this is very high level. And to cluster these concerns under the following headings: fragmentation of care, role of provinces, financial flows, strategic purchasing, the Office of Health Products Procurement, the governance of the fund, and social determinants of health. Next slide. So let's start with fragmentation of care. And the format, Chair, I'm following is really just to outline what the concerns are with the provisions in the bill and then what the proposal is. So if you start with fragmentation of care, in the bill, there's a creation of district health management offices and contracting units for primary care as national government components, right? And this will fragment the health service. The NHI and these government components, the Public Service Act actually says feasibility studies need to be undertaken before pronouncements could be made on government components. And as far as we are aware, these have not been undertaken to date. The NHI fund directly contracting with regional and large hospitals. So this would be directly from a central fund nationally, directly to the facilities themselves. The central hospitals would become a national competence as provided for in the bill. So we think that these provisions would really fragment the health service. And our proposal is that the NHI fund works with provinces to develop a single cohesive aligned system with clearly defined roles and lines of accountability for performance, aligned to the principles of UHC. In the province, we have spent the last decade or two trying to build a cohesive health system. You would recall over the last decade or two, primary healthcare in the rural space has been provincialized. TB hospitals that used to be run by local government and Santa have been taken over by the province. EMS has been provincialized. Forensic pathology that used to be run by the police services have now come over. So we've been building this cohesive health system over the last decade or two, and we fear that the provisions in the bill will start to mitigate against this cohesion and start to fragment the system. Next slide. So the next aspect of fragmentation is central hospitals. So the bill makes provision for the management of central hospitals to become a national competence. Now, our estimation is that almost 44% of secondary general specialist services in the metro are provided for in the central hospitals. There is significant outreach by specialists from the central hospitals across the platform. So this will fragment both the service delivery platform and the training platform and governance arrangements in the province. We do not believe that the changing the governance arrangements of central hospitals is necessary to achieve the policy objective of the bill. So the rationale for this policy change is unclear. Furthermore, the track record of this province, the Western Cape, shows that these central hospitals are well-performing institutions. So that's further reason to not change that arrangement. So our proposal is that the central hospitals continue to function under the governance of the provincial departments of health. Next slide. So then we move on to the role of provinces. Under the NHI bill, the role of provinces is limited to emergency medical services, forensic pathology services, environmental and pollution control services, which are municipal functions, health and medical services during provincial disasters only, and maintain infrastructure. This is a significant reduction in the scope of work and the powers of the province from the Constitution, from the 1977 Health Act, which the minister referred to, and this was assigned to the provinces. So to all intents and purposes, it has the weight of provincial legislation and has not been repealed to date. The current National Health Act and the PFMA. So that we see this as a significant reduction in scope and powers. So the bill refers to provinces as management agents of the NHI fund, but the delegations and responsibilities of provinces are unclear. Next slide. So the proposal is that UHC can be achieved through a strong collaborative partnership between the NHI fund, the National Department of Health, and provinces. Provinces should be accorded a clear role where they have the capacity and track record of good performance to become the NHI fund's contracting unit and responsible for the overall coordination and accountability for health system performance. Funds should flow through the provinces, who will then develop and manage contracts with a mix of public and private providers. As you see in the graphic there, so the NHI fund works through the province, who then contracts with a range of providers, public and private. The National Department of Health and the provinces should be co-stewards of a trusted health system with clear lines of accountability aligned with the PFMA and the current NHA, which is both in place, and therefore this enables our movement towards the objectives of NHI and UHC, and we can achieve those objectives. Next slide. Financial flows. So the reallocation of conditional grants and redirection of equitable share to the NHI fund is a concern. Public sector health budgets have been reduced in real terms over several years, and services are in quite a fragile state. There is a separate process being undertaken currently, which is a revision of the provincial equitable share formula. And in that process, further cuts are envisaged to provinces like the Western Cape and Gauteng, right? So these are real concerns. So the proposal is that the current funding arrangements, namely the equitable share to provinces and conditional grants, should remain in place. The NHI fund should use tax subsidies from the private sector as a top-up fund in the initial stages of this process. And the public sector that services more than 80% of the population should be protected and strengthened. Next slide. Next slide, Afika. Okay, so then we go to strategic purchasing, right? The bill proposes that the NHI fund is a single strategic purchaser. Now, the dangers of vesting the total strategic purchasing power in one entity are as follows. Firstly, poor performance will have a multiplied effect across the country. Failure to conclude contracts timeously will lead to national stockouts. The NHI fund may struggle to find sufficient suitably qualified and skilled staff to carry out these functions. And the large financial exchanges will make the NHI fund a target for corruption. So those are some of the high-level risks in having a single strategic purchaser for the country. Our view is that the strategic purchaser is critical to achieve universal access to quality healthcare, negotiating prices, using economies of scale for commodities procurement, as well as the setting of tariffs to be paid to providers of services will be an important function of the NHI fund nationally. However, determining what services are to be reimbursed by the NHI fund and the actual purchasing of services to meet people's needs and expectations must be decentralized to local settings. It is therefore recommended that provinces should also play an important strategic purchaser role in this regard. The Office of Health Products Procurement, so Section 38(2) of the bill deals with the establishment of an office for health products procurement to be located within the NHI fund. And again, healthcare is incredibly complicated, and the ability to manage health-related procurement at a national level requires significant administrative capability. The challenges to manage pharmaceutical contracts is a case in point, and it has had ripple effects across the country when this is not procured in time or tenders are not awarded, etc. And this raises concerns about the ability of the fund to manage the proposed national procurement system and the wisdom of centralizing all procurement. So we therefore propose that when this bill is enacted, sufficient and appropriate staff, systems, and processes are put in place before attempting to centralize the procurement process. Then the governance of the NHI fund. So considerable authority and power is vested in the Minister of Health. Now, to appoint or dismiss all NHI board members, recommend the appointment of the NHI fund CEO and his or her dismissal, as well as to add a discretionary list of services to the NHI formulary. And we think that's considerable authority and power vested in a single person. The proposal is there should be appropriate checks and balances applied to the governance of the board, the appointment of board members, and the CEO, including parliamentary oversight. And then the last policy concern is social determinants of health. So the health services sector is almost the receiver of health problems caused by social and commercial determinants, such as poverty, unemployment, social deprivation, various trade issues, etc. So the bill does not mention addressing the social determinants, but focuses only on direct service delivery. Now, our proposal is that we have to, as a health system, address the burden of disease and the social determinants of health. And this should be made explicit, and health at both national and provincial levels have an important advocacy and stewardship role to play in this regard. So that, Chair, is the summary of policy concerns around the bill. And now I want to move to our proposed approach to UHC and NHI. Next slide. So our approach is that health is an important economic investment with a return on investment close to sixfold, and that figure has been internationally quoted. The current dysfunctionality of the public health service and the unaffordability of the private health service is just unsustainable. So we, as the minister, as the MEC has said, we do need health reform and significant health reform at that to address these twin challenges. The fragility of the situation, including budget cuts in the public sector, are close to a tipping point. So we need to be very careful in terms of reducing public sector budgets. The stakes are high and requires us to move beyond the political divide. The situation therefore requires more than tinkering at the margins. It requires a transformative solution of doing business differently in very fundamental ways. It requires more than a financing mechanism like the NHI, which only addresses a thin slice of the health system problem. And we require a much more robust, holistic health system strengthening approach to finding solutions. And the current debate on the NHI provides an opportunity to find transformative solutions to the health system. So suggested principles for our approach: we think the pooling of resources from the private and the public sector with the shared goal of improving population health outcomes is an important one. Let's engage in a spirit of cooperative governance and collaboration and avoid the narrative of polarization, like the MEC has said, that polarization being public versus private or national versus provinces, etc., that only escalates fears. And how do we cooperatively and in a collaborative manner engage and jointly find solutions? The NHI bill will be up for review, and we use this opportunity to re-establish mechanisms for robust engagement and joint problem solving as a social compact to address all the concerns in the bill. The health system reform process worldwide is a complex, ongoing process that is both technical and political. Global experience shows that we have to customize lessons from elsewhere. We cannot merely import solutions from other countries. We have to customize it. We have to carefully titrate the health system design choices we make to our local context, local conditions, and our local capacity for change. It has to be calibrated to our own strengths and weaknesses in keeping with our own state of development. In this regard, we need to be mindful of the differing capacities and track record of health system performance between provinces. So not all 9 provinces are on the same page or at the same level of development. And therefore, we need to be very cautiously titrating our solutions to these varying conditions across the country and the need for further customization even between provinces. Next slide. We need to have a holistic health systems approach that spans service redesign, governance redesign, and public policy. And it needs to be based on a culture of connectedness and collaboration, both internally to the health system as well as externally with our partners in the private sector, the higher academic institutions, and business sector, civil society, etc., towards building UHC and achieving optimal health outcomes. The affordability and financial flows, and I've not discussed this much, but very important issue within the NHI framework should be pronounced upon by the National Treasury. And there's been various perspectives about the unaffordability of what's on the table, but we think the National Treasury should pronounce on this. Create opportunities to learn from below. And the Western Cape is prepared to be a laboratory for testing innovative service models which can further inform policy development in our context. We want to strengthen our collaboration with other provinces to share and learn from each other. And we believe this learning approach is the way to take this process forward. Next slide. So in conclusion, Honorable Chair, the Western Cape government would like to thank the committee for the opportunity to provide comments on the bill. The bill is an attempt to bring a solution to an ailing health system in the country. And there are elements in the bill that make a lot of sense, but then there are also concerns that need to be addressed. Learning from our responsiveness, adaptivity, and innovation during the pandemic over the last 2 years, as well as the research and development, will strengthen and build, help us build a resilient health system for the whole country. And we must take the experience of the last 2 years into account as well. So like I said previously, we are willing to become a laboratory for testing out aspects of UHC within the province. We're very committed to working with the National Department of Health to address the challenges we've identified and collaboratively find workable solutions. We believe in the country, we have the collective expertise to do this between ourselves in the provinces and local government, as well as our other partners in the private sector, universities, etc. Thank you very much.
Thank you, Dr. Valabji. I'm not sure whether is there any input from Dr. Karim before we give it back to the chair and then wait for the responses, for the questions or input from the members.
No, thanks, Minister. Dr. Valabji presented our views, Honourable Chair and members. Just one small point. During this pandemic in the province, as perhaps in other provinces, there were many innovations that we brought about during the pandemic that, in fact, if one looks at it over a longitudinal time period, will in fact take us towards UHC in the province. This is not a COVID conversation, but the number of those innovations, in fact, will strengthen the resilience of the health system in the province towards UHC. Thank you, Chair, and thank you, Minister.
Yeah, thank you, Chair. Just to add what Dr. Karim has indicated, also in terms of even working with the privates, using COVID as an opportunity in regard to when we have to work around the bringing in the critical care or high care spaces, just in case we might need those.
and also even in regard to the innovations in relation to those, for us as a public, having like a robotics as part of the fourth industrial revolution in regard to medical care. We have to learn more from the private, not necessarily that the public doesn't know, as you know, Chair, as a health professional yourself, that we get professors in the public. And also it's only the public that trains medical doctors. And then once they are done with the specialization, then they go to the private. So what we're trying to highlight is that it doesn't mean that when we are saying we're learning from the others, it's about the others, they don't have the capabilities. That is a whole issue about the resources. So just to give more time, Chair, for the questions, I will leave it to that. Thank you.
Thank you very much, MEC, and to your team for your presentation here today. We have listened very carefully, and we also note that the members would like to raise some questions with you. We would have to take those questions in the following order. Honorable members, first will be Honorable Ismail, followed by Honorable Chirwa, Honorable Clark, Honorable Siwela, Honorable Gela. Any other hands, honorable members? Honorable Howard. Any other hands before I'm going to close this opportunity? Thank you very much. We can start with raising your points with the delegation, and we start with Honorable Ismail. Thank you.
Thank you, Chair, and good afternoon to the panel, and thank you for your thorough presentation. I just have a few clarity-seeking questions. I'm sorry if I'm asking a question that has already been covered. I've had a connectivity problem. My first question, what are the reasons that you recommend that the governance of specialized hospitals should remain with the province? My second question, in your opinion, does the bill address social detriment of health and preventative strategies? Now, what would be the implications if these items are not addressed? And if we need to address these items, what would you recommend be specifically specified in the bill? My third question, you highlighted oversight. Now, this is very, very essential. Do you recommend the private sector be included on the board to improve the accountability and legitimacy of the board? My fourth question, under the bill's current governance and organizational structure, in your opinion, what is the state of risk corruption? How strong are the accountability measures in the bill, and what would be necessary to be included in a bill to countermeasure this? My fifth question, to what extent does the bill allow for equal access to quality healthcare? You mentioned a few lines on this, but in your opinion, is this an all-inclusive bill? And how sustainable is this bill in its current form? My last question, do you think with the current state of the bill, if it's not amended, do you feel that we will lose a lot of healthcare workers, in the system? I mean, do you think we will have a lot of our healthcare workers moving abroad? Thank you, Chair.
Thank you very much, Chairperson. My question to the Western Cape is, I want to know what kind of collaborative efforts do they envision between national and provincial? Because I think the roles of the province are encapsulated in the bill, but I want to hear from them how exactly they envision and how it could legitimize the bill. Like what roles would be allocated to the province that cannot be done by national, or that would cause a crisis in the provinces? And please appraise us with in detail and not philosophically as the presentation is done. And secondly, I want to know how the Western Cape has made interventions to deal with infrastructural inadequacies, because you note that as some of the backlogs or challenges that we're facing in the NTOH example, but I mean, these are challenges that can also be found in the Western Cape as well. And I give an example of Khayelitsha District Hospital, because we did oversight there, and the community it services has grown by millions in the past years, but this isn't mirrored by the facility and the work that has been done to grow the facility to cater for the needs of the population that has grown by millions over the past years. I mean, the staff also raised this concern at the oversight that I'm speaking about, to which It affected services like occupational therapy, which is vital for children and kids within the autism spectrum, right? And second to that, the clinics in township and rural areas don't necessarily function at a 24/7 basis. And that's not the direction that the province is taking either. What is this leadership intervention that the Western Cape asserts is lacking in national that they have mastered? And why hasn't it resolved these structural issues that directly affect the communities and their health needs? Please give us tangible examples of how of the mastering of this leadership capacity that you guys have that the rest of the provinces don't have, and how it has changed communities, and counting even the communities that I'm counting the fact that already you have failed to address those structural needs in those communities. Thank you, Chairperson.
Honorable Clark.
Thank you, Chairperson. In your inputs, there is mention that shifting funds from the equitable share of provinces will negatively affect integrated, intersectorial connected service delivery. Can you elaborate on this point? What reasons will a shifting of funds result in a degradation of service delivery? What are the implications of the changing role of provinces on service delivery with regards to healthcare? The bill intends to dilute the role that provinces currently perform in terms of the NHI. In your view, how will this impact quality access to healthcare services? What challenges do you foresee with this shift? Thank you.
Thank you, Chairperson. And I've got questions to the Western Cape government. My first question is the Western Cape government main concern the change in the role of the provinces? The bill states that provinces will move from purchaser and provider to become a delegated provider with stewardship of the public services. This, according to clause 32.2, is to allow functions to follow funds in creating a single fund NHI. Please clarify what is your concern, especially the establishment of a central fund. The second question, Chair, is the presenter seems to assert that setting up the NHI fund as a strategic purchaser is risky, and it is better to continue with the current fragmented system. What is the motivation behind this assertion, given that the fragmentation has not helped to address the health needs of the population? Thank you, Chair.
Thank you very much, Chairperson. Chairperson, let me thank the MEC and the Chief Directors for the presentation. Just two questions from my side, Chair. The first one is the Western Cape government comfortable that some populations in provinces where there are no access to central hospitals care continue to not have access to the services in these national assets, as we know that the central hospitals are largely funded from the conditional grant. Then my second one, Chair, is currently the Northern Cape, which is my own province, and the Eastern Cape depend on the Western Cape Department of Health to access some of its services. Now, I'm just interested, Chair, what is going to happen one day when the Western Cape province start to deny citizens from provinces without quaternary services when they need such services? Can I please have a comment from the team? What is going to happen one day when the Western Cape denies them those services? Thank you very much.
Thank you very much, Chair. Let me also welcome the presentation from Western Cape. Chairperson, I've got a few questions that I want to ask. The first one, the presentation from the Western Cape gives a sense that They support fragmentation that is constituted of 10 departments of health, each working independently as a universal model. My question to you is, how does Western Cape expect to achieve equity in the country by maintaining the system? My second question, Chairperson, the presentation appears to assume that none of the public hospitals will be contracted service providers under NHI. May I get some clarity on this particular? May I get clarity? May I get some clarity on this particularly in as far as the presenter's views, which suggest that hospital service will only be limited to emergency medical services. What informs this position from Western Cape? My other question, Chairperson, your presentation has alluded to the WCDOH as a province that had innovations during COVID. Can the presentation confirm if these were not nationally integrated and managed together? And is this not what NHI will achieve if the whole country works together on one system? Lastly, Chairperson, with regards to the proposal made by Western Cape and concerns raised with respect to the centralized procurement processes, what does the Western Cape believe is the best way of amending the bill under Section 38? Thank you very much, Chairperson. Lastly, Chairperson, I know that during our visit to Western Cape during the NHI public hearing, people were complaining that Western Cape government were misleading people regarding the NHI processes. So, Sis French, benifuna uyazi ukuthi kutheni lento benilahlekisa abantu bakuthi sithi siza nebhili enje right for abantu bethu ukuthi bonke bakhona ukuthi bafumane ezempilo ngokulinganayo, but nine Western Cape nithathe eyenu indlela as if nina you are not part of South Africa. So if unganiphendula apho njengongqongqoshe or umphathiswa wezempilo apha eWestern Cape ukuthi why you are misleading the people of South Africa, because we had many stories from people of Western Cape during the public hearing. Unfortunately, or fortunately, I was part of the public hearing, and we had a lot of complaints. Naze nabasusa nabasa kwenye indawo nakhupha nezenu i-pamphlet information engekho relevant that was misleading the community of Western Cape. So if when you are answering my question, you can also cover that, why are you doing that in the society of Western Cape? Thank you.
Thank you very much, Chair. I have two questions. First one, procurement as described in section 217.1 is different from buying products, which the providers should do themselves of the formulary at fixed national prices. How does WCG see this as a national risk? Second question, If central hospitals are national assets, why is the Western Cape DOH averse to this being converted into governmental components that are accessible to all South Africans and managed in a manner that achieves UHC? Thank you.
Thank you very much, honorable members. Is there any other member that I would have left out who would want to raise any points here with the Western Cape government? Anyone at all? Let me also raise one or two points with you, MEC, and with your team. And before I do that, I must also say that I know that you actually accept that there will be an NHI, but that you have certain proposals to make, which you have actually made with regards to some of the points raised in the NHI bill. And it is very comforting to know that the Western Cape government supports the principle of the National Health Insurance. And what is before us now, of course, is the National Health Insurance Bill. And even that is very comforting to know that you do support the bill, apart from you making some points of concern, raising some points of concern and making certain proposals which we have seen, or I have seen, and many of your slides which you presented. I want to also speak about your concern about the changing roles of the central hospitals and to acknowledge your concerns. Now, the white paper states that the structured financing of central hospitals will be transformed into national assets, as well as training platforms, research hubs, and centers of excellence locally, regionally, and internationally. What is your view on the challenges that have been experienced by users, especially from rural provinces who do not have sufficient access to central hospitals? This comes in relation with the point which was raised by Honorable Sukacha about the Eastern Cape and the Northern Cape, where we know that we have a referral system to the Western Cape. And I do remember it being in place even from as far afield as Namibia, even when I was a medical student and when I was working as a medical officer and subsequently. Would you agree with me that achieving equitable universal health coverage requires the provision of accessible healthcare services for the entire population without further imposing barriers? In absence of centralization of these hospitals, how do you suggest we address inequitable access to central hospitals? And how do we ensure that South Africans in need of specialist services are able to access such care within the context of geographic inequitable distribution? I now want to speak to the other point that you raised about the creation of contracting units for primary health care, as it is provided for under Section 37 of Chapter 8 of the bill. The proposal is made to utilize the existing provincial structures which are already overstretched. My question is, what would prevent the provinces from participating in the processes and activities of the proposed contracting units? And given that our public resources at provincial level are already overworked, how does the Western Cape see the proposal they have made materializing? And the very last point I'd like to raise with you is your intention or your motivation to serve as a laboratory and allowed to be funded to invent the models as for the NHI. Now we are aware that previously in reports which were made by the National Department of Health, the Western Cape has rejected almost all of the national, the proposed national models, for example, the health patient registration system, the CC MDD, quality programs, etc. How do you bring a relation between your proposal to serve as a laboratory towards the invention of the models with your previous rejections of the models which were put forward by the National Department of Health? I think those are all of the questions which all of the members would like to raise with yourselves. You're very welcome to reply, and we are actually looking forward to those replies. Thank you.
Thank you, Chair. Dr. Karim and Dr. Valabji will respond to the technicalities, but I'm just responding under general so that the members also can look in terms of what is currently happening in terms of the provisions within the current legislation. In regard to central hospitals, in case you are not aware that the provinces that do not have central hospitals, because remember, central hospitals have got a history in regard to that they are academic or teaching hospitals, and therefore find that they used to, at the time, focusing that they are attached to the medical schools. So, and also that quaternary services is related to that because there must be specialization and packages of different disciplines that needs to be offered. So those provinces like the Limpopo, Mpumalanga, I think you mentioned Northern Cape, you find that they do receive central hospital grants. They do receive, and I'm aware, for example, the Mpumalanga, that actually the Gauteng invoice them in regard to that aspect. So there is an offer in regard to that. In the Western Cape, the two central hospitals, which is the Fortescue and the Tygerberg, and then the tertiary hospital, the Red Cross as a children's hospital, actually the provision is there within even the National Health Act that they are catering beyond actually for the provinces, specifically from the Eastern Cape and also parts of the Northern Cape in regard to Tygerberg, I think for Springbok in terms of the Northern Cape. So it has always been there. And also even the central grants that are being provided, the provinces, specifically Western Cape, has to provide more of the funding that comes from the equitable share for such. In addition to that, in the Eastern Cape, fortunately, I'm also from the Eastern Cape, and I also train the Eastern Cape. We even have specialists, specifically, for example, for the pediatric oncologists that have got clinics on monthly basis where they'll go to Susila Makiwane, to Mkandul, and all of those in regard to that. So the current at Gauteng has got more, I think 4 or 5, I can't remember the central hospitals that they have. So what we are trying to highlight is that every province that has got a central hospital, they do know that the central hospital is not for that province or is not for that specific area where the central hospital is allocated. That's why for Tygerberg, when we made the request to the National Treasury in regard to have a Tygerberg Regional Hospital to cut the Tygerberg, because currently, what is a central hospital? Because there's no regional hospital in that area, it means that it still has to service, especially the response in regard to the Khayelitsha, because the service is also part of the Metro East, in addition to other parts of the province and also other parts of the country, that's how things are in central hospital. Now, the question is about why should it remain? The issue of as you see in the WHO is very clear about it, the issue of the continuity of care, because we're talking about preventive, promotive, which is the primary healthcare part of it, and the intermediate care, which includes rehabilitative care, and the palliative care, the acute and subacute that are being catered for in level 1, level 2. And the majority of the poorest people, they ended up even having disabilities and also even deaths, early deaths, without even having been able to access the central hospitals, which is the quaternary services. Therefore, the preventive and promotive and also the level 1 district hospital, level 2 regional or provincial hospital, they have to still play a role, because actually the majority of the people, that's where we find that they go to, and all these hospitals, they are part of the province. So the continuity of care is about, you cannot have one piece and then you have another piece as part of the continuation. Because when you track Auntie Sarah, when she enters the primary health care up to the level that she needs to have that heart transplant, it should be part of it, because you cannot be able to trace that person if it's so happen that it now becomes segregated. Hence, I was making an example of our specialists who now even have to go and have these clinics outside the Western Cape and assist and provide assistance to admit their patients in those spaces out there. And then in regard to generally, again, about the NHI UHC, I thought we made it clear that there's no one who can deny not to have universal health coverage. I even made an example up to where even as a country, through being guided by the national, we visited as many of the countries where we divided into groups with the provinces, visited these countries where we can be able to see lessons learned and then to customize ours. I made an example of going to Thailand, others went even to the UK, where they saw that the social determinants of health, they could easily be even added in terms of the, included in terms of the costing, also of the budgeting. So we have never said that we are not supporting universal health coverage. And the question about the pamphlet, because we also need to be very careful, honorable member, when you say the people said about it, because one can also come and say that what the people said about that other person or those other people. The pamphlet that we're talking about, it is this pamphlet that we provided the people to summarize it for each and every person so that can understand exactly what is NHI, what is being offered, what is not being offered. So as we indicated earlier, that about the issue of the universal coverage, that part of it, there's no argument around that. Now, the question related to, I think they can answer about some of those in regard to the purchasing and also the centralization and all of those. Technically, they could be able to answer that. But if I could also make more of the input in regard to that, to that space in terms of fragmentation. The bill I still repeat, the bill, it's an insurance fund as it is written. If now this bill could be able to achieve what everyone is expecting, which is the UHC, bravo. That's why I was saying that in this form, it will never take us to the UHC. It won't. And as I highlighted in terms of what is the reason, because the focus is more on one aspect of the building block of the health system, which is more the financing and the funding. And I made an example that just like any other insurance, a national health insurance, an insurance which is about where you create a fund and then all the monies are collected and then that fund buys for different packages of care. And we're already stating that even in those packages of care, nothing is being mentioned related to the upstream factors that impact on the care. We're even saying that the issue of the subsidiarity, where the decisions supposed to be made at the local level. For example, for us, even without even mentioning the issue of the NHI and all of those, the decentralization, and we're allowing things happening at that level, where, for example, the central hospital for level 11, in terms of the post, they could be able to appoint, doesn't need an MEC or HOD as according to the PSA. It doesn't need. The issue of the budgeting, where you give budgets to the hospital so that it doesn't have to wait to be in terms of approved at the head office in order to fix a window. There are many of those packages. They approve a post list where we have a post list so that that person, management in that hospital, if now they lose a clinician or a specialist, they can make a decision regarding that. Do we need to replace another person with this cardiologist where probably there's no need, instead of probably appointing maybe 2 or 3 MOs or maybe 10 or health professionals, nurses and other categories if need be. The point that I'm trying to make is that already the current system does allow that things can happen there at the periphery, at the district or at the sub-district level. And in terms of the PFFA, the accounting officer, the HOD, has to not only to account, has also take the responsibility. Now, if you're going to, all the funding is being centralized elsewhere, what we are saying is that this will not work when we are still have to be responsible in terms of the delivery of the care services. And if you look in terms of what is being said about the provinces, that the limitation will be in the EMS, for example, when you talk about the issue of the EMS and all of those and other aspects. So that's why you cannot divide the continuation of the rendering of the services. And also lastly, the building blocks, as you are aware, we talk about the health financing, the information systems, leadership and governance, the human resource, the package of care, the care that you provide, it's all based on these building blocks. So you cannot take one system to be there at the national level. You take another part of the health system, another building block there, because everything must be within. But what you are saying is that we understand the limitations that is being provided in the National Health Act, where it states it's clear that the National Department of Health Responsibility is more on the norms and standards and the policies. They don't own hospitals, they don't own hospitals, they don't own patients, they don't own human resource. It's done by the provinces. Therefore, it makes them to be in a difficult position when they have to make some of the inputs, especially when the health system is collapsing. Therefore, there is a need that they're supposed to be part of it. That's why we're saying that let's not create binaries. Similar with the private health. No one is happy. No one is happy in regard to when the people ended up not being able to get a service because of affordability. And also we don't want where there's an exchange of monies at the point of service. The prepayment, it's where to go. Internationally, that's what is happening. 26 of the countries already, they've implemented the UHC. We have to do and customize our own UHC. The private, I listen to the private. Actually, I've had even engagements and the seminars and the symposia with the private. They are very much welcoming the issue of the UHC because lastly, Chair, at the end, the contribution that goes to the private, mostly from the medical schemes, the majority of those medical aids are mostly those that are coming subsidized by the government, and most of them in order for them for their livelihood. And that money comes from who? From us. If you look in terms of the public servants that we have that are on medical aid, which they contribute towards that side, there is a lot that money could be done. So, Chair, I'll ask now the team just to contribute, and then I might come back about the other specifics. Thank you. Over to you, Dr. KV.
Thanks, Minister. Just to pick up from where you left off, Minister. So just to and just pardon me if I don't cover all the ground, but I'm sure Dr. Karim will also come in. I think the issue of several of the questions related to issues of fragmentation, 9 provinces, etc. And I think at no stage are we saying that we don't believe in one national health system, that we are all part of one national health system, and the intent of pooling resources from the public and private sector to try and achieve the best possible population health outcomes is completely supported. Right? So I think that's a very important statement to make at the outset. So one is not, espousing a kind of fragmented system and each province does its own thing, etc. We are part of a national health system. And in fact, the national department should be setting the national policy for the country, the national direction for the country, the health reform agenda for the country, and we should be buying into that. We should be co-developing that, right? And we should co-commit to implementing that over the next many years. So I think I want to just make that point strongly at the outset. I think having said that, right, the issue of cohesive health systems is a hell of an important thing, right? And like I said in the presentation, we have spent decades trying to build a cohesive health system where the different parts talk to each other. Patients have been referred thousands of times every day between facilities, right? And the ability to maintain that cohesion, to strengthen the relationships between the different parts, to be enabled and supported is hell of a important to be a well-performing health system. And we're saying that any reforms that goes against that will fragment that cohesion and undermine the performance and achievement of a health system. That's what we are saying, right? I also want to say the point about we don't in the Western Cape profess to have mastered the leadership in health reform, or that we don't have problems to solve, or we are completely 100% all sorted out in the Western Cape. That's never been a pronouncement from the department, and we don't say that at all. I mean, we've got our fair share of challenges in the province. Of course, there are equity issues in the province that need to be addressed. There are efficiencies that can be improved. There are quality of care improvements that can still happen. There are many innovations still to happen. And the reform process with all of this is a lifelong journey. It's an ongoing journey of improvement that we're committed to. So we don't profess to know it all and have all the answers to all the problems. What we say is that we have a process where we can co-commit to jointly solving these problems, jointly sharing what we have experienced and share that across provinces as well as between national and the province. And that's the approach we would like to take. So one of the questions was about, what are the collaborative efforts with national? And what we're suggesting is that this NHI bill process is an important opportunity for that engagement to happen and build on what we have. And the last 2 years has been an excellent example of collaborating and working together. It's been an excellent example of taking some of the principles of UHC forward, with the way the vaccines have been procured for the whole country, right? With the way public and private have worked together at an operational level, sharing of data, joint problem solving, etc. And it bodes well for the future. And that's what we need to build on going forward. So I think that's just as an example of the collaborative effort. But we must convene and create the process and the environment for that robust engagement to take this process forward. On the issue of Honorable Chair, your point about some of the projects that have been rejected in inverted commas. I think rejection is a strong word. I think there are where there's been engagement still to be had is that in the Western Cape we've had long years of establishing certain systems, and the question is, how does one switch, or how does one make the transition smoother between different systems, or how does one interoperate different systems as opposed to all of us dismantling what we have built over years and committing to something new. So the HPRS is a good example. So it's a health performance registration system that the National Department has created. We've said we've had a system that has gone for 10, 15 years of the way we've registered our patients. We have a data center, we have a patient master index, and that has worked well, etc. And we've collaborated with National to share our data set with National to see how we can make this interoperable, right? And I think that's an important principle going forward, Honorable Chair, because especially in the IT space, there are going to be a lot of IT applications, and every province has histories and different systems that have been tried, etc. How do we create a transition towards an interoperable national health system where we can seamlessly share data and achieve the same purpose? So that's just as an example. I think those would be the main points. Minister, you covered many of the other areas, especially the central hospitals and those issues. I think let me stop there, Honorable Chair, and I'm not sure if Dr. Karim would like to add.
Thanks, Honorable Chair. Maybe just one or 2 points from my side to pick up where Dr. Viability left off. I'll get my camera up and running. Here we go. Honorable Chair, so I think the one big
definitional issue that we've also been grappling with, as I'm sure you have, is the stewardship role of the provinces. Now, I mean, we've had the experience, as Minister pointed out, during the COVID pandemic, of playing that stewardship role in the province, not just for the public health, but for public and private. As you might know, we had entered into contractual agreements with the private sector hospital groups in the province, the medical schemes, to provide healthcare as a composite basket of healthcare, public and private. I think the issue of the stewardship role of the Provincial Department of Health is actually quite critical. But then also in looking at the definition, it will be important then to distinguish the stewardship role from the purchaser, the provider, and even the regulatory role. And I think those distinctions, if they're quite clear, could in fact enhance and strengthen the position. I think the Minister and Dr. Viability both spoken about the UHC, and that's always been the position of the province, is that we are wanting to move towards UHC. And even as we said in the introduction, the innovations brought upon during COVID, in fact, are taking us along that path towards UHC. There was one question, for example, about some of those innovations, and we were talking about the kind of innovations brought upon, like telehealth. We discovered, for example, that diabetics are higher risk of dying from COVID, so instituted a telehealth system to help diabetics and understand their risk factors. And in fact, it showed significant reduction in mortality. We instituted a system of delivering chronic medication to people's homes. We've delivered about 3 million patient medicine parcels to people's homes over the 2-year period, so that they don't have to come into the hospitals and queue and stand in long queues just to pick up their medication. So a number of those innovations, but all of those in a sense are action areas that we've identified towards UHC, and those can be summarized as our service delivery capability. We also have, as Dr. Viability and Minister pointed out, governance capability and defining the roles of the various role players, public and private stewardship in the province. And if we look at the workforce capability and our learning capability, those are kind of the action areas or pillars, if you like, of our thinking towards UHC. And so when we talk about being a laboratory for that, I mean, we certainly have, we believe in the province, the strength of all 4 of those action areas to be able to help us understand how UHC is to be delivered. And Minister already spoken about the NHI itself being largely a financing mechanism. And that's where we had some of the concerns, obviously, that Dr. Viability raised. Thank you, Chair. I mean, just to add to the conversation.
Thank you very much. MEC, are you coming to have that second opportunity as you said you would?
Chair, I think they covered everything, but I think what I wanted to stress, because there was a question about what will be the packages that the provinces is being proposed to provide within the NHI. It's the emergency medical services and forensic pathology services, which currently is the case. And noting that the EMS, based on the 1977 Dispensation Health Act, they were also under the metros, which is, I'm thinking Gauteng, some of them, they are still, some of them are still under the metros. But it's in terms of the constitution, in terms of the schedules, that it's a provincial function. Forensic pathology services, as I think Dr. Viability indicated, that they were transferred from the police to the provinces. And I recall that the person, although I wasn't here before, the person who was actually spearheading it was convening. It was the DDG, Dr. Nicholas Crisp, was influential in terms of transferring this during the time. The Environmental and Pollution Control Services, which is, according to the National Health Act, there are municipal services and also specifically for the district and the national. And then the health and medical services during provincial disasters. That's the only function. Now, because I always make an example of track down anti-SARA patient aid. So in terms of the NHI bill, it says that there might be that service provider that will have been appointed by the national in order to provide that service. So anti-SARA will go to that clinic, and the clinic or whatever, it could be private, that provides such a basic, maybe primary healthcare services as accordingly. And then if it so happens that anti-SARA has got an issue with that kind of a service there
it means that there must be, or there should be, or there could be, or there might be a complaint line that will go directly to the province. Because if the province is not in charge, is not a steward in regard to the care that is happening inside their province, it means that all the complaints from the Maritzburg and whatever, they'll go to the national. Because for the province, they will say, if it's not EMS, if it's not forensic, if it's not about disaster, then we are tired. So that's why I was saying that once we encourage the whole system to work as one, because when you say UK system, NHS, when you say that it's a whatever system in every country, talk about one country, not segregation. So that's why I was saying that one health system was the difference between the governance, but we talk about the system. One health system with a multiple entries so that it provides different needs for the different people as they require without financial hardship, and also for the choice. If others now they've got affordability where they can put the frills, but we as a government, because we have to absorb and to protect the vulnerables, therefore, that's why I was saying that it's long overdue to pulling the resources and see how each and every sphere could be able to work towards universal health coverage. Thank you, Chair.
Thank you, MEC. I was just about to stop you, but thank you very much. We've come to the end of the presentation by the Western Cape government. We appreciate you coming to make your input here to us as the members of the Portfolio Committee on Health. We would have to move on, honorable members. You are very welcome, MEC and your team, to stay on should you wish to, but you're also welcome to leave the platform since you are very busy people, but it's entirely up to yourselves. We are going to have next a representation from SALGA, and they will be led by Ms. Nosibele Makanda. And you're very welcome to introduce your team, Ms. Makanda, and also whoever will be doing your presentation. And I hope you've already been, yes, I see you have already been made a co-host. So very welcome to our committee. It's a continuation of a meeting of this morning. We have spelled out the rules of our meeting, not for your purpose only now, but for everybody's purpose. And we're looking forward to your presentation. Thank you. You may continue.
Thank you very much, Honorable Chairperson. And I'm not sure if I should straightway share my screen. Let me just quickly share my presentation.
I'm only concerned that you're still moving. I hope you don't get cut off at some stage. I see your vehicle is moving.
Yes, I am. I am a bit on the road, Honorable Chairperson, but I'm confident that the network will carry me through. Chairperson, I was supposed to be with Councillor Stan Ramaila, the National Chairperson, responsible for the municipal health services in SALGA, in the NEC of SALGA. But he's going to be joining me, and because he's held up in another meeting of the municipality. And so it is just me for now, and I'll be presenting on behalf of SALGA. And if he joins me, then he will be able to then respond and maybe comment as in the course of the discussions. So I am ready to present. And greetings to you, Honorable Chairperson, and the honorable members of the committee, the honorable minister and the MECs that are present, and all the colleagues from the National Department of Health. I see the acting DG, the Office of the DG. Honorable Chairperson, as SALGA, I wish to present as follows. First, under definitions, the comments that we wish to bring forward, that one, the bill defines healthcare services as meaning A, healthcare services including the reproductive healthcare system, or let me just put it on, sorry, yes, as including reproductive healthcare and emergency medical treatment contemplated in Section 27 of the Constitution, and B, basic nutrition and basic healthcare services contemplated in Section 28(1) and C of the Constitution, and under C, medical treatment contemplated in Section 35, subsection 2, subsection E of the Constitution, and D, where applicable, provincial, district, and municipal healthcare services. Our comment as SALGA on the definition is that the bill must clearly define what municipal healthcare services are to make reference to a legislation where municipal healthcare services has been defined as it is the case with the ABC in the definition section. And it appears in this bill that the municipal healthcare services could mean something different to municipal health services as defined in Section 1 of the National Health Act number 61 of 2003. Again, under the application of the Act, Section 3, subsection 1 of the bill states that the Act applies to all health establishment, excluding military health services and establishment, while Section 3, subsection 4 of the bill states that the Act does not in any way amend, change, or affect the funding and functions of any organs of state in respect of healthcare services until legislation contemplated in Section 77 and 214 read with Section 227 of the Constitution and any other relevant legislation has been enacted or amended. Our comment on this one, on the application of the Act as SALGA, is that our interpretation is that the Act applies to health services and establishment at local government level. It is our view that the implementation of the National Health Insurance will require addressing health infrastructure and human resources for health, amongst other things. It must be noted that some municipalities currently have health establishments in the form of clinics, which may require infrastructure improvement and additional human resources for health for them to meet the standards required for accreditation as service providers. Local government will also be required to provide and coordinate services such as water sanitation, waste management, energy and access roads aimed at enabling the efficient provision of health services. It must therefore be noted that both the preparation of the implementation of NHI and the actual implementation of the NHI will require more funding than what is currently allocated to local government. It is therefore urged that the NHI bill highlight the need for the review of the appropriations, equitable share and grants to the local sphere. On roles, Honorable Chairperson, Section 31, subsection A of the bill under the general provisions applicable to the operation of the fund, it outlines the role of the minister as including governance and stewardship of the national health system, while Section 31, subsection 2 of the bill states that the minister must clearly in appropriate legislation the respective roles and responsibilities of the fund. I'm sorry. Section 32 of the bill clearly outlines the role of the national department and further indicates what must happen with the provincial department in as far as its role is concerned. SALGA's comment on the roles, therefore, is that we understand that the National Health Insurance is a health financing system. However, we know that the bill also seeks to provide of health services. Both the National Health Act number 61 of 2008 and the 2018 National Health Insurance Bill clearly outlined the role of local government in the provision of health services. SALGA notes the exclusion of the role of local government in the current National Health Insurance Bill. SALGA is of the view that municipal health services forms part of the country's health system, and therefore the minister must clearly delineate in appropriate legislation the respective roles and responsibilities of municipalities, as it is the case with the respective roles and responsibilities of the fund and the national and provincial departments, taking into consideration the Constitution, this Act, and the National Health Act. The Act must also stipulate the role of municipalities, if any, or what will happen under the contracting unit for primary health care. Section 37, subsection 1, subsection A states that a contracting unit for primary health care establishment in terms of Section 31B of the National Health Act manages the provision of primary health care services such as prevention, promotion, curative, rehabilitative, ambulatory, home-based care, and community care in a demarcated geographical area. While Section 2 indicates that the contracting unit for primary health care must be comprised of a district hospital, clinics, or community health care centers, and ward-based outreach teams and private providers organized in horizontal networks within a specified geographical sub-district area. And our comments as SALG on this one is that it must be noted that the local government played a critical role in the piloting of the National Health Insurance. The environmental health practitioners employed by local government constituted the ward-based outreach teams and played a critical role in cases, investigations, and in the addressing of environmental health conditions impacting on the health of the citizens. The number of environmental health care practitioners currently employed by national, provincial, and local government is far less than the number recommended by the World Health Organization and the standard prescribed in the National Health and Environmental Health Policy, which is prescribing one environmental health practitioner per 10,000 population members. And will not be able to.
Ms. McArthur, can I just make certain, since I did raise, I do see you in the passenger seat. I would assume you don't have a left-hand drive vehicle, so there is a concern by some of the members that you are actually traveling. While doing your presentation, you must ensure or confirm with us you are not actually driving.
No, not driving.
And secondly, if possible, that you should pull over to do this presentation. You're about halfway, so you can consider from our side of the portfolio committee, we want to be certain that you are not putting yourself and others at risk. Thank you.
Thank you, Honorable Chairperson. It's considered. I will ask my driver to pull over as soon as we are safe. It is safe to do so. Thank you very much. But rest assured, I am not driving, and we are going to slow down a bit so that you can pull over.
Yes, and another comment, you must please put your seatbelt on. I'm sorry, I'm translating. I'm relaying the messages. Don't shoot the messenger. Thank you.
Thank you, Chairperson. Okay. Well, back to the comments of Salga on this section. The environmental health care practitioners employed by government. Oh, I'm sorry. I was on bullet number 3 in terms of the capacity challenges of the environmental health practitioners to deal with the current demands of the sector. So the recruitment of environmental health practitioners should be prioritized together with the recruitment of other health professionals in preparation of the full implementation of NHI. So this is our submission on this part. And then on the repeal or amendment of laws, Chairperson, the National Health Act number 61 of 2003, then the amendment of this act of 2003 proposes in section 31A and subsection 1 of which seeks to establish the district health management offices as national government components to, among other functions, manage provisions of non-professional health services in the district. And our comment as SALG on this one is that municipalities are currently providing non-personal health services in the form of municipal health services. But the municipal health services as defined in section 1 of the National Health Act, number 61 of 2003, includes water quality monitoring, food control, waste management, health surveillance of premises, surveillance and prevention of communicable diseases, excluding immunizations, vector control, environmental pollution control, disposal of the dead, and chemical safety. The bill should therefore clearly define the non-personal health to be managed by the district health management offices to prevent fragmentation and duplication of non-personal health services. The last part, Honorable Chairperson, as we conclude, is that we believe the successful implementation of the national health insurance will require intergovernmental and multi-sectoral approach, and to that effect, local government plays a critical role in addressing social determinants of health and in contributing towards improved health outcomes and a long and healthy life of all South Africans. Strengthening environmental health programs such as health surveillance of premises, surveillance and prevention of communicable diseases, waste management, food control, vector control, and environmental pollution control are essential at all service levels. The implementation of the National Health Insurance should take into account
Chair, I'm not sure if I'm the only one who's lost the presenter, but I've lost her completely.
Yes, Ms. Nosibele, are you back?
Yes, I'm in. Okay, it's the weather now. But the last part of the sentence that honorable members may have missed is the last byte that says we require the implementation of the National Health Insurance that would take into account the inputs that have been listed and to ensure a unified health system. And the realization of Section 27 of the Constitution of the country, the SDGs and the NDP goals as it relates to the universal health coverage. Thank you, Honorable Chairperson. That is the end of the presentation.
Thank you very much for your presentation. And I'm sorry I made you lose some time on reaching your destination. But
thank you.
Appreciate you coming here today and your willingness to come and do this presentation. Yes, so we do have some members who would want to raise some questions. I have one. In fact, I don't have anyone yet. One so far, Honorable Howard would like to ask a question. Honorable members, you can indicate here for me if you'd like to ask any questions or raise any questions with Salga.
Thank you, Chair, and also thanks, presenter. I just have one question. Can you clarify to the committee the difference between municipal healthcare services and municipal health service, and the sections or clauses in the bill where the two may have been conflated? Thank you.
Thank you. Any other members who would want to ask any questions?
Yes, Chair, I do.
Please go ahead, Honorable Gela.
Thank you very much, Chairperson. Let me welcome the presentation from Salga. I've got two questions that I want to ask Salga. The first one, is there a provision of healthcare services by municipalities funded or an unfunded mandate? In slide 5, you state some municipalities currently have health establishments in the form of clinics. They have no statutory mandate for this function. So now they want to offload the services, but with no budget, transfer with the function shift. This is not acceptable. As an example, the city of Cape Town has over 120 of these clinics, which basically add to the budget and capacity of the Western Cape Department of Health. The salaries of staff employed by municipalities are different and higher. What is Salga proposing in terms of how these services can be funded and harmonized? The second question, there has previously been an effort to provincialism
the personnel health care services delivered by the municipality. In your view, what has been a bottleneck in achieving this goal? What are your proposal on how this can be affected? Should you be in agreement with the provincialization? Lastly, Chairperson, can the presenter clarify if municipalities will be interested in moving their infrastructure to the province system for the current unfunded mandates?
Thank you very much, honorable members. I will also raise some questions, and I had specifically noted, Ms. Makanda, you're talking about two things here, the municipal healthcare services and the municipal health service, and that you are asking the question whether these are two different things or whether this is supposed to mean one thing. And if you can maybe clarify for us the difference between those two and your views on those, as well as the sections or clauses in the bill where the two may have been conflated, it would really assist us. And in terms of your understanding of SALGA's mandate, or with regards to municipal health services, I remember a time when there were municipal health clinics, and we still find them in the larger cities or in cities, in metros. And I do remember even where I lived, there used to be health services provided by municipalities, and then it was removed and taken over by the provinces. So in my understanding of this, I would like to be then informed, but more informed of my, of your view rather, of the definition of the National Health Act of 2003 with regards to this municipal health services, which should be rendered at a municipal health level, and especially Chapter 5, Section 32 of the same Act. Do you suppose that these could be regarded as personal healthcare services that are to be funded through the NHI? And then you also raised in your presentation issues related to the provincialization of health services and the devolution of environmental health services. We've had a presentation by the Western Cape government, and especially the Department of Health, which spoke to the same point of the type of services. So what is your view as SALGA of these two, having considered current policy on the two and long-standing problems that have not been resolved that pertain to environmental health services and offices? And your presentation is motivating for infrastructure budget from the NHI fund. Do I understand you correctly? Thank you very much. Those are the only questions which will be asked to you this afternoon. We do appreciate you coming to present, and if you can please respond to those questions. Thank you.
Thank you, Chairperson, and I appreciate the questions as they are coming. Well, am I audible?
You are, you audible.
Thank you, Chairperson. It's under definitions, Chairperson. On the first question that deals with the difference between municipal healthcare services and municipal services. So what we want to bring in under definition is also something that clearly states municipal health services as well, because under municipal, so it's section 3.1 that deals that defines the application of this, and let me just go to the comments. So it's under definition under A, B, and C. So what we are recommending there, Chairperson, is that we believe that municipal health services are as they are contained in the National Environmental Health in the National Health Act 1, and they deal with the municipal health services as provided by local government. Then municipal health care services would be services that are located within the municipal jurisdiction that are offering care services to the community, and such would then also include the services that are offered through the healthcare services that are offered by local municipalities in terms of the primary health care. But when we talk municipal health services broadly, we also believe that such should also involve environmental health care as well as already defined in the Act, and the provision of the services that I had outlined. Then under the area of the healthcare services by municipalities as an unfunded mandate by the question by Honorable Gela. Indeed, currently, the process of provincialization was done, and so the healthcare function was taken from local government and returned back to the provincial government. But that process in metros did not happen, so the metros are still funding are still carrying out the primary healthcare function with all the clinics and the healthcare establishment run by the metro. And part of the challenges that are there, indeed, the metros are spending from the municipal funds more than the allocation that they are getting from the provincial government in terms of providing the primary health care. And they have come because of the level of infrastructure, as well as assets in terms of human resource that they've put into the system. In the period of transition in the provincialization, it became clear that I'm sorry? Oh, it became clear, Honorable Chairperson, that process, the disagreements between the provinces and the metros in terms of the running of the healthcare function, in terms of the personnel and the levels of scales at which the personnel were at metros versus where they would be going into the provincial department. There was then an agreement between the provinces and the metros to have the metros running the function. Indeed, it is a fact that it continues being an unfunded mandate because it is not the function of the municipality, but they have a service level agreement with the metros. And maybe to link that to the next question that says, what becomes SALGA's proposal for funding and harmonization between the functions as provided by the provinces as well as by the metros? Then the proposal would be that the funds must follow the function, and that on the assessment of what the function is costing the metros, then the allocation of the funding should also be commensurate with that. And again, possibly that because at this point, it would seem that both the department in provinces as well as the metros that are rendering the service, there is an agreement that it is better served. The interests of the communities are better served where the services are located at the metros, of course, with the allocations by the provinces. But then we would just, as SALGA would call for, an allocation that would meet all the funding requirements of the service, so that it does not have to take from the municipal funding to also fund the sourcing, the resourcing of the service. Then again, indeed, the area on bottlenecks in terms of the primary healthcare services transfer between from the metro. In fact, I can assure the portfolio committee that with the districts, because the function was rendered by the districts, and some districts were having service level agreements with the local municipalities, but all of that has been taken over by the provinces. So the local government is now rendering the primary healthcare services in metros. So the bottlenecks are only in as far as because I don't think right now we have not really I think we left the discussion with the Department of Health hanging in terms of really taking over the function and having the function fully provincialized from the metros. And so the metros are still running with the function. Now, the only thing then that we're saying is that so that it does not continue becoming a burden to the metros, the funding, the required funding must be allocated to the metros so that they are able to render and also to be supported in the rendering of the function. Of course, there is a good relationship between the province and the metros as it were now. As far as the municipal assets are concerned, I think it was one of the challenges, Honorable Chairperson, that the municipalities have invested deeply into the assets for the primary health care. And now the taking over of such, the handing over of such assets, there was no agreement in terms of the municipalities being compensated for the assets that they've bought and accumulated over time, as well as the human resource aspects. Because as it turns out, apparently, as I've said earlier, the metros are paying the healthcare providers at a higher scale than the normal clinics that are run by the Department of Health. And so we could not really reach an agreement in terms of that. So that would make the transition therefore happen to the provincial departments. It is well, as far as the primary healthcare services that are rendered by metros is concerned, for the communities, it makes sense for that service to be rendered by local government. It makes sense, but we understand fully that it is not our core function, and it is not our mandate, in fact, as local government. And so the function is being rendered on behalf of the provincial government, and hence the service level agreements that are there. And of course, when we're referring to the infrastructure that then is there, in terms of both the municipal healthcare services as run by the metros, perhaps then it would be to say so that they are not, the infrastructure meets the standard of the national healthcare national health insurance, then then the metros or rather local government would also need to have such funding for that would also improve the infrastructure to reach that level, so that they are not as indicated in the presentation, they are not they remain the service provider. They continue to play the role of being the service provider. And indeed, so part of that infrastructure definitely is dealing with the healthcare centers, the clinics, and as far as the municipal health care, municipal health services, as indicated, to providing. Let me just quickly go to the slide. To providing water quality monitoring, food control, waste management, health surveillance of premises, surveillance and prevention of communicable disease, and as well as vector control and environmental pollution control, with the disposal of the dead and chemical safety. Again, the municipalities are responsible for that funding, but the funding from the equitable share is not adequate, and sometimes it is a challenge that was brought to the attention of the at a national level, where we had a national health indaba on the 28th to the 30th of September, where we brought together, we partnered with the National Department of Health, we brought in National Treasurer and COGTA, so as to discuss this whole issue of the funding and the capacity challenges that are faced by local government, and that have been exposed mainly by COVID, with the outbreak of COVID, wherein the ability of the environmental health care function in preventing communicable diseases, that would also have helped a great deal in preventing the spread of COVID-19 if there was adequate capacity. And the funding currently, in the allocation of the funding to the municipality, the allocated budget with actual service sometimes is not as demanded by the service. So as part of the healthcare system, we believe that the municipal health services, in as far as environmental health services should also be considered and funded under the national health insurance funding, so as to be able to come to be the standard that the World Health Organization wants it to be at. I hope I have covered all the questions, Chairperson.
Yes, I think so. Thank you very much. I'm trying to understand what you are actually really raising, and it's not difficult what you are raising, but I'm trying to get it into context. You are saying there are services being rendered at the primary healthcare level, clinics, which are then managed at the local government level, and especially in the metros. You are saying that funds should follow function. And you are also saying, therefore, that, and my question would be whether you would then be able to participate in the NHI as either SALGA or as the clinics, but I'm going to put this much more clearer to you just now. So what is your view, what will happen to the health facilities, for example, under the control of local government now, as well as the assets and liabilities linked to primary healthcare services, since we're now talking about this? You've also mentioned that there has been an indaba around this, and that there hadn't been final conclusions around the same topic. Now, this was supposed to have taken place, and I'm talking here about the transfer of the facilities, the assets, the liabilities, etc. was supposed to have happened in 2003. But what I do also understand is that NHI will purchase from any provider that is accredited. So my understanding is that this bill does not prohibit local government from managing clinics, and that is already in the National Health Act. Does it then also mean that SALGA, if you are saying what you are saying, will support a situation where the NHI fund will contract directly with the clinics belonging to the metros? Or what is your view in terms of that? And if that should happen, it would mean that the budget will be going directly to the clinics and not to the municipalities. So it'd be important and very interesting to hear what you would say about those points. Thank you.
Thank you, Chairperson. Again, in terms of this one, I think what
your network has frozen. I'll give you a few seconds. Ms. Nozibele. I would have loved to have heard the views of Ms. Nozibele Makanda on this one. Honorable members, yes, are you back? We are ahead of time, so we give an opportunity to reconnect.
Thank you, Chairperson. I'm back. I don't know what is happening with the network now, because for a while it was fine. What I'm saying, Chairperson, then is that if the NHI, on the assessment of the function as rendered by the clinics and with the agreement between the metros and the provinces, is happy to fund directly to the clinics, as SALGA will support that, because what is important is for the adequate service to the community that would meet the standards as required by the NHI. And if we need funding, then so funding to also upgrade those facilities to meet that standard would have to go directly to those facilities under the auspices of local government, being, of course, having a service level agreement with the province. We do not have a problem with that, and I think because through the as part of cooperative governance, but the issue is, if then the burden becomes on the municipalities to have to continue funding far and over and above what is allocated. Of course, there is a portion that the municipalities have taken responsibilities on, the metros in particular are taking responsibilities on over and above what is allocated by the provincial departments, where the primary healthcare services is rendered by local government. And but now with the continuous underfunding of the municipalities is burdensome to the metros and hampers their ability to deliver quality service that would be that would meet the requirements of NHI. So we would want that part of the funding should take that into consideration. And of course, I think if the transfer of assets were to be a requirement and between the provinces and the metros, then obviously all the implications would have to be discussed, and so that a budget would be set aside that would take care of all the implications of either the transfer of human resources or of the assets and liabilities, of course. And then as SALGA would be happy to participate in that discussion and would be happy to provide what would make sense for local government, but would also equally be happy to have local government as one of the service providers allowed, of course, the mandate not being that of local government, but with the service level agreement, we would be happy to participate in this as local government if our metros still feel comfortable that they have the capacity to deliver on the service, on the function, and they are getting the requisite allocation of funding.
Thank you very much, Ms. Makanda. We appreciate you coming and taking your time to come and present to us. I just want to make certain that there is no one else who would want to raise anything with you. I think just before we finish off with you, any last final words you want to say to us?
Person, well, it is an appreciation of this kind of a discussion and obviously the engagements. But what we also really would want the Portfolio Committee on Health to also really bring into the fore as into the bill is the significance of municipal health services into the prevention of disease spread and control in communities through the work that the environmental health practitioners do, and how such the capacitation of such would improve the health of the community on the preventive aspect, so that the preventive aspect is equally or almost equally funded as well as the curative aspect. And we believe that as SALGA, if the preventive aspect of health is given as much attention as the curative aspect, the desired outcomes would be a reduction on the need to fund the curative aspects of health, as prevention we believe is better than cure. Thank you, Honorable Chairperson, for the opportunity.
Thank you very much. And I like your closing argument there for prevention. Of course, the basics are very important. And we thank you very much for coming. Honorable members, we are going to try to move on. You are welcome to stay.
Thank you, Chairperson. Thank you for the opportunity.
You will be leaving your place where you are parked. We will continue because our committee secretary has informed me that Life Health Care does have its representatives already on the platform. They were to have done their presentation at 18:15, and we would appreciate it if they'd be able to indulge us with starting a bit earlier. I believe the group CEO, who is Peter Wharton Wood, is on our platform. If he is leading this delegation, would you please indicate to me and also indicate whether you are ready to commence with your presentation. Thank you.
Good afternoon, Honourable Chairman, Dr. Jacobs. Yes, I'm Peter Wharton Hood, the Group Chief Executive. I am leading the delegation from Life Healthcare this afternoon, and a warm welcome to the honourable members of the Health Portfolio Committee. If I may introduce my delegation, Honourable Chairman.
You're very welcome, and after that you may continue with your presentation.
Thank you very much. I've asked them to switch their cameras on for the purposes of the introduction. I'm joined today by my Life Healthcare colleagues, Mr. Adam Pyle, Chief Executive Officer of our South African operations, Dr. Sharon Vasuthavan, Executive Head of Education, Mr. Andre Joseph, General Manager, Funder Relations, Ms. Amrita Raniga, our Health Policy Manager, Mr. Ridwan Jabbar, Head of Funders, Analytics and Product Disruption, and Mrs. Ansuye Padiachi, who's Head of our External and Community Affairs. Thank you, Honourable Chairman and members of the Portfolio Committee, for allowing us the opportunity to make this important presentation to you today. And I thank you too for accommodating the diary request that we put to the Honourable members earlier in this month to accommodate the meeting with our shareholders in the form of our annual general meeting, which took place earlier today. Honourable Chairman, if I may move forward into our presentation, please, and I'll ask my colleagues to switch their cameras off, and they will switch them back on as and when they make their respective contributions to this afternoon's proceedings. In the context of Life Healthcare, if I look at the agenda that we will follow during the course of our presentation, Amrita will bring the slides up for me. You'll see that I will present an overview, and then we'll move through the various stages of our presentation. I won't read the slide off because it'll become apparent during the course of the presentation, and I will wrap up in the shape and form of a conclusion. If I commence with Life Healthcare's overview, you'll see that our ambition statement that we have made to shareholders and all stakeholders alike is that we will be an international healthcare provider, and I stress the word international. That plays out in some of the logic we bring to you a little later, providing and delivering measurable clinical quality through a diversified offering and a people-centered approach. Our mission: we improve the lives of people through the delivery of high quality and cost-effective care. All of those words also important to today's contribution. And our overall purpose, which many have heard, is making life better. If I continue to just put Life Healthcare into perspective, it is often mistaken as a purely South African hospital group. And yes, we have an extensive footprint in South Africa. We manage and are responsible for 66 healthcare facilities across our country, across 7 provinces of South Africa and Botswana. We are also the largest provider of employer-based on-site healthcare and other industry-related services. But our differentiator, which will bring a different nuance and subtlety to some of the points we make, is that our international business, through our wholly owned subsidiary, the Alliance Medical Group, is the leading provider of imaging services to governments, and I stress the word governments, across that of the United Kingdom, Italy, and Ireland, with a further participation in 10 countries. And I'd like to dwell on this slide just for a moment, Honourable Chair, because we stand in front of you as one of the most important providers in the shape and form of public-private partnership to the National Health Service in the United Kingdom, to the Government of Ireland, and to the Government of Italy. We've contracted with them to provide and provision a substantial service to them. And we've done it with the highest quality, on an extremely efficient basis, and at the lowest cost, where in each one of those countries, we as a private healthcare provider charge the same rates as the state would charge the citizens of the country. For me, this is an important emphasis, because as the Group Chief Executive of a South African listed healthcare company, I speak with pride and with confidence with the work that we have delivered to 3 very well-run and very important governments. And I stand today in front of you, representing our listed company, knowing that we wish to be able to do the same. It disappoints me that we haven't been able to include the South African government as one of our partners of substance in the diagnostic and imaging services delivery process that we've already proven internationally. And we hope, through the context of our conversation today, that our plea to be able to participate and help goes recognized, and we are able to activate it as this process moves forward. I will now hand over to Adam Pyle, the Chief Executive of our South African operation, to continue with the domestic overview. Adam?
Thank you, Pete. Can you all see me, Pete?
We can, yes. I will switch my camera off.
Thank you, Pete, and good evening, ladies and gentlemen. So in terms of Pete has covered our international overview, and in terms of South Africa, you know, our business has various categories to it. We are primarily an acute hospital business with our 49 acute hospitals across various provinces in the country. We also have what we call a complementary services line, which consists of the mental health business, the acute physical rehabilitation business, and then renal dialysis and oncology. In addition to that, we have a healthcare services business, which consists of two quite different businesses. One is we call Life Health Solutions, which is fundamentally an occupational health and wellness business. And then we have our public-private partnership, Life Estemeni, with its 10 facilities and over 3,000 beds. In addition to that, we have our nursing education asset, which sadly is an underutilized asset at the moment. It consists of our Life College of Learning with its 7 learning centers across the country. And, you know, historically, we used to train close to 1,500 nurses every year. And we are currently training about 20% of that number. And later in this presentation, Sharon Vasudhavan will go into a bit more detail in this regard. You go on to the next slide, please, Amrita. So I'd like to, first of all, reaffirm from a Life Healthcare perspective our support for NHI, our support for universal healthcare, and our support for improving the access to quality healthcare and improving the actual overall quality of healthcare for all South Africans. And, you know, I do want to say that from a Life Healthcare perspective, you know, we are providers of healthcare, whether that be imaging overseas or acute hospitals in South Africa. And I'd also like to think that we are pretty good at what we do in terms of that delivery. What we are not, though, are health policy experts. So please take our comments as regard national health insurance from whence they come. Secondly, I'd also like to make the point that when we make our comments on NHI, we do not presume that the private healthcare sector is perfect, because we know it's not. It is a fragmented system. It has challenges as regards cost. There's challenges as regard resources, and we know we don't treat enough people within the system. Our view here on NHI is that the NHI initiative is the largest undertaking ever taken by a government. It is going to require a massive change to the underlying health system. This change is complex, and for NHI to achieve its objectives is going to require a number of, how shall I frame it, building blocks to be in place if we're going to improve the access to healthcare and the quality of healthcare. And in this regard, if we believe that we're going to accelerate the implementation of NHI, the public and private sectors need to work together, and private sector should be involved. And the private sector should be involved not just in terms of private sector capacity, but in various other ways. And we will touch a number of those ways throughout this presentation. In addition, we believe the single payer system creates not just enormous concentration, but we believe it creates enormous operational risk to the NHI system. And we believe this risk is unnecessary. And our proposal that you can still have a single fund, but one should have, though, is a multi-payer system to alleviate some of that operational risk. And my final comment before I hand over is that for NHI to be successful, and if we are to improve the access to healthcare, we improve the quality of healthcare for all South Africans, then those building blocks need to be in place. And to ensure they're in place, we are proposing a milestone-based approach to implementation. I know we're not the first company to suggest that. And to go into this in a little bit more detail, I'm now going to hand over to Amrita Ranagar to take you through our proposal. Thank you.
All right, did we lose you there?
Amrita, are you on mute?
Apologies.
Oh, there we
Good
go.
evening, and thank you to the honourable members of the Portfolio Committee of Health for the opportunity to engage you on this critical reform. Healthcare is complex all over the world. We are dealing with the health and lives of our people. Life Healthcare, as Adam mentioned, unequivocally supports the attainment of universal healthcare for all South Africans. However, there are many components that need to be in place in order to realise the objectives of NHI, but with most critically being the human resources for health. So our journey towards attaining universal healthcare began in 2007 when the ANC resolution was passed. Since then, the country has engaged in the commentary process with the Green and White Paper policy papers, the NHI draft bills, as well as the public hearings, of course. Sorry, honourable members, I just seem to be having some technical difficulties here. Perfect. So our journey towards attaining universal healthcare coverage started in 2007 when the ANC resolution was passed. Since then, the country has engaged in the commentary process of both the NHI White and Green policy papers, draft NHI bills, as well as the public hearings. Honourable members, this extended timeline of the last 14 years in itself is indicative of the complexity of our healthcare reform journey. Of course, this is further complicated by the uncertainty that has been brought about by the pandemic. Critical point is that amongst this complexity, the recommendations made by the Competition Commission from the lengthy inquiry into the private healthcare sector must be considered for implementation. Much has been achieved in terms of understanding the complex nature of our health system, but we have so much more to do and have yet to put all our might and strength into improving the healthcare delivery system. Taking into account the enormity of this reform and the various components that need to be in place, a very lengthy implementation process is anticipated. Therefore, it is our view that a time-based approach will be challenging. The end game is crystal clear in terms of what we need to achieve. We need to approach this critical reform on a milestone-based approach, one step at a time. The bill proposes that both phase 1 and phase 2 be completed within a specified time period, with phase 2 completion being envisaged by 2026. However, there is a risk that the NHI will become fully operational prior to the positive and enabling outcomes being achieved. We therefore are not in support of a time-based approach. Honourable members, we should be dependent on the actual achievement of concrete milestones, which will enable an effective rollout of NHI. A monitoring and evaluation process is critical for the most rapid achievement of milestones. We do believe that guidance must be taken from the World Health Organization Health Systems Framework and the Presidential Health Compact, which identifies components that need to be in place, as well as where the existing health system needs to be improved or strengthened before we can move towards universal healthcare. The World Health Organization Health Systems Framework and the Presidential Health Compact sets out the interventions or activities that need to be realized in order to achieve universal healthcare. We believe that the implementation of the fund should be linked to the completion of the interventions set out in respect of each of these pillars that you see on the slide, and not the fixed dates that have been specified in the bill. As such, the bill should target the achievement of these established implementation milestones instead of the fixed dates. Honourable members, if we build a hospital and we put equipment and do not have any nurses or doctors to treat our patients, we will not be able to deliver healthcare. There is some interdependencies amongst these pillars, We saw this quite clearly during the pandemic when either we had sufficient beds available for patients, but were challenged by a shortage of nurses, or were challenged by a shortage of beds. As mentioned previously, the monitoring and evaluation is absolutely critical. There must be an independent approval or sign-off process that assesses whether these milestones have been met satisfactorily so as to enable the effective rollout of NHI. The adequate supply of competent human resources is the most critical foundation, and this is evidenced based on what's indicated within the World Health Organization Health Systems Framework, as well as the Presidential Health Compact. A milestone approach allows for management of risk sequentially. We will be able to bank successes in an incremental fashion and really gain traction in implementing NHI. Honorable Chair, I will now hand over to my colleague, Dr. Sharon Vasudevan, Executive Head for Education at Life Healthcare.
Thank you very much, Amrita. So I think human resources is going to be key to the NHI, because NHI is about creating access to healthcare. And this cannot materialize without adequate healthcare professionals. When we speak to sufficient healthcare workers, we must emphasize the need for the development and training of healthcare workers to meet the current and the future healthcare needs of the country. Management skills for the management of facilities, these skills do not come easy, and we need a concerted effort to develop our managers and then hold them accountable for smooth operations. Management of facilities has been highlighted frequently and determines clinical outcomes. It is our experience that there is a direct correlation between the competence of a hospital manager and the performance of a hospital. A hospital manager makes or breaks a hospital based on its capability to run a hospital. In terms of infrastructure, we need sufficient facilities across the continuum of care over multiple geographies, both rural and urban. The Office of Health Standards Compliance sets the standards which must be applied to all facilities to raise the level and quality of care to enable our communities to benefit. Accreditation of facilities, both in the public and private sectors, is critical to improving the overall quality and standard of care. When it comes to capital, sufficient capital requires investment models that are fit for purpose. If it is not attractive investment, then the investors, including the international donor agencies, may not support it. It would be detrimental to the entire health system, both public and private, if investors or donors decide not to direct their funding towards this critical investment. The reimbursement models should be simple, with attractive incentives for the patient, the purchaser, and the provider. Next slide, please, Amrita. So coming back to our health workers, sufficient healthcare workers, I mean, if you just think about that, we have a nurse-led healthcare model in South Africa. We already have a critical nursing shortage that we're all familiar with. A recent study supported by both the National Department of Health and the Hospital Association of South Africa cites that currently we have a shortage of anything between 26 to 62,000 nurses, and these numbers will get worse within the next few years. The contributing factors include an aging nursing population, introduction of the new nursing qualifications with limited numbers for training, reduced training outputs currently sitting around 3,000 nurses per annum, and a general lack of interest in the profession. The COVID pandemic demonstrated the critical shortage once again, both in the public and private sector. Short-term government contracts were offered in various provinces, and we in the private sector moved nurses between provinces to meet the needs of the patient. The lack of specialized nurses and the delay in training more of them, together with the challenges in transitioning from the legacy qualifications to the new ones, further exacerbates the problem. NHI will see the acceleration of primary healthcare clinics, and we currently do not have sufficient nurses to support these structures. This is a burning platform that must be addressed sooner rather than later. While we all know there are more specialist doctors in the private sector than the public sector, we must agree that the overall number of doctors for our country are inadequate, and the slide adequately reflects the same when we compare ourselves with other countries. Let us not forget all the other healthcare professionals like pharmacists, physiotherapists, occupational therapists that must also be trained. In terms of management development, this is key to our future. The training of this specialized group will determine the success of NHI and the delivery of quality health care to the people of this country. Thank you, Honourable Chair. I will now hand over to my colleague, Andre Joseph, to take us to the next section.
Thank you very much, Sharon, and good evening, Honourable Chair and Honourable members of the committee. Having considered the information shared by colleagues, we will now propose certain areas that both the public and private sectors can collaborate and partner on. Next slide, please, Amrita. So Life Healthcare is of the opinion that we can collaborate with the state in the following 4 areas. And we will now unpack these 4 areas, starting with number 1 in red, the human resource, education and training component. So to iterate what Sharon has explained to the committee, we definitely need more healthcare workers to address the delivery of the NHI. In addition to the supply of doctors and nurses, we should not overlook the training of other members of the multidisciplinary team, again, as Sharon has explained, and especially the hospital managers. We believe them to be a critical cog in the delivery of healthcare. It is thus essential that both sectors operate in an enabling environment to increase the training of healthcare workers to be able to deliver on the NHI. Please forward, Amrita. Life Healthcare has a proud tradition of training nurses at our 7 colleges across the 4 provinces for more than 25 years now. At the height of our training, as Adam alluded to, we delivered 1,500 nurses per year into the healthcare environment. This training was not only for our own requirements, but we also trained on behalf of government and for individual students wanting to join our colleges. Therefore, the entire nurse pool was increased. Unfortunately, in 2021, we were only able to train 237 nurses. We therefore propose that this college platform also be used to train doctors, both the specialists as well as the medical subspecialists. We want to bring to the attention of the committee that Life Healthcare has now, for many years, supported doctor training through the various colleges of medicine. We also provide direct financial support for the subspecialist training that is done at various medical schools. And in addition to this, Life Healthcare has been a proud supporter of the Public Health Enhancement Fund to the tune of 46 million. In terms of the skills transfer program, we want to suggest that an exchange program for staff between the public and private sectors will add value and enhance the career development of all categories of staff. There are lessons to be learned in both sectors, and we do believe that transferring staff between the sectors will just enhance their training. Next slide, please. So given the extent of our HR shortage, we suggest that an urgent intervention is required to address the policy impediments. And we will now in the next slide address these impediments. This slide details examples of impediments that we believe that if it's addressed quickly will lead to almost immediate gains in the health system. The first box on the left-hand side speaks to the limited accreditation of private nursing colleges. We have in the past demonstrated Life Healthcare's ability to generate significant numbers of nurses each year and can easily do this again if allowed to. The next three boxes highlight the obstacles to increasing the number of doctors in our system. For example, there's potentially a role for private providers to play with respect to doctor education, particularly given the clinical expertise that resides in the private sector. Given the success with which nurses have been trained in South Africa's private health sector, we believe there is merit in investigating whether the private sector should at least be allowed to play a role in supporting the training of doctors. To illustrate this point, doctors from sub-Saharan Africa are employed in the USA and in Europe, but find it difficult to be employed in South Africa. So the restrictions on the employment of foreign doctors in South Africa, we believe is a further impediment that, if removed, will increase the number of doctors available for our system. As mentioned in the findings of the HMI, the fact that the private sector cannot employ doctors has inhibited the evolution of innovative and integrated models of care. And this is something that we can address fairly quickly. Next slide, please. Thank you, Amrita. We've addressed the human resource education and training, and now we just want to spend some time on the next three components indicated in red. That's the hospital management services, supply chain management, as well as capacity. Next slide, please, Amrita. If you will allow me, I just want to spend some time on the supply chain management, but I want to mention that the provision of hospital management services and the utilization of spare capacity is our offer to the public sector in ways that we can partner, and we want this to be explored even further. We want to spend some time unpacking possible collaboration in terms of the provision of imaging and radiology services. Both Pete and Adam spoke extensively around the expertise that Life Healthcare has in this field. Life Healthcare, via the Alliance Medical Group, is the largest provider of radiology to the governments of the UK, Ireland, and Italy, as mentioned earlier. The Alliance Medical Group operates in public hospitals, and some innovative methods in rural areas allows this radiology services to be available there. The dynamic relationship that the Alliance Medical Group has with these governments increases access to scarce services, and in so doing, speeds up the diagnosis of conditions and therefore the subsequent treatment of these conditions. Next slide, please, Amrita. I don't think this presentation would be complete if we didn't spend some time to look at the lessons learned from COVID and the vaccine rollout. We believe that the pandemic was an emergency and both sectors treated it with the necessary urgency that it deserved. We suggest that the provision of a UHC also requires our collective urgent attention. Our response to the pandemic and the vaccine rollout demonstrated the ability of the sectors to collaborate effectively across these various areas that's listed on the slide. Honourable members, I implore you that we would like you to take away only two messages from all these lessons learned during the COVID pandemic. And the first one is, even where hospital beds were available, not having enough doctors and nurses rendered those beds inoperable. And point number two, where the collaboration between the public and the private sectors were effective, we increased access to services and thereby improved the clinical outcomes. We therefore are confident that through these actions, we saved lives. Honourable members, I would now like to hand over to our Group CEO, Peter Wharton, to conclude our presentation. Thank you.
Thank you, honourable members, and thank you to the Life Healthcare team for the contribution to this afternoon and now this evening's presentation. I'd like to just go back to what Andre mentioned and re-emphasize the lessons that we saw or have learned through COVID. One, it clearly demonstrated in stark terms the shortage of healthcare facilities and healthcare professionals. And for those that choose to argue that we do have enough nurses and do have enough doctors, we as Life Healthcare take a very firm stance that logic is flawed and unacceptable. The positive learning out of COVID was that working together between the public and private participants in the healthcare system, we improved delivery for the country, and no doubt that cooperation and partnership saved lives. It's in our assessment that when we come to our conclusions, that the constant conversation that the NHI is around funding and that the delivery of UHC and our support thereof is a matter of money is a flawed argument. I thought as a professional that left banking after 25 years and moved to healthcare, that the conversations about money would dissipate and we'd concentrate on health matters. And I'm disappointed when I hear constant references in implementation of NHI focusing on funding as opposed to what we see as the real issues. We acknowledge that this is the single most difficult undertaking by government. But we again emphasize that government is not on its own to bring the resolution and delivery of the NHI to fruition. We would like to be part of it, and government should see us as a partner. I re-emphasize the point that Adam made, that the concentration and operational risk with a single payer system is too high. I come from an industry that is expert in managing operational risk and high volume systems. And I cannot contemplate how we would make something this complex work. And I don't think I know a group of executives anywhere in the world, not just South Africa, but anywhere in the world, that would be able to design, implement, and sustain such a highly complex system on a day-to-day basis. So it is our view that the risk is simply too high for this country to bear. I re-emphasize that it is our proven view that there are insufficient number of healthcare workers, nurses and doctors in the present and in the future under current circumstances necessary for the successful delivery of NHI. It does beg the question why we as Life Healthcare are not allowed to train our full complement of nurses at 1,500. And I would re-emphasize and urge that we accelerate allowing us to do so, as we believe it helps solve the problem in the future. To meet the demands of the NHI, we need adequate infrastructure and facilities. And our milestones-based approach emphasizes that in the correct order of prioritization. It goes without saying that excellent administration is essential. So we wrap that up, Honourable Chair and Honourable Members, with a 6-point conclusion where it makes it clear from our perspective as to exactly where the emphasis should lie. We urge and employ Honourable Members to take the message away that an implementation plan based on the achievement of concrete milestones, acknowledging that we need enough nurses and doctors, that we need enough infrastructure and facilities, and that we need enough excellent administration is absolutely key to the success of the plan and for our country. And my closing comment is Life Healthcare sees itself as a partner in achieving this significant delivery for our country. Thank you, Honourable Chairman and Honourable Members.
Thank you very much, Mr. Waterwood, and to your team for your presentations. We appreciate you coming here today to do these presentations to the Portfolio Committee. We have a number of members who would want to raise some points with you, and I'm going to mention their names. It's Honorables Harvard, Wilson, Sukacha, Gela, Clark, Siwela, in that order. Is there any other member whom I have missed who wants to raise anything with the presenters? You might just shout your name on the platform now. If not, we will start in that order, and I'm going to repeat it. It's Harvard, Wilson, Sukacha, Gela, Clark, Siwela. Thank you very much. And if you could please, after that, just give us your responses to those questions. Thank you.
Honourable Chairman, I don't want to make like a disappearing act, but I will be moving into the room with my colleagues for the question and answer session. You will see me in a different location. I'm on my way.
You're very welcome. Thank you.
Thank you, Honorable Chair, and also thank you, presenters. We appreciate your input. I have two questions. First one, on NHI administration, you are concerned the single-payer system creates enormous concentration and operational risk. What is your basis for this concern? Is it based on empirical evidence on similar systems? If so, please share with your research with us. Second question, we understand your concern that NHI implementation is time-based, thereby runs the risk of premature implementation. Are you aware on Section 57(1)(b) of the bill, which states that national health insurance will be gradually phased in using progressive and programmatic approach based on financial resource availability? I thank you.
Thank you, and thank you very much for your presentation. Lots of food for thought in it. I principally want to deal with the what we would call a maldistribution of health professionals. And other people who presented seem to think that this actually will be exacerbated by NHI and not improved on it. Now, it's little wonder that many health professionals, particularly highly qualified doctors, etc., are loath to work in the public health system, principally because the hospitals are under-resourced. They don't have sufficient equipment. In some theatres, we've had theatres in Mpumalanga closed down because there's no air conditioners working. And all of these kind of things create problems for health professionals, specialists and surgeons in particular, who are in a country where we are already sitting with billions of rands worth of medico-legal claims based on malpractice and hospital problems. It's little wonder that we have a maldistribution of health professionals. And I want to deal specifically with nurses because you are categorical in your statement that there are more than enough nurses. I find this fascinating from our perspective because we are so often having to fight to get graduated nurses' positions. So the question is, you're saying there's insufficient. We are finding very often the opposite. And please, my picture may be skewed. I'm not in any way saying that you are incorrect. So one of the earlier presenters said there was 3 pillars that will hold up the NHI, what actually hold up the health system. The first of those being that it must be affordable and sustainable. The second one, that health facilities must be accessible, health access to proper health must be accessible. And thirdly, obviously, the quality of health is critical. And those are the essential foundations, I think, for any any health system. And yet we do not have that in place in the certainly in the public health sector. There is essentially the quality of healthcare in very many provinces, particularly those that are particularly rural, are abysmal. Very few people in the rural areas have reasonable access to proper health facilities. And quite frankly, with the cut of budgets, and particularly in human resourcing and in infrastructure, there most definitely is an indication that our current system is not affordable or sustainable at the moment. And I'm pleased to note that you are prepared to partner and that indeed you are prepared to assist, because I think this is going to be critical. And hospital managers were raised, and we have submitted lots of questions about lots of hospitals where hospital managers and senior personnel have actually been employed with not even 5 years experience in the medical industry, let alone having any administrative or financial background. So this is a concern. So my question is, with all of these things taken into account, and even with a partnership with organizations such as yourselves, should we not be rather targeting the foundation and the 3 pillars of sustainability, affordability, accessibility, and quality, and getting that right before the NHI should even be considered? I thank you.
Thank you very much, Chairperson. Let me also welcome the presentation. Chair, I've got just one comment and 2 questions that I would like to ask from the team. During the presentation, Chair, the team has made an interesting recommendation that the NHI milestones needs to be aligned to the Presidential Health Compact Pillars and the WHO Health Systems Framework. Your submission is noted, I must indicate. We should also like to encourage you to also communicate this to the Presidential Health Compact Committee through your stakeholder group. That is my first comment. My question now is on slide 13. You recommended that appropriate reimbursement models be considered for the NHI. Can you please specify which models would you consider to be appropriate vis-a-vis those that are not appropriate? I'm asking this question based on the findings by the Health Market Equity Panel on current provider payment mechanisms, specifically issues related to supply, induced demand, and increase in utilization and expenditure of private health services not justified by changes in demographics, risk profile of the beneficiary of medical schemes. In your response, can you please also consider the proposed reimbursement mechanisms and the process of determining these rates by the level of care within the white paper and the NHIP? Then my last question, has Life Healthcare any thoughts on task shifting and task sharing to moderate the HRH challenges? Thank you very much, Chairperson.
Thank you very much, Chairperson. Let me first welcome the presentation. I've got 2 questions that I want to ask My first question, your presentation proposes a single fund and a multi-payer system for NHI. Can the presenter please expand on this point with a special focus on the benefits of this proposed funding model and how it will impact on reducing financial intermediaries that have been shown to increase non-healthcare cost? My second question, it is your assertion that NHI must not be implemented prior to the achievements of the milestones that you have outlined in your presentation. In your view, how long do you think the health system strengthening initiatives that you have outlined could take to achieve? And is NHI not meant to improve resourcing and funding of the health system to ensure that these milestones are reached? Please comment. Thank you, Chairperson.
Thank you, Chairperson. I also just have two questions to ask. One, shortages of healthcare workers are a major concern. Your presentation highlighted the impediments to addressing human resource challenges. What recommendations or changes to the NHI or to the above-mentioned policies can you make to ensure that the bill meet the human resources requirements? And then secondly, what implications will a shortage of healthcare workers have on the adequate service delivery within the sector? Thank you.
Thank you, Chairperson. The opportunity. The first question is that you worked with NH implemented immediately after the devastating World War II, where the infrastructure was decimated by the war. Can you share with the committee how the NHS did this, and also share with us what is currently being ensured health equity in South Africa? The second question is, in these 9 milestones that you have identified, what time frame would you suggest for each milestone? Can they be run in parallel? Do you think that by employing this method, we will ever implement a single health system for the country? And lastly, is Life Healthcare asserting that because of the perceived risk that you state is so high, the status quo must be retained until the HR, infrastructure, and management challenges that you have outlined have been resolved? Thank you, Chair.
Thank you, honorable members. I do not think there are any other members that want to ask any questions. So I'm just going to mention what I want to speak about. I want to speak about 4 areas. The one is your points you raised on SLAs, on tariffs, certificate of need, and on service providers. Now, your recommendation on the first one, that SLAs are best set at national level and operationalized at provincial level is noted. Are you aware that some of your competition in your market do not have a national footprint? And what do you suggest these providers ought to do, or should they be excluded from these SLAs? And also whether you would consider HMI recommendations on the barriers of entry into the facility market and what your view would be on that. On my point on the tariffs, your recommendations on key parameters to be considered when tariffs are determined is noted. Are you aware of Section 26, which talks about the pricing committee and the different stakeholders who will form part of the committee? Do you perhaps need further clarity on this section? And then the point that I want to raise on certificate of need, whether you'd be able to share with the committee your views about the HMI recommendation on the certificate of need. And this questions in specific I am posing because this is one of the things that need to be addressed in the private hospital market. The concentration of private facilities within metropolitan areas which does not follow the healthcare need, particularly from the rural provinces, is a point in question. And then I have one more question I want to raise with you, and that's the one on the service providers, that if you could please help me understand from your presentation whether you're insinuating that the NHI, under the NHI, only the state service providers will be contracted, and what actually informs this view, and where possibly in the bill that you find this view. Thank you very much. I think those are all of the questions from the committee members. You're very welcome, you and your entire team, Mr. Wharton-Hood, to respond to these, and we're looking forward to those responses. Thank you.
Thank you, Honourable Chair, and to the Honourable members for listening to our presentation and asking such valuable questions. As there are some themes here, and I would ask the subject matter experts around the table to be able to address them. Regrettably, I missed the first Honourable member's two questions while I was in transit between my presentation room and where I am now. Adam, is there anything that arose in the first two questions that you would like to cover before I coordinate the rest?
Yes, it was about the two questions on the single fund, single payer,
right,
and why the operational risk is the basis for our view on the operational risk.
Sure.
And then are we aware of Section 57(1)(b), which talks about a programmatic approach to implementing NHI rather than a milestone? So we can talk about that under the milestone.
Let's do that under milestones, and perhaps I will address the notion of the operational risk and why we have such a firm stance on it. A system that undertakes to be a national provider across such a complex landscape requires the creation of a technology process that cannot fail. In addition to which, the resource and support required to process this volume of transactions on a daily basis and at such small levels and values is not necessarily risk-worthy and is probably going to be insurmountably expensive to make available 24/7. I've had comparisons drawn in my office between the national payment system and the single payer system that's been advocated, and I would argue that they are incomparable. Yes, the national payment system transmits billions, if not trillions of rands worth of transactions, but they're done in very, very high value, and the nature of the transactions are generic, and their validation processes are relatively simple by comparison. In the context of what is being contemplated in the single payer system, both the volume, the complexity, and the variability, in addition to which the auditability and verification requirements per transaction, I cannot fathom how that system could be designed, and I shudder at the difficulty in managing such a complex system. In addition to which, if it were to fail, the whole healthcare system would grind to a halt. Whilst the provision of service, it doesn't impact on the ability of doctors and nurses to actually do their jobs. The cash flows that flow from it could bring the ultimate value transmission that supports the delivery of healthcare to a standstill. And in so doing, I feel that it would be appropriate that the country consider
and adopt a multi-payer system so that if there were any difficulties encountered, such a disruption would not bring the provision of care to a standstill or be compromised. Having said that, a multi-payer system also allows us to insist that the providers of such services compete for business and that the volume of work afforded or awarded to individual participants is on a competitive bid basis with a view to driving the costs of administration down to the most efficient and representative cost per transaction. In a single payer system, such an opportunity does not exist because there is no alternative provider and there's no competitive mechanism by which to actually force efficiencies into the underlying administration. So whilst multi-payer single fund doesn't seem to provide or, shall we say, get the recognition and support it deserves, it comes with economic outcomes and competitive outcomes that will drive for a far more efficient system. And so it's a combination of risk, and it's also an opportunity to improve the financial outcomes underpinning it. And I see one of the honourable members mentioned the context of innovation. If one thinks about a multi-payer system, these respective providers will have to compete for work. They will be obliged to be able to bring their prices down, otherwise they won't receive work. So I'm a strong advocate for multi-payer single fund. I'm a strong advocate, we are a strong advocate for delivering that back to the country, and I trust that my answers find favour with honourable members and will be absorbed. In the context of moving on to the other issues that have been raised, Adam, do you want to deal with the milestone-based approach and answer those questions in composite?
Certainly, Pete. And Andre, you can come in if I miss certain points. So the first question is, we do understand that the bill talks about a programmatic approach to implementing NHI, and we understand that. What we'd like that to be is a little bit more explicit in terms of what it has to deal with. And certainly that the Presidential Compact and the World Health Organizations, they're fairly clear in terms of what those building blocks that need to be in place. And what we would hope that in terms of going forward, that we are fairly clear in terms of what those building blocks are and what we need to achieve per building block. What we're not saying is that NHI is something you just turn on and off. We know there's a journey we're going to go down here. And we're certainly not saying we stop everything until we get this in place, because we know it's we're going through a journey. What we're certainly not saying is you have to do building block 1, then you move on to building block 2, etc. There are a whole range of initiatives which we should be starting all of them now with different work streams. You know, with resources, with doctors, you know, if you want to train specialists, it takes you at least 10 years. And every year that goes past, if we don't increase the number of specialists, it just delays the issue by another year. You know, there has to be a real focus primarily in terms of how we increase the level of healthcare workers in this country. But that doesn't mean we wait until we get the perfect number of healthcare workers in the country before we implement NHI. It is a journey. But what we are saying is that if you don't have sufficient healthcare workers, you don't have sufficient hospital management and competent management, you don't have sufficient accredited facilities and sufficient access, then we're not going to achieve the objectives of NHI. And for us, this is not about ticking a box and saying we now have a national health insurance system. This is all about improving the access and quality of healthcare for all South Africans. I think that covers it. If I missed anything out.
No, I'm happy. Sharon, would you mind just clarifying our position on the number of nurses in the country? I think there was a slight misunderstanding as to how we wanted to, what the problem statement was, our position, and how we would close that gap down.
Thank you very much, Pete. I think we just want to confirm that in our presentation, we did speak about the shortage of nurses rather than us having a sufficient number. And we did confirm the maldistribution of health professionals, between the public and the private sector. Currently we have registered in South Africa about 285,000 nurses. And, we don't know, whether all of them are actually employed in the country, because we depend on the database system run by the regulator that is not able to specify exactly whether these people are employed or not. And so that makes it very difficult. But in the study that I cited, I also said that 85% of nurses currently are employed in the public sector and 15% in the private sector. And so, we've got statistics to kind of support some of the numbers and how the distribution works. But while we say that, we know we have a shortage, and we don't have adequate healthcare workers in this country. And, one of the points was, well, will this have implications for the service delivery? Well, I want to say that I think it's already having implications for service delivery, and that was proven during the pandemic. And we saw the sudden rush to offer contracts, to bring people on board, and to really start to share our resources. So I think that is a point that we want to confirm. Around the concept of task shifting and task sharing, it's something that we continually explore, bringing in other cadres of workers. We were one of the first groups to start exploring the use of healthcare technicians. And we know, once again, a lot of the implementation around some of these concepts and introducing new levels of workers is not encouraged because we don't have enabling regulation. And so we are really firm believers that if we have enabling regulation around the training of healthcare workers and introducing new cadres of healthcare workers to support the healthcare system, we will definitely make much more progress. Thank you, Pete.
Sharon, thank you so much. While I ask the team to contemplate their response to the alternative reimbursement mechanisms, please, I'd just like to make a comment on the honourable member's question around the maldistribution of healthcare professionals in the system as it presents itself currently, and perhaps a comment on where doctors choose to work. The honourable members are well aware that doctors that choose to work in Life Healthcare facilities are not employed by Life Healthcare, and they choose to practice in our facilities by choice, as opposed to us having any other lever to bring them there. They practice in our facilities because we provide excellent infrastructure, nursing support, facilities and theatres, together combined with rehabilitation and a continuum of care that allows them to discharge their responsibilities to deliver quality care in an environment in which they feel safe. I've stated the obvious, but I wanted to draw the conclusion that the ultimate management of these facilities is what creates it in a sustainable fashion. I have an observation, only having 18 months experience in the healthcare industry, that a hospital manager's job is one of the most complex jobs that I have seen. It brings together a multitude of disciplines under in a very pressurized environment, dealing with very well-educated professionals, solving problems from scheduling all the way through to electricity, power challenges, and hygiene issues, and staff shortages, and so on. So I would advocate that in uplifting up all our facilities, it's not about just spending money on the infrastructure. It's making sure that we actually have in place capable managers who are able to look after these very important assets. And that the combination of infrastructure improvement together with the necessary executive oversight and management of these facilities go hand in hand. Great facilities with no management will be a waste of money and they will fail. And great management with inadequate infrastructure will not allow us to be able to deliver the quality of the care that we are promising to our country. On alternative, may we then move on to alternative reimbursement models? Thank you, Ridwan.
Thanks, Pete. Thanks, all members. I think just to clarify our point around appropriate reimbursement models, we are completely aligned with the recommendations that came out of the NHI bill, as well as the findings on the HMI. So I think we acknowledge the fragmentation in the private sector. We know that it's predominantly driven by fee-for-service with scant primary care, and that really drives utilization in the environment. And I think the principles we aligned with is one that all reimbursement models must be aligned to population or episodic outputs that align clinical multidisciplinary teams and really pay on a risk-adjusted basis for outcomes. And I think for us, those principles are sound, and we support those, and we think that those are the basis for effectively contracting the private sector to deliver through the NHI.
Thank you very much, everyone. Another point to make a comment on is one of the honourable members asked about improving the affordability of healthcare services in South Africa and our view around how we could help improve affordability. And it's our considered opinion that affordability will improve if we eliminate waste, not through the reduction in the quality of care. So our hypothesis and how we feel we are able to participate is by maintaining the quality of care that Life Healthcare stands behind and is proud to deliver, but improving affordability must come from the elimination of waste that is within the system, and it's our job to make sure that we continue to eliminate it. In the context of the milestones approach and how long we think it would then take to implement, the honourable members asked a very, very difficult question. In the context of understanding how long those milestones will take to execute is obviously a determinant of the overall time it will take to deliver the project. We just feel that by focusing on milestones, there will be a logical and coordinated approach, focusing on the most important issues first, so that we can build the outcome. Like building a hospital or building a classroom, you have to get the foundations right. We can't start with the roof. But the honourable member did ask, could we do some of these things in parallel? And the answer to that is a definite yes. So in the context of the project management, if we focus on milestones, we'll be focusing on the resources and the effort required to make sure that we put the deliverables in place. A focus on a time-based outcome may produce unrealistic pressure, and once the time-based outcomes are put in place and they are exceeded, it's very difficult to then actually draw accountability back as to where it failed. So we feel a milestones-based approach is far more in line with the way that we manage very large projects inside our own company, and it's a methodology that with which we feel comfortable. Honourable Chair, in the context of recounting the history of the successful delivery in the United Kingdom and the NHS's efforts post-World War II, I feel inadequately qualified to be able to give a detailed account of the step-by-step process that put them in such a formidable position today. I would ask some leniency that we perhaps answer that question in writing, unless any one of my team has a better recollection of the history and all the steps than I do.
You're not that old.
I don't know, you're younger than you look.
We don't know, Fred.
But thank you. We will come back in and answer that question to the honourable members in writing. Adam, I've pushed off. Yes, please, if I left.
What has just happened to you? Can you hear me? Mr. Wharton Hood, can you hear me? Honourable members, can you hear me?
Yes, we can hear you, Chair.
Yes, Chair, we can hear you.
Thank you.
Sorry, Honourable Chairperson, we seem to have some technical difficulties with our boardroom connection. We will, however, continue with responding to your questions using this platform.
Thank you, Honourable Chair. Apologies, we've lost visuals unless you feel that. Adam, do you want to come in? Yes, Chair?
So, Honourable Chair, there was just, you asked some questions. And the one was about, certainly we see the contracting taking place with both the public and private perspective. No way do we see that private be excluded. The question you did have about the HMI and the concentration of assets in cities and not in sort of more the rural areas, and that is correct. I mean, the assets, hospital assets in particular, are concentrated in the cities. Just from a life healthcare perspective, we've got hospitals in some smaller towns, in Friedenberg on the Western Coast, and Queenstown and the Eastern Cape, Mpangeni and KZN. My KZN colleagues might look at me a little differently. They think Mpangeni is a small town. And I do want to say that managing these facilities in the smaller towns is really difficult. It's difficult to get doctors. It's difficult to get nursing staff. It's difficult to get competent management. And, like during COVID, one of these small towns, one of the hospitals, they lost their entire management team. They all got COVID at the same time. And the question is, how do you manage a facility when your management aren't in the hospital? And so the hospitals in the smaller towns do come with challenges. Not to say we would want to be there, but it is a lot more difficult to operate. And just an example, we had a hospital in a small town in KZN, and we could never get that hospital to work. It was always unsustainable in terms of enough doctors to work there, enough patients, etc. So that it does come with challenges. There was a question regarding the SLAs in our view that it should happen at a national level in terms of contract, but operation at a local level. And you raised a question about, so what does it mean if you don't have a national presence? Our view is that it shouldn't really impact. You can have a general contract at a national level, which plays out across the provinces. And the provinces then contract with the facilities that are in those provinces on the terms negotiated at a national level. Are you agreement with that?
That's good.
Yes. Did I miss anything out from the chair? What was the last question regarding certificate deed? Yes, our
views on that. Because the fact that we've got massive concentration concerns and supply issues.
Well, I think in terms of certificate of need, there's I suppose it tries to deal with the redistribution of resources across the country to areas of need. It's quite a difficult process to go through. We think there are a number of challenges to certificate of need. We do believe that you want to increase the resources around the country if you want to improve access. But our view is it comes back to our proposition is that if you don't have sufficient nurses and doctors, you really, the certificate of need won't fix the issue. We need to train more nurses, we need to train more doctors, we need to ensure that they are encouraged and incentivized to get into areas where there's no access to improve that access. That is our view. We keep going on about the healthcare resources, but fundamentally, we could be sitting here in 10 years' time. And if we haven't trained more nurses, we haven't trained more doctors, we certainly won't be improving the level of access or level of quality of healthcare for all South Africans, irrespective whether the NHI fund is up and running, or their reimbursement models up and running, etc. We don't have the resources, we're not going to improve access.
But Adam, I think that goes to the fundamental point that improving accessibility and affordability of healthcare for South Africans, more South Africans are going to make use of the facilities that the country provides, which means the amount of work goes up, which means that we need more nurses and doctors to be able to meet that demand. And in so doing, just reslicing the existing pie is not going to solve the problem. We have to create more nurses, more doctors.
Yes, thank you. And just from our side is that there is a real firm commitment from Life Healthcare to assist in the training of healthcare professionals, more trained nurses. And we talk about nurses and doctors, but actually we should include other healthcare workers, pharmacists, physios, etc. And we are committed to working with government to increase the numbers we have in this country. The Honourable Chair, is that have we sufficiently addressed the questions that were asked? And if we haven't, we can, we will certainly, regarding the NHS in 1948 and Minister Bevan, who introduced the NHS, we will certainly go back and have a look, and then we can respond in that regard.
Thank you very much, all of you, for your responses. I'm going to just say that echo continues, so it seems to be a way. There is one follow-up question from Honourable Chiliti Munyai. He wants to raise something, so I'm going to allow him, and if you may please respond to whatever he raises with you. Honourable Munyai.
Honourable Chair, I won't be long. It seems, is it Life Healthcare asserting that because of the perceived risk, your state, it is so high, the status quo of two-tier system must remain? and be retained until the HR infrastructure, management challenges, and also training of the staff, hospital staff that you have outlined have been resolved. And the other one, Honorable Chair, I don't think we're at one. Do you understand that the reimbursement under NHI is not going to be based on individual transmission at the PHC, since it is based on the prospective capitation, and at the hospital level, it will be based on the DRGs. Lastly, I just want them really to help me, Honorable Chair. I've been asking this question over and over. Honorable Chair, look, I want to ask the simple question. When I was involved in a car accident with my brother, right? And the ambulance came and wanted to pick me up, who was less injured. And my brother was critically injured. Do they want to really, I'm saying, to me, I saw that as a discrimination based on socio-economic status. Do they still want the status quo to remain? Despite that 8% of the GDP, accounting to over 400 billion, serve the 16% of the population, and the rest are not in that degree. Do they still want the status quo, that nothing should happen, to rearrange or to change policy reform? Thank you, Honorable Chair, for the opportunity.
I think we should perhaps start with the last question first. Honourable Chair, may I just clarify with the Honourable Member, at this particular juncture in our country, the total healthcare spend is 500 billion, of which 250 billion is in the private sector and 250 billion is in the public sector. 400 billion does not go to the private sector. In the context of socioeconomic status, Life Healthcare will accept any patient into its facilities, irrespective of its socioeconomic status. We proved that and continue to support that, as evidenced in everything we did during the course of COVID and any emergency cases that are presented in our ER facilities around the country. In the context of how we move forward to participate in providing care to the nation of South Africa, it's important for us to see our role as healthcare providers and help to improve the accessibility and affordability of healthcare services. As professionals, we are here to make a contribution together with government to take healthcare services to more people in South Africa. And we look forward to playing that role. Adam, do you want to add too?
Yes, just we do understand the reimbursement models that are proposed within the bill, and certainly we don't agree with a fee-for-service model. In fact, most of our reimbursement does not take place on a fee-for-service model currently. And we heard Discovery talking yesterday about moving to value-based care, and we're one of the organizations they're talking to in that regard. So we do have a clear understanding of that. We also understand the bill talks about DRGs, and I'd just like to state that, as a country, we don't have a national DRG grouper. We are reliant on an underlying procedure coding system and a diagnosis ICD system, which are not ours. And so there is a really long way to go if we want to have a national DRG-based reimbursement model for all hospitals in the country. This is not simple. So we do understand that, and we're very willing to participate in the development of those reimbursement models. Just a question about risk. Our point is not that we just sit with the current system and do nothing until everything's in place. What we are saying, though, that there is a journey we have to embark on, and that's the first thing, and we do have to make changes. But the second thing is, our point is that we will not achieve the objectives of NHI. We will not improve access to the quality of healthcare unless those building blocks are in place. So it's a journey we're going on. We're not saying we do nothing until everything's in place. But we have to be smart and understand that as we build these blocks, it'll take us some time, and we got to change the system in the process. But ultimately, it's all about, are we going to achieve the objectives of NHI? And for that to happen, these building blocks do have to be in place. Thank you.
Thank you very much to all of you for coming today. And I'm talking to Life Healthcare at the moment, for your presentations, for your responses, for the open and frank discussions which we could have had. Also to the honorable members that we could have had these discussions. We have really appreciated this opportunity. Ms. Majalamba, I just need to make certain before I let you go. Ms. Majalamba, I just need to make certain about our starting time tomorrow morning.
Good afternoon. We don't have hearings tomorrow morning. We only have hearings on Friday.
I mean on Friday, yes, on the 28th.
We're starting at 10:15.
10:15. Thank you very much. So once again, maybe you want to give a final closing remark, Mr. Wharton Wood. You're very welcome. Just before I close this meeting.
Thank you, Honourable Chair, and thank you to the honourable members for the constructive engagement. We welcome this opportunity, and we're thankful for this opportunity to express the research views of the company. And to re-emphasize, we do see ourselves as supporting the initiative. We'd like to be able to help and participate, and we'd like to be able to replicate a partnership model along the lines of which we've proven internationally, and to be seen as a responsible and reliable partner with government in this very important initiative for our country. Thank you to all the honourable members for their time, and to my team for the work that went into delivering this to you today.
Thank you very much. That brings us to a close, honourable members. I am going to adjourn this meeting. Thank you.
Thank you. Bye-bye.
The recording has stopped.